Hello, hello, hello. Good morning, everyone. We are all set to start. Maybe we can be seated. So, unfortunately, as you know, that the Microsoft glitches have severely impacted the conduct of our conference, and we have to reschedule some of our sessions according to that, and we may be missing some of the star talks that we had. To begin with, Dr. Dean Elterman, who was supposed to join us from Canada today morning itself, but his flight got delayed. He was traveling from Europe, and he's at the moment in transit in a aircraft, so he will not be able to join us as of now. So what we have done is we have merged the first two sessions, and we will be having four talks in this session in continuity. To conduct the session, may I call upon the chairpersons, Dr. Santosh Kumar, uh, Dr. Siddharth Jain, Dr. Ashok Sharma, and Dr. Praveen Pandey. So we'll begin with the talk on prostate artery embolization. Dr. Ashish Seni is also not able to make it. His flight was cancelled, so he's also not there.
A very good morning to all of you. We begin this session, and at the outset, I'd like to thank the team of organization of BBH 60 and Dr. Rishi Nair, Dr. Sapan Sood. We had a wonderful operative session yesterday. And as an opening batsman, I'm going to bat for prostate artery embolization, and I'll be talking about where we stand right now on this. And before I do it, uh, uh, how's the slide going to move? Okay, so before I begin, I have a few disclosure. I'm a man of science. I prefer thulium laser enucleation and bipolar TURP over anything for my patients whenever a surgical intervention is required. And of course, a few procedure slides is courtesy Dr. Ujjwal Gorsi from Intervention Radiology. So I thank him at the outset. Beside completing the gamut of modalities available for treating BPH patients, why discussion is going on is because recently after 2021, AUA guidelines changed from not accepting prostate artery embolization as a method to going from prostate embolization as the new alternative for BPH. So we have been discussing concept of minimally invasive surgical therapy. Yesterday we have seen RISM, we have seen Urolift, and this is another kind of minimal invasive surgical therapy. But the difference is the approach is endovascular, the mechanism remains embolic, and selective embolization of prostate artery with microparticles results in gradual decrease in prostatic volume, leading to decrease in lower unit tract symptoms. The connotation and consideration becomes different because you need to work up the patient. You look at whether the patient is having atherosclerosis beyond the prostate size and everything. The literature says the median lobe morphology, and there is no upper limit cutoff for the gland size for prostate artery embolization. And current referral at our center is primarily remain restricted to non-surgical candidates. I've been introduced to a cardiologist in the field, and in Jalandhar he's already done 120 cases of late, and we would like to have a word from him later on. When we look at the literature till 2019, it was clearly stated that TURP is far superior to prostate artery embolization with poorer outcomes, but of course safer outcomes. In 2021, the meta-analysis came and the grading changed that to equivalent outcomes to lower adverse effects. Of course, this can be attributed to the amount taken or the time taken to master this procedure per se. In a nutshell, the literature supports regarding efficacy says that prostate artery embolization provides a significant reduction in lower unit tract symptoms in short to medium terms with poorer functional outcomes with a maximum flow rate improvement of about 5 to 7 ml per second. However, it tops up the pharmacotherapy far superior in terms of improvement in IPSS and SHIM scores. People have gone to the extent of doing MRI after that, and they have found about 30% reductions in the decrease in central gland volume. However, when you look at the recurrence and the complication rate, the literature says about 20 to 30% patients are going to recur at the end of 5 years. And there might be non-target embolizations to the superior vesical artery, to the internal pudendal artery, or the middle rectal artery, which can give rise to non-target embolization syndromes. So far, the limitation of prostate artery embolization is basically a slower, gradual relief in symptoms, and the contraindication remains lower unit tract symptoms secondary to etiology other than BPH. However, at our center, we are also doing for intractable hematuria due to CA prostate patients. We have done in few cases. Treatment of small prostate, patients with atherosclerosis, renal dysfunction, and severe contrast allergy are a contraindication. So beside understanding the anatomy of the prostate, which we urologists understand, if you are going to do a prostate artery embolization, it is imperative that you understand the identification of the prostate artery, which is the most challenging part. So detailed understanding of the prostate artery anatomy in terms of the branches of the internal iliac and the Foley's catheter is what act as a guide. So if you look at the branches, the superior vesicle going to the bladder, the inferior vesicle continuing as the prostatic arteries, which needs to be identified, and lower down you have middle rectal and internal pudendal. The Foley's balloon is being used as a guide by the intervention radiologist because you need to understand the procedure before you start prescribing it for your patient or saying it against the procedure. So for a good orientation, at times the radiologists are using the contrast filled balloon to identify and understanding the arterial anatomy per se. And the procedure remains you cannulate the femoral artery, go into the internal iliac vessels, go as distal as possible, insert a micro angiocatheter, cannulated coaxially, and go right into the prostatic artery where you can see the delineate the hemiprostate is what is needed. And there you inject the 300 to 500 micron or 100 to 300 micron microspheres and along with the iodinated contrast medium so as to knock off the prostate artery. At our center, we are doing a CT angio before, or the radiologists are doing a CT angio before to look at the vascularity of the prostate. If the prostate is vascular per se, it is going to respond, and that is what a dictum has been over a period of time. So just to understand the procedure briefly, you can see the angiocatheter is going inside, and this is the Foley's balloon there right here, and the artery going just beneath that, and you can find in the third image the prostate hemiprostate has been delineated, and that is the artery which needs to be knocked out. You can see the hemiprostate being delineated in the first image very clearly. Just beneath the Foley's balloon you can see the prostate artery, and the angiocatheter is advanced into the right into the inferior vesicle and into the prostate artery, and this is the last image showing that the distal runoff is not anymore seen. Another image just to delineate the anatomy, you can see the superior vesical artery just coursing above the balloon, while the prostatic artery and the inferior vesical artery continuing as the prostatic artery going right beneath the balloon of the prostate. Post-procedure management remains standard. You immobilize the patient like any other angio procedures for 4 to 6 hours. The Foleys can be removed at the end of 6 hours. If it's a chronic use of indwelling catheter, it can be considered up to removal after 1 week. Adverse event, as already mentioned, apart from the non-target embolization syndrome, patient may have inflammatory process later on, which can lead to dysuria, urinary tract infection, symptoms like urinary tract symptoms, contrast allergy. These are the extra complications which you are going to have beyond your other minimal invasive surgery therapy. The technical success is primarily defined on table when you are able to cannulate and knock off bilateral prostate arteries. While the clinical improvement, of course, you are going to assess with the IPSS, quality of life scores. This is primarily from literature, what they are being using to compare against pharmacotherapy as well as against other therapy. So in a nutshell, if you compare prostate artery embolization vis-a-vis a TURP or prostatectomy, the clinical failure rates do not differ significantly as of now. The length of hospital stay is lower. However, this all comes that you are accepting a poorer outcomes in terms of peak urinary flow, post-void residual volume, prostate volume, and effectiveness according to the urodynamic studies. So where do we stand? We come back to the question where we started. It's kind of prostate artery embolization is a bridging gap between the medical therapy and TURP as of now. But you have seen yesterday what RISM can do, what Urolift can do. And of course, the referral to a IR person or a urologist taking upon this procedure, or we have cardiologists also sitting back that everybody is fighting for this procedure. So another consideration is who is going to do the procedure, who is going to the suite, and who is going to refer to the patient to whom. For time being, the verdict is that prostate artery embolization is not a placebo procedure. And with minimally invasive surgery therapy, with 5-minute procedures coming into picture, where prostate artery embolization going to stand is to be seen. Thank you so much for your patient hearing. And I welcome you all to PGI AndroCon, which is going to be held in August 10th, 11th at our center. Thank you so much.
Dr. Aditya, nobody going to throw these sandwiches to the interventional radiologist. The second thing is coming up the newer procedure, like the Urolip, Excel loaded value validation. Very high risk cases. Nobody will offer angioembolization for the BPH. And this angioembolization procedure for BPH may go into lost in the history. What is your view?
Yeah, sir, that's a possibility. I agree to it. That's why my last slide was like minimally invasive surgery therapy, which has come up, might mask the prostate artery embolization, which has just started to rise from 2021 onwards, and the AUA guidelines have changed. But we have centers where the cardiologists have done over 120 cases and he is present internationally. I think I would like to hear his verdict, how he has built up, because at our particular center, the total number of cases so far done are 16. I inquired with my IR person. So there is a referral bias. Of course, they are also overworked. We are also overworked, and nobody wants to let go of the TURP surgeries or a BPS surgery, which we are doing. So that is there. But efficacy wise, if you compare with TURP, it has lower efficacy but better safety. So probably in patients who are not fit for surgeries, this is one of the options for us at this point of time.
Another thing, what is the cost of hear from cardiologist?
Good morning to all of you. Dr. Aditya has very well presented concept of PA. There are a couple of things which I will just add to. With regard to your first comment, it will be history. We'll see after 20 years, it won't be history. This is my concept. I tell you why it is so. Every patient is not fit for any minimum procedure intervention. We are talking about a patient who are not fit for surgery, suppose patient post angioplasty, goes on oral anticoagulation, antiplatelet. Whatever minimal surgery you do, patient has to bleed. We cannot stop antiplatelet, anticoagulation patient who has bad replacement. It means techniques are complementary. We're not going to fight with anybody else. We are going to have complementary treatment patient who is unfit for standard procedures, who have high risk for standard procedures, and where some drug interaction cannot be taken care. Number one. Number two, things have changed drastically. When I started PAE, I'm talking about 2020, 2019, something like that. See, at that time, we used to do uterine catheter. Now, we don't need uterine catheter at all. Patient is not at all catheterized. We don't need CT angio at all. We are so well versed with anatomy now, we don't need catheterization. So biggest advantage is patient doesn't need catheterization. 85% of procedure what we are doing is only pure radial. We don't do femoral. Patient even need not lie down on the bed for 6 hours. He walks out immediately. And believe me, this is actual data. Things have changed. See, we are not saying PURP is not good. What we're trying to say is there are new techniques which can take care of group of patients where standard treatment cannot be done. Obviously, when you have a new technique, very difficult to digest the thing. Everybody oppose that. Then start analyzing, then finally accept it. See the guidelines, similar to the happening. So concept is this is minimally invasive. Patient need not stay. You need not even catheterize. No possible infection at all. No return ejaculation. No retention. No incontinence. What are you looking for? This is what result we are looking for. So in a selected group of patient, this technique is going to stay. Number one. But two, second group of patient who require PA is post-TURP. So patient bleeds. What option you have? You have no option except to do PAE. How the technique started? It started with the same concept. Patient had persistent hematuria and PAE was done. At that time, it was found that prostate size decreased and patient symptom improved. Now coming to symptom improvement. So I do agree. The size come down in 30% population. Size is not the suitable criteria at all. We don't do PAE for size. We do PAE or any procedure for the symptoms. Symptom relief is 85%. You see any nutrition data.
Yeah, but the overall symptom score improvement is poorer. So that's what the literature says as of now. And the second question for sir was the cost of the procedure. I think that you did answer, yes.
Symptomatic improvement is 85%, even if size doesn't come down, because symptoms are majority because of increased vascularity also. Now coming to the cost of the procedure, it depends on industry, it depends on the place it's being done. Average cost, what we are charging, it may not be good for others, charging 50,000 rupees as a package. 50,000 is not a big amount, it's a small amount.
Perfectly taken, sir, your sentiments, I agree. But we now have other minimally invasive surgical therapies which are coming, but you have to be lookout for that. That's what I think we are running short of time. We'll take up the next speaker.
Just one question, if I may. See, I believe this procedure is not yet used in patients who are in detention.
Sir, we have been doing it. We have been doing in procedure patients with who are in retention also. Yeah.
What is the rate of patients continuing to have the conflict of interest? They're not being relieved with this.
So that is a good number, sir. Initially, because it takes a it's a protected course. It doesn't not like happens overnight. So over a period of months, it's going to decrease in size, and that's the period you want to bridge it with the alpha blocker therapy as well. So that's how it goes. Sure, sir. Sure, definitely.
Patient who is not in retention after angiomyelin, this is common phenomenon. Tissue death followed by inflammation, necrosis, inflammation. So how many patients have gone into retention after angiomyelin?
Sir, the literature percentage of the record, I am not sure, but in one of the studies was about 15% or so. So that was about it. Thank you, sir.
I think I know a lot of views given by our cardiology friend. But at the moment, I think PA is mainly done by cardiologists and interventional radiologists. We urologists have not gone into this area, except maybe in PJ, the interventional radiologists are good. But the coming annual conference of the interventional radiologists, there is a session fully dedicated to PAE. And I'm told by the Secretary of the Cardiology Society that they are also having a special session dedicated to PA. I think this concept we should be very sensitive. It's a challenge to Urology Society of India. Many, I think at the moment we don't train our postgraduates also in interventional radiology. So they are also not trained to do PAE. So this is one thing we should be sensitive and we should take into cognizance and how we can include PAE in our training program.
Thank you, sir. Now, coming to the session B of this morning session, we invite Dr. Shashikant Mishra for PSA don'ts and do's.
Good morning, everyone. Slides, please. Where do I move the slides? Okay. So at the outset, I would like to thank the organizing committee for giving me an opportunity to speak about this topic. And this topic, as this states, has been controversial over the period of time. So a brief about the past, present, and future. Before 1988, when PSA was not available, it was too late for us to treat patients of CA prostate because they were all presenting with metastasis. The PSA era started from 1988, and from 1988 to 2011, the dictum was to screen all, and those who were positive were treated with the cancers. Early detection of aggressive disease caused mortality benefit, but the problem was over detection of low risk disease, and this was associated with harm. And this was followed with the US Special Preventive Task Force guidelines that came in 2012 and that recommended against screening. So this was based on the premise that reduced over detection of low risk disease would result in less harm. But then again, reduced detection of localized aggressive disease could result in lesser benefit. So now is the era of shared decision making where we need to diagnose even patients who are at a lower level of the PSAs and they have locally aggressive disease so that they could enjoy the benefit of mortality reduction. Why this topic? This topic is controversial because we are balancing harm versus benefit. And the benefit is to find aggressive cancers early, which would result in survival benefit. Whereas at the same time, we need to avoid unnecessary testing related complications, over detection and over treatment of indolent cancers that are the potential harms. And along with this are the rapidly changing paradigms, I'm sure will be discussed later during the term case. So the good part is
the PSA, when screened well, results in lower cancer-specific mortality, and there are randomized control studies and observational studies to document this. We all know that cancer-specific mortality rates have reduced to lesser than 50% over the period of time. But the bad part is still the indiscriminate screening and an epidemic of overdiagnosis and overtreatment. And obviously the financial constraints along with this screening part. So intent of screening is not to diagnose or not it's an evolution trying not to diagnose Gleason grade group 1 tumors. Why? Because these tumors are insignificant, only 0.3% extend beyond the prostate capsule at surgery. They never invade seminal vesicle at surgery. They never metastasize to lymph nodes. And following surgery, 15-year cancer-specific mortality rates are less than 1%. So PSA screening is an analog to other cancer screening protocols where the decision and the beauty is to intend to see the number needed to screen and number needed to diagnose, which is quite high. This is based on the longest epidemiological study where still we need 221 patients to screen to prevent one death. And the smart decision is to reduce this number needed to screening. If you look at the epidemiology, now we find that the problem is too many old men are being screened. And there's excessive PSA screening in these men with limited life expectancy. And at the same time, there is under-screening in younger men, which is a problem of similar magnitude. If you see the life expectancy in US, the average life expectancy is around 80 years. So the basic premise is don't do PSA screening in old sick men. And this is based on epidemiological studies which show that those patients who survive for at least 10 years would have 30% reduction in mortality when screened at an appropriate time. So clinicians should engage in a shared decision-making with people for whom prostate cancer screening would be appropriate and proceed based on person values and preference. So we need to know baseline PSA to risk stratify these patients. Less than 40 years, there's no need for PSA. Between 40 and 45 years, we need to screen patients who are at increased risk like black race, germline mutations, and strong family history of prostate cancer. Between 50 and 70, before 2023, the screening was advised for every 1 to 2 years, but now the screening interval has been increased to 2 to 4 years. This is in revised guideline of 2023. And this is based on the premise that we have to smartly screen these patients and personalize the rescreening interval based on the shared decision-making process. There is obviously a power of baseline PSA to risk stratify. We need to know the median PSA of each decade group. And studies have shown that 86% of all prostate cancer death have been reported in those patients who have PSA, which is more than their median age group PSA. If the PSA is less than the median, then the risk of lethal prostate cancer over 30 years is less than 0.6. It's around 0.6%. And we can predict those group of patients who are likely to develop prostate cancers 25 years down the line. And this is based on the noise of the PSA, which happens earlier on. And we need to also know when not to do PSA based on age. So we have to stop doing PSA if the median PSA is less than 1 nanogram at the age of 60 years. Why this? Because men with PSA less than 1, which is the median for that age, would have only 0.5% risk of metastasis and 0.2 risk of dying from prostate cancer by the age of 85. There's no apparent screening benefit when the PSA is between 1 to 2. But see, when this PSA rises to more than the median value, the number needed to diagnose reduces from 9 to 6. And this becomes very important to know. Always repeat a newly elevated PSA. This is for people with newly elevated PSAs. Clinicians should repeat PSA prior to secondary biomarker imaging or biopsy methods. Why? Because abnormal PSA, majority patients will also, the PSA would return to normal at subsequent visit. And we need to have second repeat PSA value before drawing blood or before planning further management. There is also a value of repeating PSA. So studies have shown that if the percent change of PSA is not much, after around 2 months, these are the patients would have Gleason grade 2 tumors. Whereas the fluctuations of the PSA is high, then there is likelihood that we will find alternative diagnosis as biopsy. Don't do biopsy on PSA velocity alone. For people who are undergoing prostate cancer screening, clinicians should not use PSA velocity as the sole indication for secondary biomarkers, imaging, or biopsy methods. Why? Because higher the PSA velocity, we are more likely to find prostatitis on the biopsy. Whereas lesser the PSA velocity, the chances of finding prostate cancer is high. And there are no randomized studies. There is no randomized studies to support the recommendation that PSA velocity should be followed. PSA velocity should be biopsied even in the absence of other indication. This measure should not be included in the practice guidelines. Another statement, which is a bold statement, is don't give empiric antibiotics just for an elevated PSA. You have to see urine culture reports before you give antibiotics for patients with raised PSA. Otherwise, randomized control trials for 2 weeks, 6 weeks, antibiotic are just negative trials. Do free PSA more frequently in PSA screening. Why? Because it's cheap, it's easily available. For men with mildly elevated PSA, free PSA is a more powerful predictor of Gleason grade 2 or higher tumors than the absolute level. And it's the primary driver for patients who, for the other scoring methods like 4K score or 5 scores. It is very easy to identify the risk of the patient based on free PSA because there is an online PCPT calculator. You just put the nomogram and then based on percent free PSA, if the percent free PSA is less, the chances of finding Gleason grade 2 tumors are high. And you see the slides, if it's to 20%, the risk is 13%. If it increases to 14%, the risk reduces to 8%. So it's a very powerful tool to smartly screen your patients based on the PSA and percent free PSA. We have also to rationalize PSA by doing PSA density assessment. This is a very easy test. Higher the PSA density, higher is the chances of finding cancer prostate. And this slide shows that if the PSA density is lower or on the lower side, the chances of finding Gleason and benign Gleason grade 6 and benign biopsies are more high. So now to summarize what do's and don'ts about PSA is, first is to stop screening old sick men. We have to explain the risk and benefits of screening. Not every man needs a PSA. Know the modified screening guidelines where the screening intervals have increased to 2 to 4 years. Always repeat an elevated PSA. Never give empiric antibiotic except when the urine culture is positive. Use your baseline PSA to risk stratify subsequent screening plan. We should know the PSA velocity, which is not particularly valuable. Use free PSA more in all the screening decisions. Estimate PSA densities and know when to stop screening. Thank you.
Thank you, Dr. Misra, for nice presentation. Few things from the Western or from European country. Our population are different from their population. Even in Punjab, we have seen people with 80 years old patient who are doing robotic radical prostatectomy. I have found them many patients more fit than us and many urologists also. So age solely should not be criteria, whether should go for PSA screening or not. Sick patient, okay, you can leave it. And second thing, Gleason score. If PSA screening found Gleason score 3+3 and PSA less than 10, it is not always low risk disease. There are other factors, paracrine, intracrine factors which is responsible. We have seen PSA with less than 10 and Gleason grade 3+3 patient progressing within 1 year. Patient used to belong to Professor Mandal, operated by Dr. Singh. Patient within 1 year came with lymph node metastasis. And we have done robotic radical prostatectomy and with lymph node dissection. So just on the basis of Gleason score, I may telling it is Gleason score 3+3, but he may tell it is 3+4. And somebody may tell it is 4+4. So Gleason score is not sole criteria to dispose the patient is a low risk patient. Thank you.
Yeah, absolutely agree because this is exactly this. See, Gleason scoring is all pathology dependent. So just based on the Gleason scoring, we should not rush to the decision, but it's actually to smartly identify those patients who would not benefit because this was exactly the criteria when LRP was in the picture, the radical prostatectomy rates were low. But when robot came into picture, more and more patients with Gleason's kiss were also operated. And this was the premise why US Special Task Force came with the guidelines. So I'm sure, yes, the points are all well taken. It's all depends upon the longevity of the patient and the physical fitness of the patient. It's true. Thank you,
doctor. Now we have how to do biopsy, pre-biopsy preparations for prostatic.
Dr. Rohit Kaushal.
Very good morning to everybody. So I'll be talking on the prostate biopsy preparation regarding the role of which antibiotics, when, how long, the role of antiplatelets and bowel preparation. So as we all know, prostate biopsy is a generally safe and effective and well-tolerated procedure. And infection, though rare, is a dreaded complication of prostate biopsy to the tune of almost 0.127%, and risk of severe sepsis is 0.3 to 3.1% in the largest series. So antimicrobial prophylaxis has been shown to reduce the risk of severe infection, but they are overutilized in most places for the trust biopsies, and this poses a risk of antibiotic resistance. And in a recent study, it has been found there's a wide difference in the antibiotic regimen used globally. As much as 24 different regimens has been used globally. So the rectal microbiome is mainly composed of the gram-negative enterobacteria, mainly the E. coli and other organisms in the family, and few cases also with the enterococcus species. So it has been seen that bacteria may be seen in up to 20 to 53% of pre-procedural cultures, but it is not necessarily associated with the development of post-biopsy infections. However, they have recommended routine pre-biopsy urine cultures not necessary in asymptomatic patients, but as of now, all guidelines still mandate a sterile urine culture before proceeding for a prostate biopsy. Now, coming on to the duration of the prophylaxis, a one-shot prophylaxis is considered sufficient, and a limited 24-hour course is generally recommended. However, still many urologists are customarily preferring a 3 to 5 day full course of antibiotic therapy, potentially contributing to the progressive diffusion of resistant strains. So, in a recent study, it has been shown that the degree of the antibiotic resistance in the E. coli organisms has been found to be 21%, and in some series it has been seen that up to 40% of the strains are resistant to fluoroquinolones and other antibiotics. So, the main risk factors for the infectious complications have been highlighted mainly in the form of bacteria, pre-biopsy urine culture, indwelling catheter in situ patients, or a history of recent international travel, antibiotics uses in the last 6 months, or patients with colonized FQ resistant E. coli. So one must do a risk stratification before thinking about the antibiotic to be given and how long to be given. So any patient with a history of antibiotic usage in the last 3 to 6 months with a prior fluoroquinolone use or international travel or hospitalized patients, healthcare workers, they need to be given a little bit prolonged antibiotic prophylaxis. So now see what are type of the antibiotic prophylaxis which are mentioned in the literature. The most commonly and the most widely practiced till date was, now empirical monotherapy with either fluoroquinolone or cephalosporin or aminoglycosides, and recently fosfomycin as well. The second type of prophylaxis is the targeted prophylaxis, in which is based on the rectal swab or the stool culture or urethral swab culture. And the last is augmented prophylaxis, in which the usage of 2 or more than 2 antibiotics is recommended. So amongst the empirical antibiotic prophylaxis, the mainstay till date was fluoroquinolone. However, in the recent years, with rising rates of fluoroquinolone resistant strains and ESBL producing enterobacteria, the resistant strains have grown too much, and now FQ use is discouraged by most of the guidelines, as the resistant strain can be as high up to 20 to 40%, giving rise to severe infectious complications if fluoroquinolone is used as a monotherapy in these patients. So to circumvent this problem of resistant strain, alternate options were explored in recent few years, like the alternative monotherapy, targeted prophylaxis, and augmented prophylaxis. So fosfomycin, third generation cephalosporin, aminoglycosides have been studied as empirical monotherapy. Other antibiotics like the piperacillin, tazobactam, amoxicillin, clavicolic acid have also been studied, but they have been found to be inferior result except for the fosfomycin. So 3 large studies recently with the amoxicillin have found large increase in infectious complications, and therefore they have not suitable as a monotherapy. In a recent study, among 697 patients, the cotrimoxazole was studied for the antibiotic prophylaxis, and it was found that in cases without multi-drug resistant gram-negatives in the pre-interventional urine cultures or rectal swabs, it was feasible and practical and safe. The efficacy of fosfomycin was also studied and published recently last year, in which they found that only the significant difference among the fosfomycin group, which had received just 2 fosfomycin doses versus the long antibiotic more than 8 days, that there was no difference in the infectious complication. It was comparable. Only significant difference was the lower tract symptoms were a little bit higher in the fosfomycin group, which was not statistically significant. Now coming on to the augmented prophylaxis. So like I told, augmented prophylaxis means that 2 or more than 2 antibiotics are used for the prophylaxis before a prostate biopsy. And it has been shown by 3 large RCTs, meta-analysis of 3 large RCTs, that it has performed consistently better results compared to monotherapy. So different combinations have been tried, like the fluoroquinolone with an aminonucleic acid combination, or a first, second, or third cephalosporin with aminonucleic acid combination, and they're found to be useful. Local antibiogram is essential to decide the prophylaxis in any setup. Now coming on to the targeted prophylaxis, it has again been extensively studied. Multiple publications are there, but still ambiguity remains regarding the clinical utility in most cases. In a recent study, it failed to find significant advantage in reducing severe infectious complications. Even in patients with fluoroquinolone-resistant bacteria, only 6 to 9% patient develop severe infection without targeted prophylaxis, which was same with the use of monotherapy with fluoroquinolone. And the other considerations like the economics, the logistics, patient has to come at least 10 to 2 weeks prior, get a rectal culture done, then wait for the culture report. So there are a lot of economic and logistic consideration as well in few setups. So this was a study in which they found that the targeted antibiotic prophylaxis adapted to the rectal swab, mainly with third cephalosporin, significantly reduced the rate of infectious complications. So there have been publications which are in favor of targeted prophylaxis, but recent studies have raised a question against its actual real clinical utility, and they found that the infectious complications is almost comparable to a augmented or a monotherapy prophylaxis. So let's see what does the guidelines say. Guidelines still, as per the AU guidelines, they recommend either a single dose fluoroquinolone or first, second, or third generation cephalosporin with or without aminoglycoside, or a third generation cephalosporin. So still in the AU guideline, single dose FQ is still mentioned. However, the EU guidelines differs on this. They have a stringent rules on the fluoroquinolone use, and they have suspended in Europe. And they have recommended where fluoroquinolone use is suspended, either cephalosporin or aminoglycoside, and they have found comparable infectious complications in 2 large meta-analyses. But as far as the augmented prophylaxis is concerned, there is no standard combination has been established to date. So they recommend primarily a transperineal approach in reducing the infectious complications, and the use of either targeted prophylaxis based on rectal swab stool culture or augmented prophylaxis is still their strength rating is weak. So this is the flowchart, what they recommend. If a transperineal biopsy is feasible, one should proceed with a transperineal biopsy, first choice, with a perineal cleansing and antibiotic prophylaxis. If not, a transrectal biopsy. But of note, people should use a povidone iodine rectal cleansing, which is must and has been shown to decrease the infectious complication by more than 50 to 60%. And if the fluoroquinolone is licensed in that country or area, then one must again use either a targeted prophylaxis or augmented. The fluoroquinolone prophylaxis is the number for which they recommend. However, if the license is not available, one must go ahead with it, either a targeted prophylaxis or augmented prophylaxis. Alternative antibiotics like ceftriaxone or aminoglycoside can be used as such. So with the increasing fluoroquinolone resistant strains and discouraged against its use of FQ remains as monotherapy. Most guidelines is now discouraged. And most cases need a single dose prophylaxis plus a 1 day of antibiotic is sufficient in most patients, except for those with risk factors like I outlined earlier. They might be given 2 or 3 days of antibiotics more than the prophylactic regimen. And the non-pharmacological measures play an equally important role in reducing the infectious complications. Now coming on to the antithrombotics before a pre-biopsy. Most men needing prostate biopsy are old, they're having multiple comorbidities, and many of them are on 1 or more antiplatelets or anticoagulants. Some have recently started, some are on the chronic antiplatelets. It has been seen that almost 10% patients on antithrombotics will need an invasive therapy each year, and it's critical to understand individual agents and their pharmacokinetics and dynamics to optimize outcomes. So these are the risk groups who are already on antithrombotics, either antiplatelets or anticoagulants. And there have been many risk assessment tools which has been outlined in the literature, like the CHART score, the Capillary risk assessment models, the bleeding risk assessment. So using this risk assessment model, one can actually outline the risk of stopping the antithrombotics prior to biopsy and the risk of major complications. So as far as antithrombotics is concerned, there are mainly 2 types, the antiplatelets or the anticoagulants. As you can see, antiplatelets, we have the aspirin, clopets, And this cilostazol, among the anticoagulants, we have the oral and the injectable forms in the form of heparin or the new anticoagulants and injectable and the oral warfarin. Amongst the antiplatelets, we have the COX-1 inhibitors like aspirin, the P2Y12 receptor inhibitors like clopidogrel, prasugrel, which are very strong antiplatelet agents, the glycoprotein 2B3 receptor antagonists, and PD5 inhibitors. So as far as the dual antiplatelets are concerned, it has been advised that at least 2 weeks post angioplasty, then dual antiplatelet has to be continued at least for 6 weeks for bare metal stent, at least for 1 year for drug-eluting stent. So it has been seen when DAPT is discontinued for emergency surgeries, the risk of major events is almost to the tune of 10%, and mortality is 10 to 46%. So only life-saving procedure should be done within this critical phase, and prostate biopsy is not a life-saving procedure in most cases. So, and bridging therapy in this critical phase is poorly studied and discouraged. So among the anticoagulants, we have the warfarin, which is mainly acting by irreversible binding to the enzyme in the liver, inhibiting the factor 2, 7, 9, 10, and protein CNS, and mainly indicated where strong anticoagulant is needed, like for atrial fibrillation patients, for VT prophylaxis, and mechanical cardiac valves. Now, the concerns is warfarin as it has a very low therapeutic index and delayed onset and offset of action, and its constant monitoring and dose adjustment, and its half-life is very long, as long as 36 hours. And bridging is necessary in most cases with moderate to high risk of thromboembolism. So warfarin should be stopped at least 5 days prior to biopsy, and it should be bridged with a low molecular heparin 36 to 48 hours before the biopsy or post the last dose of warfarin. And the low molecular heparin should be restarted at least 24 hours after the biopsy, and warfarin should be started after day 1 of biopsy if feasible and safe. And overlapping between the low molecular heparin and warfarin should be continued like in bridging until a target INR of 2 to 3 is reached. Now, these newer oral anticoagulants are very good drugs which have come up recently, and they have a superior advantage over the warfarin in terms of the half-life or reliable pharmacokinetics and dynamics. And there's no need of bridging anticoagulation. It is a fairly safe drug to be used. However, there are concerns with the use of new anticoagulants, like it cannot be reversed completely, and it's excreted primarily by the kidneys. And it is not recommended to be used in high-risk cases or like antiphospholipid syndrome or mechanical cardiac valve patients. Now, when to stop this new anticoagulants? As early as 2 to 5 days, we can stop this new anticoagulants, and depending on the risk of bleeding procedure, and we should restart it as early as possible, generally after 24 hours if feasible. So to conclude, low-dose aspirin can be safely continued preoperatively during the biopsies. In non-critical phase, the dual antiplatelets anticoagulants can be stopped, and only aspirin should be continued. We'll just skip these slides. Now, as far as the bowel preparation is concerned, many studies have been done with all these agents like bisacordyl, enema, PEG, and rectal cleansing.
So we have run.
Yeah, I'm just finishing with
you
last
can
one.
just reach to the message.
So amongst all this, the rectal cleansing with betadine has been found to be the only thing which has shown to significantly decrease the infectious complication by almost 50 to 60%. And now even the EU guidelines recommend using this rectal cleansing with povidone iodine prior to a transrectal biopsy, which is strong rating. Thank you.
Was a quite comprehensive presentation. Just a quick question. Is your protocol for transperineal, transrectal biopsy antibiotic prophylaxis same, or do you differ in?
For the transrectal biopsy, I use an augmented prophylaxis using a third generation cephalosporin with an aminoglycoside. And for the transperineal, I just use single dose of a third generation cephalosporin. That's it.
For anaerobe also?
No, sir. In the transrectal biopsy, I'm not covering for anaerobe. We just give one dose of prophylactic antibiotic ciprofloxacin with rinidazole combination 1 day prior, and we just cover 1 day with an augmented prophylaxis. Right.
Rinidazole does cover the anaerobes.
But in
our usual practice to ciprofloxacin seen with rinidazole.
Right, sir. But the recent studies, they have shown that there's almost no role of using this anaerobic cover in transrectal biopsies in most of the literature recent. This, but still, I think maximum people out here, they are using this anaerobic cover as well.
What is the usual practice? Ciprofloxacin plus rinidazole. Do you cover anaerobes? Professor Gupta?
I'm doing only transrectal biopsy till to date, and we use mechanical cleaning. What he said is the most important thing according to me, both perianal and intrarectal. betadine, swab, you should clean the rectum thoroughly. I always ask patient to take enema morning or previous night, and we give ciprofloxacin with this nitrotinidazole BD for 3 days at least, and one shot of this Magnex injection in the morning.
I think nowadays, because of ESBL bacteria, the immunolones and cephalosporin both are 70 to 80% are resistant. So it is of no use to you give a third generation cephalosporin to the patient, any cephalosporin or oflosporin. Because they are uniformly, if you see the culture of your institute, you will find 70 to 80% bacteria are resistant. So there is hardly, I think the most probable choice, most good choice is ostromycin plus amanaglaxin. That will cover most of the bacteria, and the bacteria are still sensitive to ostromycin.
Sir, one of the choices is a single shot of piperacillin and tazobactam. Because we have to understand these patients are coming from the community. They are not carrying an infection. As a routine, we do a urine culture. We are not doing any rectal swab in pre-operative period, but a proper cleaning with enema and betadine and a single shot of piperacillin tazobactam may do the same job. Quinolones, of course, we have been using, but there is a lot of resistance in community-acquired bacteria.
Thank you. Thank you, Doctor.
Please.
So now we invite Dr. Harshit Garg for his talk on repeat biopsies when and how.
Hello. Hi, good morning, everyone. First of all, thank you to Norzone USI, and I got a message from secretary that we have to be, we are running late, so we have to wind up real quick. So the purpose of next 5 minutes is, don't want you to allow you use your phones, don't want you to get dozed down. The morning is a beautiful morning, and so we'll just make it quick, we'll make it interactive, and we'll talk. Everyone knows this repeat biopsy. We have all been doing it for years and years. So repeat biopsy is just like, we all facing need. We think repeating need is a terrible answer. So biopsy for the patient is a great thing. Like, you don't want to repeat a biopsy. The first thing first, that try not to have a patient where you need to do repeat biopsy. And how can you do that? Do the first biopsy correct. So repeat biopsy, the question is when and how. We all, kind of know it, learning it for years, and maybe not what's there in the recent evidence. So there are two questions, when and why, and second is how. So let's talk of when. And it's not a new issue, as we all know. So since 1995, a lot of papers, how to do repeat biopsy, what to do and all that. So when we talk of repeat biopsy, what new things has come in the MRI? So have you done MRI before that first biopsy? And was your first biopsy MRI able? So what are the guidelines right now to talk in terms of all the guidelines? Just talk, Chris, what is NCCN saying, EU saying, there's some guidelines in 16 by the SEO EU consortium. So when we do repeat biopsy, when we have a high suspicion of prostate cancer and our first biopsy is negative, at that time we do repeat biopsy, very straightforward answer. So there's certain other, riders to that when you have some atypical presentation with NCCN says very crisply that if you have atypical reduction perforation without invasive cancer, repeat a biopsy. If for ATPR, consider repeating a biopsy in next 1 to 2 years. And even if you have ATPR, HGPIN more than 3 and all that, when you have a strong suspicion, repeat a biopsy with a refined biopsy technique. So that's the key there. You should have a refined biopsy technique. And what are we taking here? When I have done a repeat biopsy, two questions come in: biomarker testing and use of multiparametric MRI. And biomarker, I think most commonly what we're using, PSA, PSA density, PSA velocity, all these are subtle markers. NCCN is not very supportive of PSA density. EAU supports PSA density at some level. So coming to the biomarkers first, what does NCCN say? That, you can, therefore say PSA, percentage free PSA, but they also add the newer biomarkers like prostate health index, 4K, confirmed MDA, Progensa, MIPS, all that thing should be considered as an option when you are trying for a high repeat biopsy. These are the old diagram. Everyone knows about these parameters. We'll not go into those details because we don't want to dwell into them right now. 4K score basically includes total PSA, free PSA, intact PSA, human calligraphy. Not very commonly done in clinical practice, not easily available. I'm open to house if anyone is doing it very often. 4K score. So please help us there. So, but it has shown in various studies that it can be used. The score is high. There is a high suspicion that the cancer. You should go for a repeat biopsy. That is when you should go back. Second is again prostate health index. You again have a cutoff score of 35, and it has shown that if you do this biopsy and you add it to the MRI, which is easily available right now, they together give you a negative predictive value of 97%. So what do you mean by negative value? That if this test comes negative, that means there is 97% chance that there is no cancer, and that is what we want. But yes, test ne bola cancer nahi hai to nahi hai, and then we'll not do the biopsy. That is what we are looking for, a good negative predictive value here. And so what this study showed that if you use this with MRI, you can actually decrease your biopsy significantly. Again, Progens are not very commonly used in Indian practice. All these are very easily available in USA, and they have been shown that if you combine PCA3 of Progensa with MRI, they have been shown to have a negative at 100%. That is 100% chance. If it is negative, you don't need to repeat the biopsy. So then again, confirm MDX for the epigenetic testing. Again, good MPV. So we have a lot of these codes, not very practically used. And I would like, if anyone in the audience is using them for deciding whether to go for a repeat biopsy or not, that would be very great. You can tell us they're using it in practice or not. Then let's get back to practical. So what do we do then practically? Practically, you do an MRI. So you have to first say that whether an MRI was done earlier or not. If MRI was not done before the biopsy, the first thing is that you do an MRI, see where the lesion is, and try to target that lesion. That is the essence of this story of 10 minutes. So we come to now how. So first, MRI aided fusion or in vivo target biopsy. That is the answer for negative biopsy and repeat biopsy. Or you do a saturation biopsy. So let's see quickly. So when you are doing an MR fusion or a targeted biopsy, they have shown that it decreases target biopsy. They actually miss only 2 patients, while if you do a standard biopsy, it will miss more cancer. And we all know this thing like MR fusion biopsy or MRI target biopsy. What they do, they will increase the detection of significant cancer and they will decrease the detection of insignificant cancer. That is what we want. That significant cancer ko pakad le, insignificant cancer ko chhod de. And that is why MRI is all here. And it's now the standard case. You should try to do MRI fusion biopsy as per all the guidelines, because it will also eliminate the low risk tumor. Then we come to that, the systematic review of this thing and say higher rate of detection of significant cancers, lower for incident cancers, and it is, improvement in overall, even in the repeat biopsy setting, it has shown to be important. The second concept is saturation biopsy. Not many of us are doing it. So it is more than 12 core, 18, 26 core biopsy. So whether it is transperineal or transrectal, there has been papers on that, and what they say that both have same cancer detection rate. And which is good or which is bad, we leave this to debate in the next round between Dr. Siddharth and Dr. Sindhureka, that whether it is both trans or transperineal. Will not well in detail this. But what does NCCN finally say? That despite this emerging evidence, the panel is not recommending saturation biopsy. Karna hai to MRI fusion biopsy karna hai. In brief, अगर आपका कैंसर आपने फर्स्ट बायोप्सी कर दी है, it is negative, you have strong suspicion of cancer, go to a center, do it, or do a MR fusion or MR targeted biopsy. That is the key here for last 5 minutes. And is that all? No. Yes, mostly yes, that's all. But one more question. If I have done first biopsy as an MR fusion biopsy, and now it is coming negative. I recently had a patient, I had 4 lesions, PS16, and we did a cognitive fusion there, and it was negative. We were very confident that our cognition was smart and all that stuff, but it didn't give. And normally you take 4 courses, 3 or 4 courses. More than 2 courses have to be taken when you're taking a target, as per all the trials. So, sir, Doctor, I would like to take the opinion of how what could be now. Yes, so that is another answer. PSM guide biopsy. I think PH indicated doing that.
My practice, I will like to do the repeat MRI. Must be after an interval of 3 or 6 months at least, And then the radiologist, we have an expert one, they compare the previous MRI and this MRI. And if it remains the same, then I may not do the biopsy. I'll say again, wait for 6 months more. If they say that now there's a change, then I'll do a fusion biopsy, which I am doing since 2012.
So, sir, we always call sir as teacher of teachers, and sir reiterated the European guidelines in one word, which I was to show in the next slides. That is what the European urology paper recently showing the protocol is. Yes, sir. Yeah, I think that's also reading the MRI.
I think we have a situation here which is different from West to India. West doesn't have a PSMA PET scan which is available for them. We have PSMA PET scan. It is this thing. So let us not ape the what Europeans have said or Americans have said. If you have a strong conviction that there can be a malignancy and the MRI fusion biopsy, whatever biopsy you have done, which is negative, and you see a progressive increase in PSA, I'm fine with doing a PSMA PET scan to see if there is a high uptake inside. Why are we put the guidelines to them. This is how we can do it here afterwards.
But how do you, PSMA biopsy is not available very easily. So if you want to switch over tissue diagnosis.
I'm not saying PSMA guided biopsy. If you see the question now is, are we missing a disease? Are we missing a disease? This is a prime point for any patient, right? Are we missing a disease? An MR sometimes may show an abnormality, and MR many times may not show any abnormality also. I'm right. If there is nothing there which is seen in an MR, I still love to do a PSMA. If there is a PSMA solid spot on a PSMA, guided biopsy or core biopsy of that area.
How is that guided biopsy?
Yes.
No, you just correlate with your transrectal because it's not a big. Once you know where to biopsy, I don't think we need an MR fusion to do that area.
Thyroid food lesion in the left midfield.
Mhm.
We did a biopsy with cognitive fusion of what is fusion.
Fine.
But that biopsy came there. Now what we do next?
That's exactly. Every Pirad 4 lesion doesn't mean that there is malignancy. Why are we saying that? Every Pirad 4 lesion may be seen. It is interpreted as a Pirad 4 lesion, need not have a malignancy. If the person had a MR fusion biopsy or MR guided biopsy or MR whatever biopsy is in, if there is a progressive increase in PSA and we are convinced about it, I don't mind doing a PSMA PET scan, understanding the disease if at all, if it is.
Harshil, I actually agree with what he's saying. We have to see the situation in our country scenario. That PSMA is possibly available to all of us very easily. I have two patients, just to put an example, who had anterior zone tumor. They had 3 biopsies in Europe, and they were negative. There was an anterior zone tumor, and we did the PET PSMA and targeted the same area without fusion, and it was positive.
Yeah.
So, Dr. Garg,
So I think all these points are well taken.
What is the role of combining multiparametric MRI and PSMA PET in this situation? And if there is a very high suspicion going for a radical prostatectomy effort, why to go for a biopsy effort?
first thing, Dr. Garg, we have to investigate.
Just find out quickly. I think the house became very, like,
Just-
you
just-
close it. So
just-
what does they say? That you just redo MRI, read MRI, and then you repeat a biopsy. If it's paralyzed, just do a biopsy again. Three or four will not be cancer, as Melissa said rightly. So you just follow them up. In a nutshell, that's all. I think we'll close the
Just
topic.
with last statement, we are not following any guideline. I am not doing any MRI. Okay, per rectal examination, PSMA PET, biopsy, that is only investigation you are doing, but that is the final investigation. If there is lesion, you do targeted biopsy. No repeat MRI, there is no role of MRI. You are not following this, you are not following all these guidelines. Okay, thank you.
I think the message from this is, Bahubali 1 was doing very great, but if you are doing a Bahubali 2, that
Thank
was
you.
a bigger film than
Thank
Bahubali
you,
1.
Dr. Garg.
Repeat
Thank-
Next,
Thank you, Harshit, for making it a lively, interactive session. And thank you, chairpersons, for chairing the session. We now move on to the debate session. Again, on the similar topics, may I invite the chairpersons for this, Dr. B.S. Olak, sir, Dr. Anil Ellens, Dr. Keshav Murthy, and Dr. Aditya. Please. So this is only in one go debate. The presenters are requested to present in a one go itself, 5 minutes for each presenter, and there are additional 2 minutes for any question answers that the panel, the chairpersons may have. Thank you.
Yeah, good morning. The first debate, NPMRI for all before prostate biopsy. Yes, for all, Dr. Gopal Sharma.
Good morning, all. I would like to thank organizers for inviting me here and giving me this opportunity to debate with for this topic with Pradhan sir. So, uh, 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 I would like also thank Dr. Harshit Gar for his lively talk and making the interact session so interactive. And then now move on to my talk. Uh, before we go on to doing MRI before biopsy thing, so actually when a patient comes with elevated PSA or suspicious of prostate cancer, what all we can do? We have basically three pathways. One is we can do directly biopsy. Second, we can do MRI and then see what it is. And then third is we can do some risk adapted scores like PCPT score and then see how much is the risk and then do the biopsy. So basically how the MRI pathway works, when a patient suspicious of prostate cancer comes to us, we do a MPMRI. If it shows Pirates 1 or 2, we don't do biopsy. If it shows Pirates 3 or 5, we do biopsy. Only in those patients we do biopsy in which Pirates 3 to 5 is seen. So the question in hand for this talk is why should we subject every patient to MRI? What is the advantage? And is it useful for patients who has a very high PSA and multiple hard nodules? Will I subject this patient also to MRI? I don't think any of us here would subject this patient to MRI. Most of us would do directly biopsy. So what are the problems with MRI? For a country like ours, the first and foremost problem is cost. Second is availability. And obviously, patients with implants and pacemakers cannot do that. And it is also not safe in certain patients, like it has its own nephrotoxicity. So what is the current level of evidence for doing MRI before biopsy in a patient who is suspicious of prostate cancer? I would say it is level 1A. So it leaves no doubt that all these patients should be subjected to the biopsy. So I had just prior to this talk, I had dropped a short poll onto the WhatsApp group, and from this I could make out that our learned audience have given their opinion regarding unanimous opinion regarding the use of MPMRI in any of the condition if a patient has a elevated PSA with a normal or abnormal DRE. So why there is so much confidence in our audience regarding the use of MRI? Basically, there have been 5 or 6 RCTs, multicentric RCTs. Most of them have been in UK, like this Promise trial. And second was Forum trial, which was a Dutch trial. And third was Precision trial, which was basically done in UK. They had slight difference in methodology, like in Promise trial, when a patient with suspected prostate cancer came, he went under MPMRI, and then on the same day patient underwent transrectal biopsy and transperineal mapping biopsy, in which they took biopsy from 5 mm space. Second was a 4M trial, in which when a patient came to them, they did an MPMRI. Patient with Pirate 1 or 2 underwent transrectal biopsy. Patients with Pirates 3 or 5 underwent MRI fusion biopsy. The Precision trial, which was recently about 4 years ago, it was reported 4 to 5 years ago. It differs slightly. It was slightly different from these. It was more of a MRI pathway approach, in which they made 2 arms. Arm 1 was MRI pathway. Arm 2 was transrectal biopsy pathway. In arm 1, they did biopsy only when MPMRI score, I mean Pirate score, was 3 to 5. For Pirates 1 and 2, they did not do biopsy. And in the arm 2, they did biopsy for all the patients. They did transrectal biopsy for these patients. So from this slide, you can see what were the basically results of these studies. And I have pooled the numbers for these studies, and I feel that this is the take-home message from all of these slides, that by using MPMRI in a patient suspected of prostate cancer, using a Pirates 3 cutoff, you can avoid biopsy in 30% of the patients. And with a catch there that you would be missing only about 11% of the clinically significant prostate cancer. The information we know here, we don't know here, is that whether missing this 11% clinically significant will decrease their survival or not, because no study has been done on that. But it is certainly known that avoiding 30% biopsies reduces the risk of complications, and it improves the quality of life in those patients who don't undergo biopsies. There has been a Cochrane review which has shown that MRI pathway is the best pathway. They have compared all the possible pathways available, like trust biopsy, MRI only, MRI targeted, systematic biopsy. So they have shown that MRI pathway is the best pathway. And this is a slide taken basically from the EAU guidelines. From 2018, EAU guidelines recommended MP-MRI only in the repeat biopsy setting. But now they have changed the recommendation to do MP-MRI in all the patients, even in the biopsy naive patients. And they recommended using Pirate score uh, as a decision maker for doing a biopsy. But in recent update in 2024, they have added Pirates plus PSA density as a decision maker for doing biopsy. This is the same, and slides say that this EAU guideline says that it recommends performing MPMRI before all MPMRI in all the patients suspected of prostate cancer. But this can be avoided in certain patients, like patients with PSA more than 50, and those you are not considering resection or any other curative therapy. So I think I will just leave this my part due to lack of time. Uh, I would like to close the talk. Thank you. Thank you very much.
Thank you, Gopal. We now call upon Dr. Aditya Pradhan to present his talk on not for all, NTMR.
I'd like to thank the North Zone for giving me this opportunity. So at the outset, I'd like to ask you, I mean, who am I to sort of contest guidelines and say that you don't do an MP-MRI or you do an MP-MRI? The guidelines that tell you do it. So my talk basically is focused on our practice, real world practice. What really is MP-MRI going to achieve, and what are the fallacies which I as a urologist need to be aware of? So this standard path, the diagnostic pathway has been shown. My slides are not up. Yeah. So we've been through this, and this is what we follow. We do a rectal exam, we do a PSA, and then we talked about MP-MRI, and then of course you go and do a biopsy with the fusion, cognitive, or whatever you do. So the first thing I need to ask myself is this technology really accessible to all? We all know it's a very costly device. In most metropolitan cities, you might get it. In tier 2 or tier 3 cities, maybe 1 or 2 centers have it. And therefore, the limited availability becomes a problem for the patient to access an MP-MRI of good quality. The other thing is that in the center doing it actually, who pays attention to all these details? How many of us actually give you, our patient, an instruction sheet, including this, like for instance, avoid ejaculation for 48 hours. This is important because your 3B diagnosis on a MRI will come from this. So patient preparation is mandatory. The other is how much diligence that center puts into doing those prostate specific sequences. Not all centers do it properly, and therefore you get a bad outcome. And remember, this is what you're going to decide on whether to do a biopsy and how to do that biopsy. So looking at this shortfall, we today have scoring systems which are available to decide on what is the MRI quality which is coming to us. Unfortunately, this is not adopted very widely yet. At the end of the day, this MRI and what comes out of your MRI request is dependent on the radiologist. There's a lot of subjectivity between radiologists in reading an MRI. And therefore, it is important to know whether your radiologist is diligent, whether he has the expertise. They are supposed to have gone through a training course. And then these are vetted against known experts. And that gives you a quality assurance of the work coming out of that radiology center. We were given this trial, but look at what you see. Even in MP-MRI 1 and 2, there is a good amount of
cancer which you may see this 16% cancers were there, 17 significant cancers out of 158. So this is what happens when you look at real world data, multiple centers, and these are centers where the radiologists in these trials were MRI, MP-MRI reading trained, proficient. Even in those centers, you can have a lot of miss. So let's come to what is false negative and what is false positive. We know if the patient has a false positive, you're going to put this patient into unnecessary anxiety, and there's a lot of burden of stress in those patients. And a false negative is worse. You've told him there's nothing, and actually you've missed a cancer. Some examples I put up here. Here are here are two foci which were actually reported as pyrite 3. Not looking at the full picture, this fellow was biopsied and it turned out to be a prostatitis. And therefore, how commonly do you get these negative, false positive MP-MRIs from infection? So even in those patients who are pyrite 3, if you see, you get maximum false positive there. And it's about 40%. So it's a very high figure. Pyrite 3s are cut off. And that's where you can see if you go pyrite 4, 5, those false positives are less common. So the major cause, as I told you, is inflammation. The other things are if there's a very large BPH, there's a complete effacement of peripheral zone. To read and see a malignancy there or not takes a lot of time and effort, and not many radiologists do that. And of course, if the patient has had a recent UTI or retention, it's probably best to not do an MP-MRI at this time. The other is the opposite, false negative. There was a cancer and it has been missed. It's not very uncommon. Look at this study, which was a recent publication in a radiology journal. Out of 96 patients, almost half had prostate cancer, which was missed. And the only reason was bad quality MRI. So these are some examples. This was a cancer focus, which was reported as normal, missed, but because there was suspicion, biopsy was done and showed a fact. The other points I'm trying to stress is that many of your patients, you can't do it because of claustrophobia. There are some contraindications like the hip replant that gives you a lot of interference. You can't do it. And of course, patients with pacemaker and patients unsuitable for contrast, you might not be able to do all the sequences. So the whole trend today is look at the MRI, decide your biopsy on that MRI, and then execute a good biopsy. So you're dependent on radiologists. Now we have technology which is bringing that control away from the radiologist back to you. Micro ultrasound. So we're talking of a 29 megahertz ultrasound, which will magnify the prostate anatomy. With this good resolution, at the same time, you can biopsy it. You have a primer scoring on this technology, which is graded 1 to 5, similar to pyrite scoring. And if you achieve proficiency in using this system, the sensitivity and specificity as much or better than MP-MRI can be achieved in a single setting with low cost and at a fraction of the logistic problems which an MP-MRI before biopsy involves. So I'll conclude by saying, yes, it's good to do an MP-MRI, but know the limitations of the machine, know the quality of the machine and the quality of your radiologist who's giving you that input. There are many ways that you can see how good your machine, MP-MRIs are. There are scoring systems on the quality of MP-MRI, which we should adopt. And I think today, better technologies like micro ultrasound will allow us as urologists to do better quality or equivalent work, what we do with an MP-MRI. Thank you.
Okay, is there a rebuttal? Gopal, you want to rebut? Any comments from the floor?
And he has a clinically palpable with periprostatic infiltration, aged persons above 70, then I think that he may not be a good candidate for surgical procedure. So in that situation, we straightway go for PSMA PET-CT instead of going for the MP-MRI and transrectal standard 12-4 biopsy can be done. No need for MRI. Whereas other scientific candidate, younger side,
less PSA, chances more for the surgical treatment. Because surgical planning and MRI also help us with that local staging. So that's why we prefer that.
Absolutely, sir. I agree.
Sir, the issue is it's very difficult for urologists to monitor the quality of radiology reports and know about their courses or know about their expertise. We just depend on the people. They give a report and we don't have any choice except to say yes to what they write. The only thing about this debate of fusion biopsy and PSMA PET CT guided biopsy. So we all need to have an idea what is the diagnostic accuracy of these modalities. So I don't know how much is the diagnostic accuracy of MRE fusion targeted biopsy and PSMA PET CT biopsy. And we would like to know also what recent research is being done in India, because most of the time we are just relying on the data which come from the outside. So probably we are having our own data, and we need to know what is the diagnostic accuracy so that it is clear to everybody which way to go.
I think we need to define ourselves in a little better fashion. What are we looking at? Are we going to do an MRI for every patient before we do a biopsy? Am I right? In fact, why are we doing an MRI for every? Suppose if the patient comes with a 50 PSA, hard nodular prostate, do I need to do an MRI? Are we looking at those patients?
These are obvious. I mean, you don't.
That's exactly.
That's
so
obvious.
let us define those patients wherein the likelihood of these patients going ahead for a radical treatment options, possibly an MRI is essential preoperatively itself so that we understand the disease better, we don't miss the disease. There is no need for an MRI for every patient. So let us define ourselves when to do it.
Malik, the question was, how are you going to achieve your diagnosis? We have relied on a radiological evaluation, which is dependent on quality of machine and radiologist.
Yes,
and
sir,
then you go and do your biopsy on the assumption that all that has been done so far is accurate. What we are trying to say is be aware of those limitations. So your biopsy is dependent on something. Now think of something else. Can you do it yourself without depending on the radiologist? Probably you can. That's why we are trying to say that technology like ultrasound is probably going to come. We are still not there, but it's probably going to come. That's what
I
we're
tell
trying.
you, I strongly believe we are not very far away before we do a PSMA PET scan just to diagnose
Malik,
and then do a biopsy.
Yeah,
that's possible.
Get into this discussion.
Ajit, we have published a paper, our experience of MRI fusion biopsy. Please go through that paper. That is in 2018 and in Indian Journal of Urology.
We now move on to the next debate, which is prostate biopsy, the root of the biopsy, whether transrectal or transperineal. We have Siddharth Yadav who will speak on the transrectal biopsy.
Good morning, respected chairpersons, teachers, and my dear friends. I'll be speaking on transrectal prostate biopsy. So transrectal prostate biopsy has been there for around 100 years and the transrectal ultrasound guided biopsy for around 35 years. But there's a recent surge of interest in transperineal biopsy with reports of higher cancer detection rates and lower infectious complication rates. In the next 5 minutes, we're going to assess whether there is any content in this or it's just a noise. So I'm sorry. So whenever we are assessing a prostate biopsy procedure, there are 4 important things. First is cancer detection. Second is complication rates, pain scores, and the cost. So for the non-MR fusion biopsy, a significant proportion of centers, at least this part of the world, are still performing the non-MR fusion biopsy. The last systematic review published in 2019 that included 4 randomized controlled trials showed that the cancer detection rate for transperineal is similar as to transrectal. However, for the MR fusion biopsy, the last systematic review in 2023, which included 15 studies, had only 1 randomized controlled trial that also evaluated patients in repeat biopsy setting, thus ended up generating poor quality of evidence. 3 randomized controlled trials have been published in 2024, with one of them having the primary outcome as cancer detection rate and other 2 having the primary outcome as infection rates. And all these 3 trials found out that the cancer detection rate was similar. But for the perfect trial, which had the primary outcome as cancer detection rate, found that the difference was 7%.
and transperineal biopsy was not found to be non-inferior to transrectal because the limit was set at 5%. As far as the cancer detection in posterior lesions is concerned, transrectal was significantly better in detecting the lesions in the posterior zones of the prostate, whereas detection of lesions in anterior and apical lesions was similar for transperineal and transrectal. As far as the core positivity, detection of any grade cancer or ISUP2 grade cancer is concerned, both the biopsy techniques are similar, but transperineal biopsy ended up detecting more ISUP1 cancers, which was not supposed to be detected. Thus, the only randomized controlled trial failed to show non-inferiority of transperineal biopsy, and the cancer detection rates of transrectal biopsy is better than transperineal in the only randomized controlled trial. As far as the overall complications are concerned, all the three trials showed that the overall complication rate, infection rate, and urinary retention rate was similar between the transperineal and transrectal biopsy. Let us focus on the infection rates, which is the main push for transperineal biopsy. There were two randomized control trials using infections rate as the primary outcomes. One of them used the rectal swab-directed antibiotics and the other used augmented antibiotic prophylaxis, both of them using simpler antibiotics in majority of the patients in prophylactic doses, found that the infection, sepsis, and readmission rates were similar between the two procedures. And there was no patient who developed antibiotic resistance in any of the trials because of the prophylaxis. Finally, we all know the pain scores are much lower in transrectal biopsies. The severe pain is lower, and then the biopsy time is shorter, and we don't need an OR suit for a transrectal biopsy. Now coming to the neglected issue, the cost. There is a substantial initial cost in transperineal biopsy, especially if MR fusion software is required. However, more important cost is the cost of learning curve, which is much longer in transperineal biopsies. And there will be cases of missed cancers and repeat biopsies till the surgeon overcomes his learning curve. Finally, transperineal biopsies are inherently costly procedure, and now it is well defined that 94% of the overall cost is biopsy related and only 6% is because of the readmission. And this slight reduction in the readmission rates does not offset the initial cost. Also, transperineal biopsy is a standard for a reason because it is simple, effective, versatile. Cognitive fusion is very easy in transrectal biopsies as compared to transperineal. Transperineal is much more difficult to do a cognitive fusion, thus making software fusion biopsies unnecessary when using a transperineal. Transrectal is here to stay because it is an omnipresent equipment. And more importantly, urologists are not allowed to use ultrasound in majority of the parts of the country, especially in the northern zone. Are we expecting the radiologist to come to our OT and learn transperineal biopsy? Probably not. So to conclude, the push against are mainly two. First is the infectious complications, the evidence for which is weak, and the high quality recent evidence do not support this. Secondly, it is said that transperineal biopsy is going to avoid the misuse of antibiotics. Now, antibiotic stewardship is the need of hour, and just shifting to transperineal biopsies is not going to solve the global problem. The main question is, are we willing to miss cancers to slightly reduce the infections rates? Thank you.
Now I invite Dr. Sanjay Sureka, and he'll be speaking for transperineal biopsy. Sanjay sir.
I am sorry to say that Siddharth is grossly dirty. He is very unhygienic. So I was requesting him कि तुमने morning में shower लिया कि नहीं लिया. So I'll talk in the favor of transperineal biopsy. So I don't know why Siddharth has a habit to find love in a dirty place. So how transperineal biopsy evolution happened? Till 2015, the 99% of the biopsy or 97% of the biopsy or transrectal biopsy. But the problem faced was antibiotic resurgence of antibiotic resistance, especially the fluoroquinolones. The infection rate was higher, and the patient, those who had a negative biopsy, they had 17% probability of a apical tumor detection, which is difficult to target with the transrectal biopsy. So, as I said, the primary concern is infection or sepsis. There is no doubt about it. In a biopsy-naive patient, overall cancer detection rate between transperineal and transrectal biopsy is comparable. And transperineal biopsy detect more prostate cancer in rebiopsy or active surveillance, suggesting increased ability to transperineal biopsy to detect clinical significant prostate cancer in certain subset of the patient, especially who is harboring the cancer in the apical or anterior zone. So this is the first earlier publication for the transperineal biopsy, and they found the transperineal biopsy provide better anteroapical sampling. So key point here to discuss whether the in terms of cancer detection rate, in terms of complication and comfort and resource utilization, as already many of the part already covered by Siddharth. The transperineal, if you see the initial most major retrospective study, which was published in 2019, they found the cancer detection rate was similar. However, in anterior region, the cancer detection rate was much higher, significantly higher, 10% vis-a-vis approximately 3%. And the UTI in transperineal biopsy and sepsis complication, of course, less. That's we all agree. If we there is a there are certain myth that the transperineal biopsy detect less cancer in large prostate, but if you see this RCT where the prostatic size are comparable, and they found there are no significant difference between transperineal and transrectal approach for diagnostic accuracy. However, the rectal bleeding, which was not covered by Siddharth, in one of my patient who had 5 days of rectal bleeding, and you cannot ignore the rectal bleeding, and it's really worrisome for the patient. So, of course, there is certain degree of increased pain. That's nobody is doubting. However, transperineal biopsy is comparable with the transrectal biopsy in terms of cancer, clinically significant prostate cancer. Now, I'll come to the complication. Yeah, there is 2-3 recently level 1 evidence that the infection rate is probably similar. But I don't want to be antibiotic accomplice. If you see all these studies in transrectal, they have given antibiotic prophylaxis, whereas the transperineal biopsy, they didn't get any antibiotic. So the complication rate in transperineal biopsy in the preventile is 0% versus 1.4%. If they could have taken another 100 patient, then probably it is the p-value is just 0. You can see the p-value is 0.059. So just 100 patient, if they used to take for the transperineal arm, this was definitely significant. The cancer detection rate is better in transperineal biopsy. And there is a Texit 2020 movement in Europe. And what they said that you cannot just take care of all the poop using enema. You cannot make a sterile rectum. That's fine. And all the whole Europe, they have moved to transperineal biopsy. There is no transrectal biopsy in the Europe. So pro-piscitile, as Siddharth said, the transperineal biopsy having a similar infection rate. If you see the study protocol, they have allowed liberal criteria to define the infectious complication. Any fever, 99-degree fever is they consider as a complication. So by applying a stricter definition of the infectious complication, reported rates are in favor of transperineal biopsy. So pain, yeah, there is slightly worse pain. That's no doubt. But if you see the European guidelines, the guidelines strongly favors transperineal biopsy is the first choice on the basis of all the meta-analysis of randomized as well as non-randomized control trial. You can see the transperineal biopsy has less infectious rate in all the meta-analysis and systemic review. So there is a cost of luxury that I agree. The expense, pain, if you want to drive Mercedes, so you have to pay a cost. Otherwise, you can drive Alto. That's your choice. So those who are doing transperineal biopsy, they said needs an operation room, needs general anesthesia. It's painful. I think infection rates are equal. I only know how to do transrectal biopsy. And I believe all of the above are true. But I believe lower infection rate with transperineal biopsy, no fear of readmission. Patients are happier. Sometimes if you give G rather than putting a large probe into the rectum, I can do it in local anesthesia. I would earn more. And I believe all of the above. So every approach deserves a respect. It's your choice. You want to be straight or you want to be perverted. I'm admitting my defeat. कभी कभी हारने के लिए जीतने के लिए हारना पड़ता है. Thank you.
Thank you so much, Dr. Surekha. Any comments from the floor? Any quick comments?
Yeah, I would like to ask Surekha, what is the total cost of the equipment needed for transperineal biopsy?
It depends on how you are doing. If you are doing a,
I'm not asking from patient. I'm asking how much the hospital is going to spend for all the equipment.
this is what I am saying. It depends on what approach. If you are using a grid and transperineal fusion biopsy with MR fusion, then the cost is the incurring cost of the machine is approximately 2 crore. But if you are doing a freehand biopsy, the additional cost is not very high. It's negligible.
So most of the hospitals, apart from public hospitals, are not going to spend that much money for just biopsy.
But
Yes, I'm
we
sure.
can do in local anesthesia and freehand biopsy. That's upcoming and evolving with time.
So what I would like to have from this debate, what is patient friendly, what is urologist friendly, and what is hospital friendly? That points, if we cover, that will be very good. Interesting debate.
When laparoscopy started way back, that time laparoscopy was very costly and no hospital wanted to have a laparoscopy. Now without laparoscopy, no hospital will survive. And the robot, so it's evolved with time. Once the more people will use, the cost will come down. Thank you.
I think one of the major advantages of the transperineal biopsy is you can target the anterior zone much more efficiently as compared to the posterior. So patients who are having low PSA, patients who are having a anterior lesion in the MRI, or where no lesions are discernible on the MRI, these are patients who are automatic choices for transperineal.
Okay.
Something cost
Thank you.
difference.
Thank you. Thank you, sir, for chairing the session. Now we move to the master talk of the day by none other than Dr. Mallikarjun. And for this session, may I invite Dr. Pankaj Maheshwari, Dr. Sailesh Shah, Dr. Atul Mittal, and Dr. Sameer Trivedi to kindly chair the session. Okay. Okay. अब देखो See now? Yeah. Ready?
Hello. Dr. Mallikarjun doesn't need any introduction to this crowd. He is a past president of Urological Society of India. And if I consider he is the most academic president up till now I have seen, and recently I was a witness in urethra at the rate of INU, and it was a wonderful workshop where robotic master was talking about urethra. I said he should not do, then what we will do, because we are doing urethroplasty. But he discussed for entire conference about the different cases. Let us listen to him about post-prostatectomy incontinence decoded. Dr. Mallikarjun.
Thank you. Thank you, Shailesh. There's nothing, I think there's nothing master of talk of this nature. This is basically revisiting the anatomy of what we had. Am I getting the thing? This guy has got a problem here. Hello? Yeah. No, it's coming and going. I got it. You got it? मेरे पास आ गया, आपके पास है? आज है यार, मतलब नौकरी हो गया। इसको क्या है? नहीं यार, वो तो अभी ऑन हो तो। हाँ हाँ, अब तो मतलब तो पहले तो समझ रखा था आपने। वन में था। हम्म। अभी देखो आए थे, अभी लगा। आए क्या? ओके। Thank you for the sorry for the inconvenience. Anyway, this is not a master talk about this, basically revisiting the anatomy, because we started having understanding the anatomy of the sphincter and everything much more better after we started robotic radical prostatectomies. All the first 2 decades before 2000, everything was looking at anatomy through the urethra, because incontinence after TURP was a major issue. But after 2000, what happened? Everybody started doing radical prostatectomy and there is incontinence. So we started revisiting ourselves how the sphincter works. Let me ask one question. How many still believe that there is something called internal sphincter, which is there at the bladder neck area, and an external sphincter outside? Internal sphincter is for passive continence and an external sphincter is for voluntary control or an active conference and stress. How many believe it still? Fine, fair. I think that's a traditional teaching, what we have been taught all these days, right? It says internal sphincter and an external sphincter, right? So the internal one is for basically passive and the external one's for active. If that is the case, if US is for active continence, how do you explain passive continence after a TUR or a radical prostatectomy? How can there be a passive continence? That means at rest also he is continent. Basically, we left with an external urethral sphincter. Why he is having a passive continence? Why resection beyond verimentonum leads to incontinence? Are we damaging the external sphincter? How can we reach external sphincter from inside the urethra, cutting into the muscle and getting into the external sphincter area? The ring we see endoscopically, which we all see as an external sphincter, is it the external sphincter? Actually, no, it is a perineal membrane. Why are we looking at it and saying that this external sphincter is great? Why passive is absent but active is present in some cases? Like you do a TUR, the guy goes home and says he is incontinent. You'll come back, you ask him to hold, he's able to hold and nothing is leaking. And then again you leave him, everything leaks. And you say you continue your perineal exercises or pelvic floor exercises. Is it relevant? Is it the correct way to do it? Let us say if the stress incontinence is going to be there if there is no external sphincter, why the patients with a transpubic urethroplasty where the pelvic floor is destroyed will still have an active continence? He doesn't leak all the time. SUI is not every patient who had a TPU will not have an SUI in all the patients. They don't. Why? How can they be? And incontinence after TUR and incontinence after RRP, both are entirely different processes, and how we'll understand that now. Let us look at embryology. If you look at embryology, You start with whatever it is, cloaca and a urogenital septum, and you realize that there is a bladder and a urethra which is being developed. What was there? There was a detrusor muscle which is developing from the mesenchyme here, urethral muscle which is developing from the mesenchyme here, and the prostate never existed at that point. Prostate develops later as a gland there, and over a period of time, prostate enlarges posteriorly more because it is fixed anteriorly by the fusion of endopelvic fascia and the puboprostatic ligaments, which will not allow the anterior portion of the prostate doesn't grow faster, and the posterior part goes much, much more. So anteriorly it is less, posteriorly it is more. So what will happen is something called detrusor, and this is a smooth muscle which is there all around the urethra, and this is a scale rhabdosphincter which is there in the membranous portion. With the prostate growing, this is an external urethral sphincter apron on the prostate, and this is a detrusor apron on the prostate. Because the prostate starts growing in this fashion, and posteriorly it is deficient because the prostate grows much more there. So let us understand that this is the anatomy which we are understanding at this point. The density of the smooth muscle is very high in this area, and that is the reason why we call it as an internal sphincter. The density of the rhabdosphincter is more here. That's the reason why we call it as an external sphincter. Let us look at sphincter anatomy again. If you look at in the perspective of the radical prostatectomy, you have a urethra which is surrounded by a smooth muscle, inner longitudinal, inner circular and outer longitudinal layer, the reverse there, and a rhabdosphincter which is there, which is getting attached onto the perineal body, and a pubourethralis muscles which surround both of them, coming across, surrounding the urethra again onto the perineal body. So let us remember this thing. The same thing with radical prostatectomy. We call about so much of nerves all around the urethra. This is the smooth muscle around. This is the question of this is the rhabdosphincter which is there around, and this is the pubourethralis which inserts onto the median raphe, and the nerves which are going there posterolaterally and all around the urethra at this portion. In fact, in radical prostatectomy, the watershed area is this. Everybody tries to preserve the neurovascular bundle here, ignoring this area, which is the main reason for, so preserving the nerves here is of utmost importance. But anyway, that is not relevant. We are talking about BPH surgery today. So if you look at sphincters of the urethra, you have inner smooth muscle sphincter, which is a cylinder around the urethra, vesical orifice to the perineal membrane. That's a functional urethral. The complete length is called functional urethral length. And the main part is at the vesical orifice. That's the main density. Whereas rhabdosphincter is most marked around the membranous part, as I said before. If you look at the same thing in a robotic view, this is that smooth muscle. This is the skeletal rhabdomuscle all around it, longitudinal and circular fibers. So you see the same urethral anatomy being done on a robotic. That's a Muller ligament and a US apron. That is the external urethral sphincteric apron, which is coming onto the apex of the prostate, which is being separated away from the prostatic anterior prostate of the prostatic surface. And it is much below the DVC. DVC is not even seen here. What you see here, DVC is much above. And this is the external urethral sphincteric apron, which is covering the prostatic lower part of the apex, and that is the actual prostatic urethra inside, which is showing the smooth muscle there. So this is the prostate, that's a smooth muscle, and the external urethral sphincteric apron. Why did I show this? The relevance comes now. So if you look at the sphincter function, you have 4 functions of the sphincter. 1, passive continence. At rest, the person is continent. Number 2, active continence. Whenever there is a little stress, cough, sneeze, there is a continence. Number 3, voluntary interruption. The guy is passing urine, wants to stop. He's able to stop. That is voluntary interruption. 4, ejaculation. Forget about ejaculation now. We look at the first 3 only now. So what prevents incontinence in any person? Number 1, a good mucosal coaptation all around. That's necessary. Number 2, a smooth muscle intact and of sufficient length. Number 3, the rhabdosphincter, the fat switch fibers to act during the times of stress. And number 4, levator ani muscle. So the 4, leave alone the mucosal coaptation. If you look at the 3 muscular components, lysosphincter, that's a smooth muscle sphincter, rhabdosphincter for a little more stress, and number 4, levator ani for doing the voluntary interruption whenever they want to stop passing urine. So clinical situation, if you look at, continence at rest is basically by the smooth muscle, which is extending from the bladder neck down to the perineal membrane. So what matters after the prosthetic surgery or a TURP is that amount of that functional urethral length which is available below the verumentanum up to the perineal membrane. That is that length of the functional urethral length which is important to maintain continence at passively either after TUR or after a radical prostatectomy. It is not the external sphincter or rhabdosphincter or the levator ani muscle which is important, but is that functional urethral length which is below the verumentanum which is of utmost importance. And the active continence also to certain extent is by that smooth muscle sphincter only, not by your external sphincter. Active continence also, as I said, in a patient who underwent a transpubic urethroplasty, he still has a active continence because of the lysosphincter existing in the proximal part of the urethra rather than the distal part of the urethra. So external sphincter or EUS or the levator ani muscle part, it will be a part of the whole process, not the complete part. So intact smooth muscle sphincter and a functional urethral length is at utmost importance for the passive continence and to a part of active continence also. So how does the active continence, if you want to have an active continence when there is a cough or a sneeze, what will happen? I showed that diagram wherein the rhabdosphincter goes on to the median raphe and the pubourethralis muscle comes onto the median raphe. So what will happen? The rhabdosphincter contracts and compresses the urethra posteriorly. That means anterior to posterior force. This is it. And the puborectalis contracts anterior towards posterior to anterior. So the two coaptation forces, one going posterior, one going anterior. That's how a voluntary interruption or a severe stress incontinence can be prevented. So active continence, what is important, which is going to be necessary after radical prostatectomy, is going to be because of these two forces. So in a radical prostatectomy, having this EUS, that is external urethral sphincter, rhabdosphincter, and the pubourethralis muscle intact is necessary to prevent SUI. Whereas in TURP or any other transurethral surgery, those two elements are never going to be touched. So what is lost in TURP is going to be the functional urethral length, which leads to a stress incontinence, not the external urethral sphincter or the pubourethralis muscle. Understood the components? So the active continence is by two components. One is smooth, another is skeletal, that is rhabdo. The rhabdo is damaged in radical prostatectomy. The smooth is damaged in the routine transurethral surgery. So this is what I said in this essay. So learnings what we have, what we require to have is going to be a good functional urethral length that is adequate smooth muscle sphincteric length available from the bladder neck down to the perineal membrane, whether it is the distal part which is active or the proximal part which is active, doesn't matter. Proximal part is active in transpubic urethroplasty, distal part is active in the radical prostatectomy. So if good functional urethral length is mandatory to prevent it. Reinforced active is voluntary interruption is by the rhabdosphincter and the pubourethralis. What happens in large glands? We talk about large glands where it extends beyond the veru. What happens? There is a distal migration of the fibers and it becomes the length of the functional urethral length below the verumentanum becomes small. So any small injury, a 2 millimeter injury, after refashioning, it becomes a 0.5 centimeter loss of smooth muscle. Suppose if the functional urethral length is only 0.5 centimeter or 1 centimeter there, you lose 0.5 centimeter in it. Even it remodels itself, there is a significant loss of the functional urethral length. That's the reason why large glands have a chance of incontinence in these patients. So let us look at a large gland. This is how it looks. This is what the gland pushing away. We see this as the external sphincter, but the actual sphincter, what you'll measure is going to be from the verumentanum till that level. So that whole length, which is the functional urethral length, which is going to be left alone after the TURP or a transurethral surgery, is of utmost importance. That's a large gland, what we just saw. And then incontinence in prostatic surgery, say BPH surgery, I would say, is a urethral sphincter insufficiency. That is a short
mid-urethral length, that is basically that functional urethral length, and surgical trauma to the sphincteric muscular structures transurethral. We are not talking about radical prostatectomy here, so we are not talking about the rest of the 2 points. So what causes incontinence in TUR and enucleation? Number one, the smooth muscle loss. Number one, because thermal or resection injury. Tear during acute angulation at the bulbomembranous junction, or mechanical stretch because of enucleation procedures, which may cause damage to the smooth muscle. Loss of mucosal integrity and bladder dysfunction with overactivity is the next to the 2 points, not relevant to the talk what we are having. So what is that loss of lysosphincter? See this, that's a sphincteric, that's a perineal membrane you're talking about, and see the amount of smooth muscle loss from the verimentanum down to that perineal membrane area. So the whole smooth muscle, which is supposed to be there, has limited only to few millimeters just above the perineal membrane. Just that is a perineal membrane, and the whole smooth muscle on either side is lost. So that is what happens whenever there is a gland going beyond verimentanum and you start resecting, the whole functional urethral length becomes smaller and smaller and smaller. So that smaller length will lead to incontinence in these patients, especially stress incontinence. Don't think that it is only complete incontinence, stress incontinence also. See this, if you resect it, what will happen? This whole thing is resected. Preserving this length is of utmost importance. If you start resecting and resect right up to this point, you are left with only the small length of the functional urethral length, and this amount of it is lost. That is the basic reason why we develop incontinence in any of these large glands. Anterior commissure tear. If you look at anterior commissure tear, see this, the similar time you resected, and because of the anterior commissurotomies, which is there, the whole mucosa slides, and sometimes even the muscle also is going to be taken away. They do heal and they may recover. So that's the reason why people develop immediate incontinence and then recover over a period of time, because the healing happens in those patients. So types of incontinence, what will happen after prosthetic surgery? Total, exertional, that is SUI. I'm not bothered about the rest of the two, which has got no relevance. One is a cough associated detrusor overactivity, CADO, which has got no relevance to the present day discussion. So how to prevent incontinence? Number one, mucosal incision at apex so that an adequate length of the smooth muscle is to be intact, deep enough to prevent a repeated shearing trauma by the sheath, relatively more proximal at roof compared to floor, because the whole length of the area is going to be much higher in the anterior aspect. Avoid thermal injury near the region of the sphincter. Perineal erythrotomy at the time of angulation. This is a mucosal incision at the TUR. We give a small, this is a perineal membrane, and you start making a marking, and so that you don't damage further. That is a marking deep enough into the mucosa and into the smooth muscle. In an enucleation, a similar process. Give a mucosal incision and see that it is divided, and see that amount of the thing which is going to be retained, and go more proximal in the anterior aspect of it. And coming to the resection and preserving lysosphincter, see both the videos wherein you have resected, and see that you're trying to retain as much length of smooth muscle as possible up to the verimentanum. You need to scoop the tissue out behind that muscle so that the length, make the effort of scooping there, so that very small chips, scooping chips, so that the length of that whole cover across onto the urethral plate or urethra is going to be retained. So that is how to prevent a loss of smooth muscle. See this, length of it is being maintained there. So that is important. Perineal erythrotomy, sometimes you will not be able to enter the bladder also. These cases are large glands. Your sheath is smaller. You're not able to enter the bladder. What are you going to do? There's a way of doing it, which we used to do, and I still commonly practice nowadays, is perineal erythrotomy. You just see the bulb, make a small incision onto the perineum guided over a bougie, and pass your scope onto the bougie and enter the bladder. The other option is going to be a robotic simple prostatectomy like what we did, and that is the way, and you finish the job. You don't need to put any stitch there. You put a urethral catheter into the bladder. It doesn't leak after 3 days. Take it from me. It doesn't leak after 3 days. Take it from me that way. There's no doubt about it. Scopy after an SUI. See this post-TURP scenario. How does it look at the end for a severe stress incontinence? You can't see the mucosal coaptation. You see a external sphincteric area, but there is a loss of mucosa. They are completely lost. See that? So there's a significant stress incontinence. And total incontinence, you see a completely damaged mucosa, complete no coaptation at all, and the completely damaged mucosa. That's how it looks going to be total incontinence. So whatever we call it as a sphincter rehabilitation after transurethral surgery is only reinforcing the rhabdosphincters and the skeletal sphincters. Nothing can be done to the smooth muscle in this fashion. So retaining a length of the smooth muscle is going to be at most importance. The strategies are only to compensate for any loss of smooth muscle function and striated muscle after prostatectomy. So all these measures, what we do as a pelvic floor muscle training is only to reinforce skeletal muscle, not anything to related to smooth muscle. So please leave the smooth muscle intact, in which case you will be able to have good continence at any point. The functional urethral length of 1.5 centimeters is necessary, whether it is post-TUR or a post-radical prostatectomy to prevent incontinence. Thank you very much for the opportunity.
Great talk, sir, as usual. I leave this, ask the audience to, if they have any questions.
I think I cannot be questioned because that's an anatomy existing. It's not my creation here. I cannot, so I don't own any of that. What is existing, I said, that's all. The only thing is we need to have an interpretation. That's
It's a brilliant compilation of the anatomical data. It's a great learning experience.
But one suggestion, this type of brilliant lecture with explanation, with video, should go to each and every DNB and MCH student's hand. Thank you.
Thank you, sir.
Very thought-provoking. Thank you.
Thank you, everybody.
Thank you so much, sir. We will now take the last session first because of the logistical issues. And now we have seen that there are some horror stories also associated with the BPH surgery. And this session is also about the same horrors. And to conduct this session, we have Dr. Pankaj Maheshwari and Dr. Rahul Gupta as moderators. And may I invite Dr. Puneet Agarwal, Dr. Kim Maman, Dr. Amar Kumar, and Dr. Mallikarjun Reddy to please take the dais and conduct.
Yes, Pankaj, as usual, you are the opening batsman. You're going to give us a presentation of the complications of pull-up.
Thank you, sir. Friends, let me remind all of you, today is Guru Purnima. Let me take this opportunity to wish all the teachers and gurus in this audience. I thank North Zone Urology for this invitation, Punjab Urology Association and Amritsar Urology Association. Last 2 days indeed has been a huge learning experience. Friends, complications are a part of our day-to-day life. Any surgeon who says he has not seen complications either doesn't operate or is a big liar. Complications can happen in every step of the procedure. They could be intraoperative related to enucleation and morcellation, perioperative, and there could even be long-term consequences of the surgery. As I had shown in my first case yesterday, capsular perforations can happen. Usually capsular perforations are small because we are working at the capsular level. Whenever you try to touch the tissue by laser, there is a definite chance of perforating the capsule. Usually small capsular perforations have no long-term clinical significance. Luckily, persistent bleeding in HOLEP is extremely rare. We would be worried about this bleeding because if there is significant bleeding, this would not only hamper our procedure, but would also hamper the morcellation, which is the next second part of the HOLEP procedure. Bladder injuries again are very, very rare, would happen most common during morcellation. Morcellation malfunction, although cannot be called as a complication, but definitely for the patient because the procedure needs to be staged, he would be unhappy and would consider it as a problem of the surgery. Urethral stricture and bladder neck contractures can happen in any urethral surgery, are also part of HOLEP procedure. Incontinence is a definite possibility. It was one of the reasons why initial adoption of enucleation procedures was very low. I'm sure after today's talk, we know how to prevent incontinence. Thanks, Dr. Malikarjun, for this. Regrowth after enucleation is rare. They say that the risk of regrowth is probably less than 1.5% at 18 years. What is one of the sure shot way of preventing or reducing complications is choose your patients well. Though guidelines may say that any size of prostate can be removed and HOLEP is a size independent procedure for BPH, more than guidelines, what we should understand is our grid lines. What is best I can do with my experience. So if in your grids, you are in a learning curve, you will not be able to manage more than 60 grams, so be it. In today's time, anything more than 180, 200 grams, because I have access to robotic simple prostatectomy, I would probably choose that over enucleation. Also, remember the one not to do. In your initial learning curve, do not choose patients who are on anticoagulants. In your OPD practice, remember to check the patient's hip movement. Can you abduct the hips well? In HOLEP, a good space is needed between the hips. So unless a patient can be positioned well, this procedure would be very difficult. Special situation, patients on anticoagulant, the risk of bleeding will be higher. Whenever possible, I would want to stop them. If I am forced to do them, I would do this procedure at low energy and low frequency. Concentrate more on hemostasis. Always keep a three-way catheter for probably a day longer. Detrusor underactivity is no contraindication, but in these patients, I would keep a consent of prolonged catheterization post-procedure. Channel HOLEP can be done. Good planes are found even in cancer prostate patients. And as we have seen yesterday, redo surgeries, especially after TURP, can be done because most often the planes are very well preserved post TURP. And for redo, HOLEP turns out to be a very, very good procedure. So a review of a large series of complications, 57 studies were looked at. All types of complications have been reported. One thing which would interest us most would be that urge, transient, and permanent incontinence is very low, probably all combined much less than 10%. Such serious intraoperative complications, although are very, very rare, this is a picture I have taken from the net. But yes, if we are not, cognizant of such events can happen. One of the common thing which people say is that HOLEP takes a lot of time. Yes, in your initial learning curve, this would take time. But as you grow in your learning curve, the amount of tissue removed per minute is much higher with enucleation than with TURP. About 30 to 40 cases would be needed for your learning curve. So in your initial maybe 40, 50 cases, don't choose patients more than 40, 50 grams. Try and choose patients who have a associated median lobe because removal of median lobe by a 3-lobe technique would be easier. And once you are beyond your 50 cases, then you can gradually step up the cases that you do. The reason for prolonged procedure is that you get lost in tissue. Now, as I said, removal of median lobe is easy. It is at the lateral lobe that when I'm trying to come from above and go up from below, if the two planes do not match, I would get lost in tissue. And this was one of the initial, very important problem that I faced initially when I started HOLEP way back in 98. Luckily, I had a chance to go to Professor Peter Gilling for my SIU fellowship. And when I had gone there, I had gone with a single agenda to learn how these two incisions, the roof incision and the floor incision, needs to be joined. The simple tip here would be identify the capsule and try to stay on the capsule. This is what I had mentioned in my procedure yesterday, that I try to convert the lobe into a mushroom. So once I undermine the lobe from both the sides on the capsule, the attachment of the adenoma to the capsule becomes small. And once that attachment is small, I can see it in a single field view. And then joining these two from one capsular side to other capsular side becomes easier. So stay on the capsule, try to start again from where you have identified capsule. Again, in HOLEP, it is very important to go back, means retract towards the verumontanum, see the adenoma from far, see where you are in a difficulty, see where you have identified the capsule, and restart from there. If you have created too much mess, all of us are good in TURP, you can definitely convert to TURP. Again, one more important thing we need to remember is the prostatic floor is not straight. It turns upwards as I move towards the bladder neck. So once I'm near the bladder neck, it is important to dip down my scope so that my laser energy is directed upwards. I don't go straight. If I go straight, I would cause subtrigonal perforation. Bleeding is very, very rare. Most often bleeding can be controlled. Bleeders up to 2 to 3 millimeters can be coagulated with laser. As if you remember in my second case that we were doing yesterday, when I was trying to enucleate from medially, there were few big bleeders which I could not coagulate. So in that time, move laterally. Once I move laterally, the adenoma gets pushed medially. The weight of the adenoma itself would cause compression on these bleeders. And when you come again there after some time, those bleeders would not be seen. But having a good hemostasis before you start morcellation is extremely important. If your view is not clear, you have two options. You could take a roller ball, coagulate the fossa, and then do morcellation, or put in a catheter, let the bleeding subside, come again after 48 hours. That time, not only the field will be clear, but the tissue would be soft and morcellation would be much easier. Sometimes you see such bleeders which are extremely difficult to coagulate. The more you try to coagulate them, the bleeder tends to increase. You can sometimes see the vessels which is causing the bleeding. And when you try to coagulate this vessel breaks and the bleeding starts from some other place. So patients go back and see the feeder vessels, try and coagulate those feeder vessels. In the end, try to see the lumen from where the bleeding is happening and coagulate inside the lumen. So focusing your laser beam inside the lumen is extremely important. That is how you would stop bleeding. Again, when you want to create hemostasis, step down your energy as much as you can, reduce your frequency, increase your irrigation, go near the bleeder, see the lumen, fire the laser inside the lumen. Again, electrocautery is there, always there to help you if you are in difficulty. Small capsular perforations, very common and usually do not alter your treatment. But if the perforations are large, as in this case, then there would come a problem as to how to proceed. Now, this was a patient where a large capsular perforation happened. The enucleation was complete and there were large tissues remaining in the bladder. The problem is that when I'm doing morcellation, I would want to step up the irrigation. My outflow would reduce. So intravesical pressures would be higher. And through such large perforations, there would be a significant intravasation of fluid. I have seen patients having abdominal distension because of the large perforations. In this situation, my decision will be based on two things. Have I controlled the bleeders well? Yes. Is the enucleation, morcellation going to take a short time? Yes, then I proceed. If no, I would put in a catheter and come again another day. So the best way to put in a catheter in this is the catheter should always be placed over a guide wire, because there is a tendency that your catheter can go through this perforation extraprostatic. I have seen this once in my career where I have placed a catheter, and when you are trying to do a bladder wash, nothing comes out. Realize that the catheter had gone out through the perforation. The commonest reason for capsular perforation, I feel, is blunt dissection. Try and avoid blunt dissection. We have an excellent tool, energy source. Once you land into a mess like this, really there is not much that can be done. Put in a wire, place a catheter, give the patient rest for a few days, come again later on. Probably next time, I would be more comfortable doing a TURP and making a good channel rather than attempting enucleation again. Bladder mucosal injuries possible. More often happens during morcellation. More often happens when you use luminous type of morcellator where it's a tube in a tube morcellator. With oscillating morcellation, this risk is very, very low. Again, we compiled the patients who presented to us with clot retention in the post-operative period. Means on table, I found the urine was clear. I had to do a clot evacuation. Of the 11 patients, 10 had a missed mucosal injury in the bladder. The mucosal bladder injury is again very, very interesting. The standard teaching is that bladder injury stops when the bladder collapses and increases when the bladder is open. The mucosal injury post-morcellation is reverse. When the bladder is full, because the bladder pressures are high, these venous mucosal injuries would get collapsed and you won't see them. It is only when you empty the bladder that you would see this bleeding. So more often when I'm doing a scopy, I won't see these bladders. But when I put in a catheter and come out, the urine tends to become red. Go in, look carefully, see whether there is any mucosal bleeder there and coagulate them. Fluid absorption, again possible, more often related to capsular perforation, more often happens during the morcellation phase. If it happens intermittently, say, if I land into capsular perforation, I would instruct my anesthetist to reduce the fluid, to give diuretic, keep a watch on the patient's blood pressure and hemodynamics. Intermittently, I would keep a watch on patient's abdominal distension. Whenever I feel I am creating trouble, put in a catheter, wait, come again another day. Now, ureteric orifice injury, possible. I have seen and done few. Now, this was a patient at the end when I was starting morcellation. I saw that there was blanching or burns, superficial burns around the orifice. More often, they heal very well. All I need to do is put in a catheter for a ureteric catheter for a few days. So I kept a ureteric catheter, kept the Foley and ureteric catheter for around 72 hours. In long term, this patient did very well. I distinctly remember one patient here where I was doing a bladder neck incision for a post-URP bladder neck contracture. I could not enter the bladder. So from the prostatic urethra, I started taking cuts, went inside, could not see the orifice, placed a catheter, came out. Post-op, this patient landed into anuria. He had a solitary kidney. When bladder neck contracture happens, the ureteric orifice tends to get pulled towards the bladder neck. And if you are doing a blind cut through the prostate side, you would not know where the orifices are. So now my suggestion here is create a small space, try and take a cut at the roof first, go in with the ureteroscope, assess where the orifices are, and then start taking incision. Probably a single 6 o'clock incision will be much better than trying to take 5 and 7 o'clock unless you identify the orifices and keep them away from harm's way. During procedure to prevent bladder neck or ureteric orifice injury, my tip would be that when you are near bladder neck, switch off the outflow, let the bladder fill. When the bladder gets filled, the orifice tend to move away from you. Your risk of injuring the bladder ureteric orifice will be much less. Clot retention, I have already said, most often happens because of morcellation injury. Now, infections. Infections post-HOLEP are extremely unusual. I tend to feel that the post-prostatectomy infection is related to the amount of necrotic tissue you leave behind. Because in HOLEP, we are working at the capsule and most of the tissue is removed, post-op infections are very, very uncommon. There would be a chance of getting patient coming back with epididymoarthritis. That happens in around 2% patients. That happens more often in very large prostates, diabetic patients, or patients who tend to overexert for their urine. But otherwise, postoperative cystitis or UTI is not very common. Need of catheter, prolonged catheter. Even in patients who do not have underactive detrusor, there is a theoretical possibility. What happens is during morcellation, my inflow is on. When a large tissue sits on my morcellator blade, the outflow temporarily stops. So the intravesical pressures tends to rise significantly. We did a study where we assessed the intravesical pressures during morcellation, and for a prolonged period of time, the pressures may go higher than 100 centimeters of water. With such high pressure, there could be a temporary hypotonia that happens, and patient may need prolonged catheter. Again, most of these patients with, one attempt of catheter for around 10 days would pass urine well. Infections, I have said, are very, very unusual. Bladder neck contracture and urethral strictures can happen after any prosthetic surgery, can happen after HOLEP also. More common in patients who have had previous long-term catheter. Now the new technology which has come up, which is MyLab, where a smaller sheath is used, the risk of urethral stricture and bladder neck contracture should reduce. Overall incidence is much less, probably less than 1%. I would not dare talk to you about anatomy of incontinence that has been discussed very well in details. All earth stress and total incontinence has been described. The good thing is that most of this incontinence reduces with time. It is very unusual to have a patient who is incontinence beyond 3 months. What are the factors that I consider? These days, I feel it is nearly possible to predict which patient is likely to land into incontinence. A very elderly, frail patient with a large prostate, uncontrolled diabetes, my prolonged procedure. These are patients I would keep them, say, mentally ready that he's likely to have incontinence. These are patients where I would try to encourage them to do pelvic floor exercises before I start the procedure. But when a well-selected patient, the risk of incontinence would be negligible. Preoperative pelvic floor strengthening and temporary anticholinergics would help in a lot of patients. Erectile function is usually maintained post-HOLEP. Morcellation is one part which again scares a lot of people away from enucleation. Because during morcellation, as I said, having good vision is extremely important. Now look at this patient. A very small tissue is there. My junior is trying to chase. Understand it here. His blade is no longer in view. Instead of morcellating, what he's seeing here is not exactly a tissue. It is the prostatic fossa. The initial view, which was clear, suddenly became red. That is when I was called back, saw that there was a rent in the anterior wall. All we did was put in a catheter for 7 days. It was extraperitoneal perforation, a catheter for 7 days. 7 days later, did the second stage morcellation. Patient is doing well on long term. So before you stage, doing a good hemostasis is important, and stage the procedure with catheter. Most perforations are extraperitoneal and would not need any intervention. Sometimes the tissue may be tough and may not break with the blade. Here, the plan would be either use a new blade or stage the procedure. Let the tissue marinate in urine for 48 to 72 hours, beyond which morcellating them will become easier. Beach ball is one very interesting phenomena where there are round, small tissues remain which keep on jumping off your blade. It is very difficult to get these tissues out. What we suggest is in these patients, it is important to slow down your speed of morcellation. Do intermittent morcellation. We know that initially, when I press the foot switch, there would be suction and then there would be cutting. So intermittently, I use suction to catch hold of the tissue and then morcellate. Small tissues can be picked up through the sheath or through the urethra. So predict or expect complications in older patients, patients who is having catheter for a long time and in your initial nerving curve. But once you are through the procedure, this is a brilliant procedure. Most often patients would go home in 48 hours and you would have a satisfied patient in long run. Thank you.
Thank you, Pankaj. Excellent talk, good slides and good videos.
Thank you, sir.
And one question really. Do you have, with so much of experience behind you, do you have any contraindication to do a HOLEP?
Sir, I have two contraindications for HOLEP. One is a patient who cannot be anesthetized and a patient who cannot be positioned. So if there is not enough space between the hips or patient cannot be anesthetized. These days, I have stopped doing it beyond 200 grams because there I feel a robotic simple prostatectomy would be much better. I would not spend excessive time in the urethra. Initially, I have done even prostates as big as 300 grams, but now beyond 200, I would better leave it for the robotic surgeon to do.
Sir, we came across one patient who had a urethral injury, sir, after HOLEP, and he had a large perineal fistula. So what could be the possible mechanism and how to prevent this? It was done somewhere else, so we could manage this patient. So what could be the possible mechanism?
Extremely difficult to say. I would
Sir.
Chale. Thank you so
Thank you,
much.
sir.
Thank you.
So next presentation is by Dr. Rahul Gupta on TURP complication. Dr. Rahul, please.
Thank you. Thank you, NZUSA. Thank you, Sopan sir, for having me. And after 2 master classes, I think whatever has been not been covered, I'll cover only that. So we start. Just before I start, forward कहाँ से होगा? नहीं हो रहा है. Complication हो गया है. Before I start. अब होगा? He is controlling from there. Yes. So we saw yesterday fantastic cases done by all the experts, and why they did not fail or why they did not have a complication was they stuck to the basic principles of TURP. Now, TURP, whenever I say it is like an appendectomy to a general surgeon, TURP is the one that differentiates a urologist from a general surgeon, and it helped our profession to grow a lot. If you do a good TURP, everybody would say, okay, fine, nothing big about it. You are a urologist, you are expected to do a good TURP. But if anything goes wrong, then it's a problem. Everybody wants to jump on you. So if you could see yesterday, all experts who were doing TURP, HOLEP, or whatever missed or whatever they did a cystoscopy first. So hardly takes 5 minutes. It is a good habit to do a cystoscopy before you start your TURP because that helps you plan the surgery. So what happens is when complications in a TURP happen, the patient's attendants, you don't know how to face them because a day prior you have told them, shown them the moon, and now you have done a complication. Or if the patient is a tube in the retroperitoneum, or you say that I want to go back after 3 days again and do it, it becomes really difficult. The hospital where you're working will not accept you not doing a good TURP or having complications in TURP. Now there is a CPA which is hanging down your neck, so that is also an issue. Your reputation is at stake, and your friends and colleagues, they will jump on it if you are not able to do a good TURP. So that is an issue. So the complications, as already discussed, may be intra, post, or perioperative. So the first complication is the bleeding. Dr. Maheshwari has shown a very good discussion and detailed discussion. So I'll not go a detailed discussion on what happens in HOLAP. I'll just talk about that bleeding is a complication of every surgeon. Any surgery you do, bleeding is one of the complications. And it may be a primary bleeding. Intraoperatively, invariably, you are able to manage. And post-operative, perioperative bleeding, I always explain my patients that first 2 weeks will be critical. If you get hematuria or you get clot retention, don't get worried. Come back, we'll take care of it. Because if you have not explained to the patient and he comes with a secondary hemorrhage, so there the attendants and the patients won't take it very nicely with you. So that is important. For large prostates, don't hesitate to keep the blood ready. Invariably, you don't need it. 99% you will not need it, but 1% you never know. So always prime them that you may need blood and you just keep prepared. That is more important. So does the use of energy source make a difference? No. So to sell bipolar, you should not feel that bipolar will not cause bleeding. No literature shows that bipolar is superior to monopolar over not having bleeding in TURP. So how do we approach when we have done a TURP and there is excessive bleeding? The primary bleeding is not an issue. You can manage with the good energy sources, with good camera systems, with irrigation available, the larger caliber scopes available, good irrigation available. It's not an issue. Issue happens when you have opened up a sinus, a major sinus. The important part is when to stop. That is very important. You can't go on chasing a sinus to stop a bleeding and create more mess around there. I don't know how many would have seen the packing of the prostatic fossa, but we have seen the packing of the prostatic fossa. If you have not seen, at least the older versions, because that time the cameras were not good, the cautery was not good. So we have seen in which you have to take out everything, do a cystotomy, pack the prostatic fossa, put an SPC and come out. It's because nothing else works when it is a torrential bleeding. So one should know how to pack the prostatic fossa and what to do. And after 48 hours, you can start just withdrawing that the packing. As it is a venous bleeding, it usually stops by its own. Perforation in TURP. Perforation has been nicely taken up by Pankaj sir, so I'll not go in detail of that. But this is one of the cases in which we have done it. The resident is doing a TURP, and you see he calls you that he's not able to proceed at all. You come and see, you do a scopy, and you see there is a big perforation in the bladder while doing a TURP. So what had happened is, this is the perforation. You can see it was the finger operated resectoscope. So he has not, as the basic principle, you always keep the loop inside the sheath. So what he had done was he was trying to adjust the camera system. And while doing that, the loop is into the bladder and somebody puts a step on the cautery pedal. and that has perforated the bladder. So this is the least you can, you can't even think that this can happen to a patient while doing a TURP. So you should be aware, and every time at least a beginner is doing the TURP, he should be aware that loop, the basic principle has to be followed, that loop should always be inside the sheath if you're not using the loop actively. So this can happen, and this is very, you have to explore the patient. You can't do anything else. It's a transperitoneal perforation. You have to explore and put a stitch, and it becomes very difficult to explain to the attendants why it was opened. So this is one more case. You have done a good TURP, and you go to the clinic, or you go back and you get a call that the post-operatively the patient is slightly uncomfortable, restless. However, the efflux is fine and hemodynamically he's stable, but he's having tachycardia. So first thing is that you don't ignore such a thing. If there's some experienced nurse is calling you, go back and palpate the abdomen. When I palpated the abdomen of the patient, the upper abdomen was absolutely soft, but the lower abdomen was, I was not happy with it, because with your clinical experience, you would come to know that when the patient is not well. So we had a bedside ultrasound. There was some fluid there in the pelvis, but not much. So when I took the patient back, because the irrigation was not working very well, as Dr. Pankaj said, you could flush, but nothing was coming out. Now, this is what had happened. So this is a classical subtrigonal perforation, and the catheter was placed blindly, which again, we would suggest that subtrigonal perforations can happen, especially in median lobes if you are over-aggressive in resecting. And so if there was a subtrigonal perforation, always and always, you put a catheter over a guide wire. Don't put a catheter like that. Put it over a guide wire. Give inflate the balloon and pull it up. Invariably, it will heal. You don't have to do anything else. But if the patient is not responding, then there is no harm in putting a drain there. So the perforation, the subtrigonal perforation, is very important to recognize. If it is in the beginning of your TURP procedure, you need to abandon the procedure. There is no discussion about that. Just take hemostasis, abandon it. Even in the middle of the procedure, you can still abandon it. Towards the end, you don't bother much. You just make it fast and put catheter over a guide wire. That is the bottom line. Don't put it blindly. So what can lead to a perforation is it is the excessive resection. And so the perforations are classified into threatened, covered, free, and subtrigonal perforations. The threatened or the covered perforations, which are invariably seen. Yesterday also, live surgery, we saw some minor capsular perforations. Don't bother for them. Just have a catheter and put a traction, they heal. But if there is a major perforation or leak, you have to either explore or put a drain. There is, you should not shy away from that, because that can make the patient unstable. So these slides have been borrowed by my dear friend, Dr. Arvind Ganpule and Dr. Rishi Nair. So there is a leak in when the patient gives a history that our post-TURP is having a leak from the rectum or passing fluid from the rectum. Rare, but a definite complication. What would you like to do? You do a RGU, MCU, cologram, colonoscopy, CCD, MRI. A lot of options are available in this. But the most important component is to recognize the complication. That accept that there's something would have gone wrong. Don't overlook it. If the patient is complaining, he's not complaining otherwise. He's complaining because he's not happy. Do an MCU. Don't accept this MCU. Always ask for a lateral plates, and the lateral plate will delineate a recto-urethral fistula, and that will show that why is leaking fluid from the rectum. Do a CT scan, because CT scan will definitely delineate where it is to show a fistula. And this is a cystoscopy picture of the same, in which a guide wire was passed through the fistulous tract. They could delineate it very nicely, and then it can be repaired. Here you will see there is the fistulous opening. So this is one more case in which, as somebody asked, there was a fistula in this. There was a urethro-scrotal perineal fistula. I believe this is more likely because of the over-aggressive use of the force. Then only this can happen. So TURP, usually it will not affect, it is not the current or something. It is more of a forceful entry, which is done in the beginning and it has been ignored. And that can lead to a fistula in case of the the scrotal fistula. What are the options for such fistula treatment? Conservative or surgical? How long should you wait? Do an open or minimally invasive, which is laparoscopic or robotic. There is nothing much to choose between the two. So what is the incidence? It is 0.5 per lakh per year. So it is not that you cannot have it. It is lucky that we've not seen it much. Doing just a colostomy and SPC with low residual diet does help. the open approach is the most preferred approach. You can do it transperineally, which is the most preferred approach to do it. And you have to follow the closure of the fistula, the principle that is two-layered closure of the urethra and the rectum. Suture lines should not overlap, and interposition is a must. And usually they heal well. There's not much of an issue. What was done in the case which was done was conservatively treated. A colostogram was, the colostomy was done, followed by an SPC and low residual diet. This is the post-operative lupogram, which at 3 months, which shows completely healed fistula. So they can heal by their own, by themselves also. So now a nicely done TURP, you're happy, everybody's happy. 3 weeks down the line, the patient comes back to you and says, I'm not able to pass urine as I was able to pass after the removal of the catheter. So what do you think? You have a stricture. Now this is an issue because the patient is not happy. How much you convince the patient that you have done a good TOR on him and it is not the surgery which is at fault. The patient is not happy because he's having either this a pinpoint stricture or a full length urethral stricture. So this is the cystoscopy of the patient in which the stricture is developed. So you can see there are multiple rings. This is being done with a ureteroscope. There are multiple rings in the urethra and you're not in a very good position because the patient is not happy. He came to you because he was not able to pass urine. He comes back to you because he's again not able to pass urine. So it can be instrument related. So it is very important for us to know what type of a sheath to use. It is a mechanical stress. How much is the size of the prostate? What is your competence levels? You can't sit inside for a longer duration in the urethra. It is very unforgiving organ. It will not pardon you. Similarly, the current and the cautery you are using, the instrument you are using, the loop you are using, all can make a difference in the outcome. So I'll just show that the monopolar versus bipolar, it is not much of a difference. If your sheath is faulty, you can develop stricture. Lubrication is the most important component. So whenever you're doing a large prostates, don't hesitate to open 2 or 3 jellies on the table and ask your assistant to go on putting jelly. And as you come in and come out, the urethra should be well lubricated. So infections can lead to urethral strictures. And one very interesting paper which I found was the use of the irrigating fluid in the post-operative period. They have found that the room temperature in the colder regions, if you're using a cooler solution for irrigation, that the incidence of stricture was much higher when we're using the warmed solution to the body temperature. So I have not seen it personally, but this is one of the things which was interesting. So I wanted to bring it back. So the scope, it is, we all know mini PCNL is better than the standard PCNL. Similarly, smaller scopes for Indian urethra are always better than the larger scopes. It is a known fact. Second point is, what is the technology used? Using a TURP, bipolar versus monopolar, it is not much of a difference. Rather, bipolar in some literature has found to be more hazardous. So choose, don't go by what industry tells you. Treatment is a buccal mucosa urethroplasty or end-to-end if it's a short stricture. So this is toward bladder neck stenosis, trying to attain very good hemostasis at the bladder neck in a small prostate can end up in this thing. Why I put up this case is there is no lumen at all. You can't see anything. So you cannot pass a guide wire here. So you don't know where to cut. So if you're not you don't have a good experience of doing a BNI or you're a beginner, I would suggest to put an SPC and go and have a, cut to the light rather than doing a blind procedure. But if with the experience, and you have done BNIs post this thing, you go at any way between 12 and 1, give short cuts, and you can enter into the bladder. Once you enter into the bladder, so as not to avoid the ureteric injury, have an inspection, and then you can start opening like a standard BNI you can do. This is not all. Sometimes you get complications which you don't even think about. I'll just show you. These are the 2 complications which I had, and I was very sorry for them because it is not a technical issue, but it is a issue of earthing in the OT. So you have done a good TURP, the patient comes 5th post-op day and he wants to remove the catheter, but he says, I have pain in the buttocks. You can't explain why do you have a pain in the buttocks. And when you see the buttocks, you can see this burn, which is not acceptable at all. So you really get surprised why this happened. And when you go back and you see what has happened is there was some earthing leak was there, which has led to the burn in the patient. So you don't feel good about it, but these are small things, and you should get your OT checked invariably for any earthing leak. And this is there is a stricture or there's a burn at the tip of the penis also. So this is also a technical issue. This is it's not a procedural issue, but it's more of a technical issue. This one last case which I'm going to show you is, I've never seen, but as you grow and do more surgery, you see more and more. I get a call from my boy that he says that there is a lot of blood at the tip of the meatus, and we always put a gauze. This is all wet with the blood. So I asked him, what is the efflux in the irrigation? He says it's absolutely clear. There is nothing there. I said, okay, fine. Wait for some time. It'll get fine. He gives me a call after half an hour again. I've cleaned. I've put a new pad. It is all red. So when I go there is a active trickle of blood coming by the side of a catheter there, and the efflux is absolutely clear. There is nothing. So I take him back for a cystoscopy, and when I'm doing a cystoscopy, what I find is there is a bleeding. A big spurter is coming from the urethra. I use Otis in all my patients, and I've not had this complication, but one odd day, I think it is because he had a partial erection. I'd opened up Otis more than what was required. I gave a cut, and once it is retracted, so this is the bleeding coming from there. So it was a very horrible situation for me, because I had never seen such a thing, and I'd never thought that a Otis can do this, because we have been taught that Otis cuts only the mucosa and not anything else. But the important part is how you technically use the Otis. So on an erect penis, if you open a Otis a lot and then you give a cut, you get into the spongiosum. So what was done was I took a rolly ball, put the cautery down, and I had to stop this bleeding, because it was a fresh arterial blood coming out. So very slowly and increasing the irrigation by asking somebody to press the irrigation, I just come down and I try to fulgurate with a Bugby monopolar. See, what happens is when you fulgurate with a monopolar, it opens up the mucosa more and it causes more torrential bleeding. So then I really got confused, but luckily I had a bipolar with me also. So what I did was I took a bipolar electrode and had a spray, and mode was a spray mode coagulation there. And I could get with the bipolar then. I was not able to get it with a monopolar, but with a bipolar, then I came with the bipolar and I could get that, and the bleeding could stop. And I was lucky enough that last follow-up was after 3 months of this procedure, and he did well. His uroflow was normal, did not get a stricture. I don't know why. I had expected that he will develop a stricture, but he did not develop a stricture. So these are very odd situations you can face sometimes. And we don't, these are really rare situations of TURP complications. So if you look at complications, the complications are bound to happen in any surgery. Nobody is perfect. You would have done 1000 TURPs and suddenly you get a complication which you have never heard of or seen of. You should be aware of it. So don't promise a lot of things to the patient outside in the chamber. Be aware that you may have a complication, then it should not be difficult to explain. So the take home message is complications happen to those who operate. Don't panic, because it is you have created a complication and you will have to face it. Take help. There is no ego. If you have not, there is somebody senior in the city, just give him a call. If this has happened, what should I do? Learn from them and don't repeat the same. That is the more important component. And surgery is learn to navigate, because it will never be a straight path for you. If you are lucky, yes, but it is never a straight path. Some days you'll have a complication which is not thought of even. Thank you very much. Thank you, NZ USA, to have given me lecture. Thank you.
Thank you, sir, for actually, it was literally horror moments. Few horror moments and horror pictures. Any questions from the audience?
Sir, this is regarding that Otis. Are there any guidelines how much that should be opened or anything like that? Or it's just the resistance we face?
No, exactly. See, it all depends what sort of a sheath you are going to use. If
26, normally 26.
26. So the thing, if 26, then you open up to 26, give a good cut, it goes easily.
And the second question, that's one more, sir. We have so many bipolar machines available these days, means the Olympus, the Stores, and many others, along with some Indian maids. Is there any regulatory body? Means we don't know which is actually a quasi-bipolar, which actually we should be using, means the patient develop a stricture after that bipolar. Can we attribute that to that the set we were using is not
I'll tell you.
approved?
See, don't be under this impression that the bipolar, I have bipolar and I have monopolar. I have been doing bipolar for the last 10 years. But believe me, the clot retention, the bleeding complications, the strictures, bladder neck contracture is no difference between bipolar and monopolar. If you have a good monopolar at your place, be with it. Don't, because the market is saying and everybody else is doing, don't jump to a bipolar. Regarding bipolar technology, I think it is there is no standardization as such. Everybody can get an approval in Indian market. It's for us to decide from our colleagues to understand which has given them results and use that machine.
Okay, so thank you.
But bipolar is not superior to monopolar.
Thank you, sir.
Yeah, you enjoy giving a cut with the bipolar. It cuts very smoothly, but it's not superior to monopolar anyways.
I like to make some comments, not this excellent lectures by both these speakers who showing the complications of HOLEP and TURP. In my practice, current practice, being a referral second and third opinion, patients are coming to me after the TURP or after the HOLEP. The problems is the symptoms, the lower urinary tract symptoms for which the patient has undergone the surgery. And after the surgery, they are more unsatisfied whatsoever has been done for them. It may be due to some complications or poor selection of the case. So two advice which I want to give. One is that preoperatively, a small prostate patient may have come with poor flow. They may be having a stricture already. What I see in the notes that at the time of TURP, they found a stricture, they have done OIU, they have done TURP. Simultaneously, preoperative diagnosis was BPH, post-operative diagnosis is stricture urethra. So a retrograde urethrogram should be done. Wherever you are in doubt, I think so better to do a RGU or MCU to delineate that the tract is normal or not. If you tell the patient beforehand you have a stricture, at least you are sure that it is not the complication of the TURP. The second thing is the hypoactive bladder. Anybody who has a chronic retention, more than 250 or 300 ml residual urine, please do a urodynamic evaluation before doing any procedure, TURP or HOLEP. And what is my practice is I do previous evening, leave a caster also, and next morning we do the procedure. If his detrusor pressure is normal, if it is not normal, then I can do a proper counseling to the patient that see you have this bladder function is not working properly. You may need some additional treatment to improve your flow, and you may not be able to void also after the surgery.
Words
So I
of
think so
wisdom.
it is better to teach our patients their disease first actually. For what you want a surgery, what my surgery can do. If you are very clear in mind, I think so you can avoid all these litigation.
So words of wisdom, sir. Words of wisdom.
I think probably NP Gupta sir has summarized what we need to do, but maybe I may add one line to what he said is when you have a doubt about the symptoms, it's rather better to overdo a urodynamic study rather than not doing a urodynamic study. Thank you, Dr.
Thank you,
Rao.
sir. Thank you.
Thank you.
Thank you, Chairperson, sir. We move on to our next session. This is actually an educational course being conducted by ISU, Indian School of Urology. And for this session, we have Dr. Arun Chawla, who is the past convener for the ISU, Dr. Mayank Mohan Agarwal, and Dr. Nikhil Khattar. Please take the dais. And before the session begins, may I announce that all the faculty and delegates who require the certificates and the faculty memento, they are available at the registration counter. The organizers have arranged the 8 hours of PMC certification, which is included in the certificate. So you can collect it from the registration counter. Over to you, sir.
Good morning. Am I audible?
Yeah, after such a dynamic session and sessions on very nice topics. So we will be conducting this course on urodynamics, which is not very dynamically interestful for most of the urologists, but we think that it's an important area for discussion. Unfortunately, Professor Chawla could not physically come, but he's available. So I'll request Dr. Chawla to kindly start the session, sir.
Good morning. Good morning. Am I audible, Mac?
Yes, you are audible, sir.
Okay. So good morning and greetings to all of you, and especially the happy Purma greetings to all the gurus and mentors and the teacher in every one of you. On behalf of Indian School of Urology, many thanks to Rishi and the leadership of Northern USI, Swapan Sood and the leadership of Jalandhar Urology Association for giving ISU the opportunity to be part of this program. So we have, as Ben has mentioned, that we have made it a 1 hour program, and we'll try to take basic to little more advanced things in this 1 hour so that everybody is aware of the concept of the use of urodynamics in the daily settings of lower urinary tract symptom evaluation. So I'll be talking about the first of all, the non-invasive urometry, and as everybody knows, The non-invasive urodynamic starts immediately when the patient comes to you. It is the careful history, the physical examination, which includes the focused neurology examination, the validated use of validated questionnaires, and the Euroflowmetry and the bladder diary. So I'll be focusing in my next 10 minutes about the Euroflowmetry, PVR, and the bladder diary. So it's a very simple and non-invasive initial investigating test, especially when the patient presents to us with voiding set of low unit tract symptom. It is nothing but just a graphic plot of flow rate against time with the estimation of various parameters. If you see the diagrammatic representation, the first picture on the top shows a Euroflowmetry graph along with some annotations which are the various parameters which we try to study during the Euroflowmetry. And these are the most important parameters which we always label it along with the Euroflowmetry graph: voided volume, the average flow rate, the maximum flow rate, the time to max flow, the voiding time, the flow time, the delay time, and interval time. It's important to spend a few seconds in differentiating voiding time and flow time. There will be some patients who will be not passing the whole voided volume in one go. There will be some main volume and some part of additional volume in the second flow. And this voided volume covers the whole of the voided urine. The flow time is the time which covers the main flow of the patient. So the voiding time is always more than if the patient has passed urine not in one flow, but an interpreted flow. This is important when we are calculating especially the various parameters. Now, if you see these various types of graphs, the first one on the top is a typical bell-shaped graph, which is a normal. And in various literature, if you see the different type of these graphs have been reported, which are indicative of some underlying cause of these voiding LUTs. The one is the prostatic, the plateau or staccato, or the fractionated or intermittent curves. If you focus on the first graph, if this is a bell-shaped graph, if you keep a hand and press it down, you will get the graph which are there on the in the middle. So one with the black line represents the prostatic, which is a compressive type of Euroflow graph, and the one with the dotted line is something like a constrictive, which is representative of a stricture. The other type of the graph which shows the curve going up, coming down, going up, and not touching the bottom line may be indicative of the dysfunctional voiding or the underactive reducer. It's very difficult to differentiate these two type of graph, one with the intermittency and the staccato curve, really from each other. But we need to keep in mind that these are representative of some underlying conditions. I'll skip this for the shortage of time, but what is more important is how you do a Euroflowmetry test when the patient comes to you. You need to explain the patient what is this test, seeks patient cooperation, try to give more privacy when you ask the patient to go. The where the Euroflowmetry is placed, there should be an isolated little bit of privacy ensured. And keep in mind the patients who are sometimes old with various post-stroke, post-CAA, Parkinsonism, their body movement should not affect the machine and get a graph which is erroneous and not fit for interpretation. And I always ask patient how you used to pass urine, and the same way the patient has to do the Euroflowmetry. It's important to rule out various artificial defects which can come because of the poor Euroflowmetry. Don't ask the patient to strain to get a good flow. Don't ask him to advise him carefully. The stream should go in the center. He should not cruise around on the funnel, and he should not press the meatus and the shaft of the penis while doing this. And I always ask the patient, was this act of flow was the same as you used to do at your home, because you need to have a widening flow almost similar to the one which you used to have at his home or in normal circumstances. And these are the various things which are not accounted. They can lead to various artifacts and probably lead to poor interpretation of the Euroflow. So ideal circumstances, we need to have volume of at least 150, preferably between 200 to 300. And whenever we have a voided volume 150, please repeat. And when you have a Qmax which is looking abnormal and not correlating with the patient history or the questionnaire which you have used, and you need to always repeat. In ideal circumstances, patients come with a full bladder with a sensation, you do the test and ask him to wait and have it to freeze over a period of 3-4 hours. You need another flow. It's important that whenever you have your flometry graph, according to good urodynamic practices, you have a scaling standardization. Any artificial spikes, whether they are positive or negative, are rounded off to get a smooth rounded contour of the uroflometry. And at the end of the uroflometry, you always give impression of first mentioning the maximum flow rate, then the voided volume, and then the PVR. The way it is written as 70/180/20, it means the Qmax is 70 in the voided volume of 180 with a 20 PVR. So this is the way in the end you should be over the after scaling down the all the artificial spikes, whether positive or negative, you give impression of the uroflometry graph and try to give some impression about the probable pathology. I'll skip this now. We all know that this is the various uroflow graphs in a one patient at different voided volumes. And you know that the voided volume of 50 and the voided volume of 710 in the varying graphs with the same patient. So how to know whether a patient comes just void 100 ml and then at one time he voids 200 ml? How to know that this the Qmax or PR which we have got really represents the actual, or how to predict that this is normal abnormal? So I like to bring this what Mank has published in his paper. If you have under root of Qmax, 100% of Qmax, it can be taken as normal. Same in this chart, if you have a bladder volume of 400, the under root of this will become 20. If you have a Qmax of 20, it can be taken as a normal, and 60% of this Qmax, that is 12, can be taken as a good graph. So this is a rough estimation in keeping in mind the varied volume patient will pass during the time of uroflometry. This is just a rough idea to take it as abnormal or a normal. I'll skip this for the shortage of time. This is the one which I was telling you. You take a Qmax in the first main flow part for the sake of description, and you will omit the last part of post-void ripple, which is not more than 2 ml per second in accounting the uroflometry parameters. Now, whether this exact uroflometry, if it is is more than 15, can I rule out obstruction? No. And if it's less than 15, can it predict obstruction? No. So any Qmax which is less than 15 cannot exactly differentiate between underactive detrusor and bladder outlet obstruction. So there has been a report of one study where they have used delta Q, which is the difference between Qmax and Q average. Now we all know that the Qmax and the Q average. Yeah. So we all know that whenever patient is having obstruction, the detrusor contraction power, the power of detrusor contraction will be maintained as compared to underactive detrusor, where there is effect on the contraction power of the detrusor. So if delta Q is taken, which is the Q max minus Q average, this will be low in underactive detrusor because the overall contraction is better. So you won't get a good Qmax, you won't get a Q average as compared to patient with bladder outlet obstruction, where the detrusor contraction is not affected, especially in the voiding phase. So this has been taken as one parameter by deducting two values from the uroflometry in discriminating the detrusor underactivity from the bladder obstruction in men with obstructing voiding symptoms. Another study has taken the same, the Qmax and Q average, in predicting the difference between the patient coming with the voiding LUTs in the BPO versus the urethral stricture. They have found that Q average and Qmax is almost half in men with voiding LUTs due to BPO, while this Qmax and Q average are close to each other in the patients suspected to be having urethral stricture disease. So the numbers, the parameters on the uroflometry have been used, the delta Q and the Qmax and Q average, to predict the BPO versus USP. Now again, there has been one index, which is a flow index, has been taken to differentiate the woman coming in OPD with the stress or the mixed urinary incontinence. We have found out that the flow index can be taken as a marker for differentiating the woman with OAB and the SUI. If you take the first graph, which is in the black line, which is the quick spike, and the downslope, which is a curve, which is representative of detrusor overactivity, as compared to the dotted line, which is normal, as compared to the bottom line, which is a plateau-shaped graph, which is a suggestive of bladder outward obstruction. So we are using different uniform parameters to just have a suspicion of underlying bladder pathology. Again, there's another study reported from Chennai in Indian Journal of Urology, where they have used the uroflowmetry along with the flow EMG. And combining this flow EMG with the uroflowmetry, they have been able to differentiate the different patterns of the dysfunction voider versus idiopathic detrusor activity versus detrusor underactivity versus primary bladder dysfunction. So just exploiting more of the uroflowmetry, combining with EMG, you can have some better idea of underlying conditions which is responsible for the low urinary tract symptom in adult male. Again, the problem is all this when we are talking is done in a uroflowmetry, which is available in a office. The patient has to walk to do this test. We have still not got any a device where the patient can do this test at home, simulating the normal circumstances in which the patient void. We have one Indian innovation from Ashish Patil, where the P flow, but still we need a little more data from that, which can be used at home by the patients. Coming to plotting this uroflowmetry in predicting the obstruction or no obstruction against Cherokee and Liverpool, there's a very low level of evidence. Actually, if you try to plot this every time, the readings will come below 2 standard deviation and look abnormal. So it's mainly meant for Caucasian population, not fit for exploiting this data to the Indian population. It's very important when you are recording this uroflowmetry, especially the Qmax. There should not be sudden rise in abdominal pressure. Patient should not press the penis or the meatus, and you should not be having a wandering stream or knocking artifacts, knocking the machine. All this will lead to artifacts. At the end, always keep this mnemonics upstream, whether the uroflowmetry has been done in the usual normal circumstances. Is there any pattern of the uroflow? Is the shape of the uroflowmetry predicting anything? The time taken, the flow rate, emptying in the form of PBR. Keep in mind the artifacts which can affect the uroflowmetry, and in the end, keep in the mind whether this uroflowmetry which you've done on a patient, making a patient wait for some time, having 200, 300 ml of urine, is it meaningful to give some impression about the type of uroflowmetry graph. So carry-on message is a very useful investigation. A method how you do is very important. There can be many interpretations made from the uroflowmetry graph, and the various parameters which we identify, these can be used to differentiate between underlying bladder outward obstruction versus underactive bladder, and the flow EMG and to rule out the dysfunctional voider versus other condition is still investigation with more data. Coming quickly to the PVR, is just an estimation of result urine after the uroflowmetry and should be done as early as possible. This is a study which has been reported in international investigation clinical urology, where we have taken post-void residual urination. We all know that we take voiding efficiency, that means the voided volume versus the total bladder volume, that means which includes the PVR also. Here it's
Mr. Chawla,
yes,
I'm sorry to interrupt.
Yeah.
For the want of time, can you please wind up?
Yes. So I'll just wind up here only. This post-void residual urine is opposite of voiding efficiency, where we take post-void residual urine ratio as compared to the voided volume in predicting the patient with underactive reducer as compared to bladder outward obstruction. So carry-home messages in the end is that this is adjunct to uroflowmetry, and the PVR or resolution is more validation. And I'll not come to the bladder, but it's important is the various parameters: frequency, voided volume, intake, incontinence, the type of incontinence, the penetration, and the use of pads in predicting the underlying cause of incontinence. Thank you very much.
Thank you so much, sir, for your presentation. Although there were some issues with the with the voice, but we could get good essence of it. Now I invite Dr. Mayank Agarwal for his presentation on how to do the UDS. It is a semi-live presentation. He will be showing a video and talking you through the procedure.
I need to control it. इसको रीस्टार्ट करना पड़ेगा ना. इसको रीस्टार्ट कर दीजिए प्लीज. Okay. No. Yeah. So it will be a video only. It's so basically this talk is about how to perform a urodynamics. So it is needless to say, before starting a urodynamics, we should have a clarity in why are we doing urodynamics. It has been discussed. If a diabetic patient, sugar should be controlled. If the infection should be controlled, there is no point doing a urodynamics in an infected patient. And please give it a proper sanctity of a sterile procedure. Urodynamics is a sterile procedure. Please give it full respect, because most of the infection will happen if you have not taken care of sugars, infections, and if you have done urodynamic catheterization in unsterile environment. And I have seen time and time again, this is the only cause you will ever find. So I don't think we need to. So a proper sterility, including pulling back the glands and cleaning from inside. It is that much required. Then a proper lubrication. Obviously, unlike Foley catheterization, we'll not put a lot of jelly inside, but adequate amount to let the catheter glide properly inside, because too much of jelly can actually desensitize the urethra and affect the results. We always use re-sterilized urodynamic catheter. Not not put in a Sidex or not just flushed with betadine, a properly re-sterilized catheter. Obviously, using a new catheter every time is going to be expensive. Alternatively, if you cannot get a proper sterilization, use 2 feeding tubes. A 5 French feeding tubes is perfectly a good alternative for doing a urodynamics cystometry. Doing this process, it has to be very gentle. If you induce pain during the procedure, half of the job is jeopardized, because the patient has developed sphincter spasm and a lot of misinterpretations will happen. I will show it in the artifacts video. Once we have placed it, another thing is we have to fix it properly. Many times what happens that the catheters come out during the study, and then in a half sterilized way you are trying to put it back in, then a lot of issues happen. So fix it properly in the first place. Rectal catheter, we use custom-made catheter because there is no point spending so much money on a company-provided rectal catheters, and it is not very easy to clean them after single use. So what we prefer is take about 9 French infant feeding tube or a 10 French feeding tube, place a glove finger over it, and I prefer to slit the cover away from the hole of measuring the measurement. The idea of putting a glove over the rectal catheter is
to prevent stool material or the rectal mucosa to plug the measuring hole. So we just need a layer of water. Lubricate with the jelly, not use too much of jelly in the rectal side, just easily it slides in about 15 to 15-ish centimeter is good enough. It has to place in the rectum, not in the anal canal. Again, fixing is very important because if it comes out during your study, it really is very annoying. Now there are 2 transducers. If you're using UPP, then you need 3 transducers. The silicone pump tubing, we have to fix it with the motor in the correct direction. And the direction markings are there typically in whatever company pump you use, the direction markings are always there. So once a pump shutter is closed, there should not be any flow through the fluid. So that is how you know that the pump is properly connected to the system. So we use high pressure arterial lines as extension tubings. Not very expensive. We use new in every case. Always use lure lock syringes so that they don't fall off. Now, very important, flushing out the tubings before connecting to the patient. Secure the lines properly. Fix them so that they don't dangle. And now the zeroing part. So in this, what we are doing is flushing the P abdomen. So once the flushing is P abdomen is being done, the P abdomen will rise up and correspondingly the P dat will show a acute drop. Then after both the channels are flushed, so we will zero the transducer to the atmosphere as per the ICS guidelines. So zero the transducers to the atmosphere. So that means all the channels are showing 0. And then switch it to the active position so that the outside atmosphere is cut off and the transducer is directly connected to the bladder. So a basic intra-abdominal and intravesical pressure will be seen, and the last flushing. Sorry. So flushing, then zero all, and finally connecting to the active to the intra-abdominal and intravesical channels, and then see the cuff response at the end. There should be no or very minimal bidirectional cuff response in the PDET, and that's a good setup. You're good to go. Thank you.
Thank you so much.
So I think we'll take the questions later.
Dr. Mayank.
So let's,
okay. So we'll take up questions later. So now, as I ask Mayank to come back and take his seat, we can request Dr. Chawla to start his presentation on filling cystometry.
Mayank,
Is sir connected?
no, I am not able to share my presentation. It is disabled. If you can help me. If you can help me in getting the permission to share my presentation. Mayank, Nikhil.
Dr. Can you share now again, once again?
Yeah, please. 1 minute. I am not able. I am having disabled participant screen sharing. If you can. No, no success so far.
Good morning, sir. Kamal this side, sir. We are just trying to go to that.
Just hold on for a minute.
The meantime, sir, please check again, sir.
Hello, sir. Can you check again, sir?
Yeah, I am going there in the. Is it okay?
Now, okay, sir. Visible.
Okay.
Please start.
Okay, so the principal aim of first of all, thanks, Meng, for an excellent video. I think most of the things which I have put on my slide, I'll take it out. And as we all know, the principal aim of UDS, which includes both the filling and the voiding symptometry, is to reproduce the patient's symptom and to detect them with synchronous with any UDS event. And some of the low unit symptoms are well suited to the same and can be elicited during the study either spontaneously or by provocative measures. Okay, so the main aim of systometry is to assess the pressures during the filling phase. And it's important we know about little bit positioning, the rate of filling, and the different parameters which we'll be assessing during the filling phase. We all know that in the filling phase, we need to look at the storage symptom because filling is related to the storage. And the important storage symptom one can have is urgency, urgent continence, frequency, nocturia, and pain. And for urgency, we try to look at the reducer overactivity. And if there is a urinary incontinence, we try to look for the reasons for this incontinence and its the frequency, whether it's related to any abnormal capacity of the bladder. So we need to have some symptoms and the reason of these symptoms in our mind to correlate with the urodynamic parameters. And it's very important that before we start the filling system entry, we need to have a little bit knowledge about what the patient history. They look at the bladder diary, the flow urethrometry.
Can you hold on for a second?
Yeah.
Can you hold on for a second, sir? Audio, will you please do something to the audio?
Is the audio low?
No, sir. I think if you maintain a constant distance from the microphone that you have, then it is okay, sir.
Yeah. Okay. I'll do that. So this
Yes,
part I'll miss, but again, what Mayank has told that the various the catheter which is placed for the P vesicum and the P abdominal readings. The most important part of this is how do you anchor and secure the catheter, because the most of the artifact which Mayank will be discussing in the last session are related to the blockage of the catheter, the leak, and the connections and the malpositioning of the catheters. So it's important that all these catheters are fixed and secured properly. And what we need to know is what is displayed in the cystometry is in the graph in the volume which is being infused, the abdominal pressure, the P vesicum, the P reducer, the flow rate, the flow volume. And we need to keep in mind that whenever we are doing a flow cystometry, we need to write everything, all events on the graph. When you start, when you stop filling, what are the sensations, the cough or any other provocation, and when you have given the permission to void and any other instructions. So all the events have to be marked and annotated. Without that, anybody else who is reading this, for them it will be difficult to interpret. And it's important to know that we don't get P that measurement directly. It is just the subtraction of the intravesical pressure and the P abdominal pressure to get the actual P that. This man has just described. This is important because is to get a good quality body you need to have the good flushing to remove all the air bubbles to prevent all the leaks. And this is the diagrammatic representation how you fix the external mounted transducers with the syringes and the tap formation to take out all the air. And in the end, we should, when we are going to start, we should have some a good reading of resting pressures, the life signals, the cuff activity, and the scales and labels clearly marked before we actually start filling it. And we all know that the P that remains zero throughout the filling phase, -5 to 5. Only the P as I come P down will change when you record it from supine to sitting to the reclining position to the standing position. There will be some amount of changes in the P as I come P down when you change the position. This is important to note before you zero it. This is again a very important test, which is a cuff test we do to see the quality of the recording. Here you can see the cuff which is not being reflected in the P abdomen. The syringe is being used the way Frank showed. Flushing, you get a good P abdominal, and the stored you can see the cuff again. The patient is asked to cuff, and you get a good P abdominal P definition. And this is the biphasic, what you get the normal variation of activity which you see in P deck. It's important when we are to start with the flowmetry, we keep on asking the patient to regularly cuff it every one minute interval to see the whole during the whole bladder filling. The fidelity of the recording is monitored through the whole filling phase. And this is just a diagrammatic implementation. Whenever there is activity in the filling sphere, how we interpret. If you go on the left side, you see there's a spike in the P abdomen and the P vasectomy, but the P that remain normal. This is activity which is related to the which is external to the bladder. It's not related to the retrusor. And you see here where there's activity in the P vasectomy and the P that which is actually due to the retrusor. And here you see in the third you have activity in the P abdomen with the negative in the P retrusor. This is suggestive of rectal contraction. And the same way you see the filling systemetry graph where all these things can be seen, where the activity in the abdomen and the negative in the suggestive of a rectal contraction, activity in P abdomen and P vasectomy, which is a reflective of abdominal activity, and you have activity in the P abdomen and the retrusor, which is a retrusor activity. So you have to keep it clear watch on the P that P vasectomy and P that to correlate these readings with the activity external to the bladder, activity from the retrusor, or activity from the rectum. Mank has described how the castration is done and how the filling is done. I'll skip this. And this is very important how to start the filling. It is usually the medium fill from 10 to 100 ml. The fast fill is related to the flow, which is more than 100. Usually we fill between 20 to 30. And how to calculate, you always go and look at the bladder diary. What is the maximum body volume? You divide by 10. That should be the filling rate in the normal one. And especially when you have a patient who have a neurogenic LUTS, you always try to fill the bladder at lower speed, preferably at 10 ml per minute speed. And what we look at the filling system, this is important. The 4 parameter which we try to look at is the sensation, the capacity, the reducer contraction, and the compliance. I'll try to go one by one over these 4 parameters. The sensation is subjective. Whenever we are doing this filling phase, always keep talking to the patient, always try to keep communicating and try to what is happening to the patient. This is very important because then only you will be able to write on the flowmetry or give annotation based on your dialogue with the patient. And we all know that we during the filling phase, we write the first sensation of filling, the normal desire to void, and the strong desire to void. The first sensation usually happens at 50% of the systometric capacity, the normal desire around 75% of the systometric capacity, and the strong desire around 90% of the systometric capacity. And whenever we have a patient who have a little bit of uneasiness and increased sensations, we try to mark all these readings with as normal, abnormal sensation in the form of hypersensitive, or if they are accompanied with some other symptom like urgency, you have to mark that. If it's accompanied with pain, you have to mark that. If there are reduced sensation or absent sensation, you have to mark that. So whenever we are doing a filling systometry in relation to the sensation, all these things should be recorded or annotated in the graph. Coming to the capacity, we all know that the maximum voided volume is noted from the bladder diary. The systometric capacity is the volume at the normal desire to void and the maximum cystometric capacity is the volume where there is a strong desire to void. And this all should be mentioned in the Europhometry, in the filling cystometry graph. So during the whole of the filling phase, usually the pressures remain quiescent. The filling phase is quite stable during the filling. Usually there are no involuntary contractions. If there are some contractions, involuntary contraction during the filling phase, you need to classify these into different types, which I mentioned, whether they are phasic, whether they are compound, whether they are terminal, or whether they sustain. We all know when they happen in the absence of the background of neurogenic condition, they are called idiopathic. In presence of any underlying neuropathic condition, they are called neurogenic reducer overactivity. And this can be spontaneous or this can be provoked. Here you can see the filling cystometry where you can see the phasic contraction happening. You can see, have a look at the P red, which is the green, and the blue, which is the P zycum, and you can see the P abdomen remain quiet during the recording of the reducer overactivity. So this is important whenever we are looking in the filling phase. Whenever there is a change in any of the P abdomen, P zycum period, you always has to look at these three parameters. This is another type of overactivity where you're seeing the multiple compound overactivity. You look at the red graph, red line, which is indicative of P abdomen remaining quiet. The example of the compound phasic diffuser overactivity, and these are the sustained. You can see the large diffuser overactivity in terms of the timing. The sustained one, here you can see this. These are all, you are seeing the cuff signal, which are seeing the artifacts, and the P abdomen remaining quiet. These are just the how you classify the overactivity in the filling cystometry into different types. And this is the flow tracing showing the type of the terminal reducer activity, where you can see there's a large contraction and the patient is being given us the permission to void, and the patient voids with a flow rate of 17 ml per second. You can have the reducer activity which can be accompanied with leak or without leak, dry or wet. Here you can see the DO, multiple DO, the phasic DO accompanied with leak. This is a spontaneous DO with leak. And here you can see the cuff, which is seen in P abdomen, P zycum tracing, nothing here. And here you can see the after the cuff, you have a start of reducer contraction, which is the cuff associated reducer activity, or you can say CADO, cuff associated reducer activity. And this is the different type of CADO tracing which I have taken from Dr. Sanjay Sinha's article. The type 1, which is the start of overactivity once the cuff signal is stopped. The type 2 is the normal, where the leakage starts when the cuff starts and stops when the cuff is over. The type 3 is a combination of type 2 and type 3, that is the mixed, and type 4 there is no leakage seen during the cuff in the filling cystometry. Now, why this is important? Because sometimes this high pressure reducer activity are associated with high reducer pressure, which can be detrimental to the renal function. And whenever we are interpreting the graph, you have to mention that there's no reducer activity means stable bladder, and if there are reducer activity, you have to mention that it is present with what pressures, and whether they were spontaneous or provoked, whether they were associated with leak or no leak. And we all know that during the filling phase, the bladder remains quiet, the pressures remain zero. The normal pressure in the filling phase at the end of the filling phase will remain between 6 to 10. However, this can vary if the compliance of this accommodation capacity of the bladder is altered. And this compliance is called as the changes in the pressure as compared to the changes in the volume. And this is measured by this equation, which I have put it, and we'll try to extrapolate this equation in the filling cystometry graph to express this compliance in milliliter / centimeter of water. Here you can see the volume at the start of the this filling cystometry 0, at the end of is 220, the pressure being 2 at the start and the pressure being at the end being 2. So if you extrapolate the equation for the compliance is 220 minus 0 or 0 minus 2 is 220 milliliter by centimeter of water. This is the way we try to look at the compliance of the bladder. However, in the next graph, if you see during the start of filling 26 volume at 123, you have a patient having the rise of the PDET along with the leak detected in the urethromet in the bottom of this. You can see the pressure at the filling being 6 at the end of PDET of 32 just before the leak started being 26. So if you measure this, it becomes this after subtracting it becomes 3.7 milliliter of centimeter of water. This is a very poorly compliant bladder. Usually we have with every volume of 40 ml of filling, you have only 1 centimeter water. This is an indication of a poorly compliant bladder. This is a way we calculate the compliance, and we all know why compliance is important, because the poor is the compliant, the more is this relation to the damage to the upper tracts. This is another example where how we try to look at the DLPP. DLPP is basically the reducer leakment pressure in the absence of reducer contraction as well as in the absence of abdominal contraction where the leak starts. So here you can see during the filling you see the continuous rise in the period pressure, and this low you can see the leak happening. So where exactly the leak is happening, that is our DLPP, and this is very important when we are especially dealing with the neurogenic alerts in predicting about the safe bladder and the unsafe bladder. And here is a filling cystometry of a patient with neurogenic alerts. Here you can see the leak here, and this the repeated DLPP of around 40 or 45. So this is the way we measure the DLPP, and higher the DLPP, poor is the compliance, and more is the threat of damage to the upper tracts. This is another issue where the leak can be, instead of the poor compliance, can be correlated to the provocative measures as the stress. So you can have a patient with urodynamic stress incontinence, you can have a patient with cough-induced urinary activity, and you can have a patient with a mixed urinary incontinence. So this is the filling cystometry where you can see the patient having a cough with a leak where we have a vessel or the physic cough activity, and you can have the multiple patient with urinary stress incontinence. And here you have a patient with the I'm short of time.
Yes, sir. We are
Yeah,
short of time.
I just summarize. I'll not put it. I just say that we need to keep in mind whenever there is incontinence, you need to correlate with the compliance, and you need to also correlate with the stress in incontinence and the disorder activity. That is the main point, and we always keep a watch over the three pressures as well as the DLPP. And this is the same graph which I have put again. Sometimes it happens that you have a patient who comes with stress incontinence. You see a typical history. You examine is this when you go urodynamics. You can't elicit that. These are the various methods where you can elicit the urodynamic stress incontinence better during the time of the filling cystometry. I'll skip this. ELPP is another. You can just record well ELPP in the terms of whether you are using cuff or whether you are using well silver. So it can be VLPP or it can be CLPP in predicting where your patient is having. The lower is the VLPP or CLPP, the more is the chances of having a poor sphincter. And this is important. Always keep in mind the difference between DLPP and ALPP. So I'll conclude by just mentioning the few important points. The urologists need to stay in the urodynamic suite to make the study meaningful. Good communication along with the patient and dialogue with the patient in asking patient what is happening is very important in giving a good interpretation, and always confirm the patient's symptom with the urodynamic event which have been produced, and symptoms are always correlated. Thank you very much.
Request. Thank you, Professor Chawla, sir. So I now request Dr. Nikhil Khattar to speak on voiding systometry and unfold the mystery of interpretation of the various pressures it flows.
Good afternoon, everybody. Thank you, North Zone USI, ISU, Dr. Swapan Sood and Dr. Rishi for having me here. Can I have my presentation, please? So the voiding systometry, the voiding phase starts with the permission to void, not with voiding itself. It starts with the permission to void. That is when the switch happens in the brain to relax the pelvic floor muscles and to allow urine to come out. And the interpretation and all depends on how well the filling phase, all precautions have been taken to have a good filling phase. And that is how we will be able to interpret what is happening in the voiding phase. For some things which are important here are that how much to fill before allow voiding should be predetermined. The rough volume should be predetermined by a voiding diary, ultrasound bladder volume, the Euroflow. And again, while the filling is being done, it should also be guided by the patient's level of fullness. And once the strong desire to pass urine is there, we should not be filling too much to reach to the cystometric capacity. And we should allow the patient to pass urine there to get the best results. Just before we permit the patient to pass urine, we should check whether the pressure transmission is proper. That can be done with a cuff just before you allow voiding. If there is any detrusor overactivity and the patient is saying that I'm not able to hold urine, and you can see that overactivity is there, we should wait for the overactive phase to come down to baseline, if that is possible, before allowing voiding. I'll tell you some more about it later. And then because voiding, permission to void is sort of most important phase in the pressure flow study. So the room should be quiet. No movement should be allowed at that point of time. Nobody should be coming in, going out. The lights should be dim. Patient should be allowed to be in his or her usual position to pass urine. If he prefers standing, then he should be made to stand. Otherwise, sitting is okay. And once the voiding has happened, then also the pressures should be checked again by a cuff to make sure that the tubes were intact and have not slipped out partially or wholly while the voiding was happening. Any situational inability to void should not be labeled as either detrusor underactivity or a contractile detrusor. So that is gaining this more and more emphasis is coming on this with newer guidelines. So if we see this voiding systometry, what we can notice is that the cuffs are just before voiding, patient has been made to cuff and it has been assessed that the tubes were in order. Then a command was also given before voiding. Then next thing you notice is at the end also there is a cuff after the voiding has finished. There are a few other things here that we can notice. I think the flow part is getting obstructed by that bar below. Can that go there? That bar? Anyways, the other thing that can be noticed here that there is a slight decrease in the abdominal pressure during voiding. This can happen when the pelvic floor relaxes, more prominent in women than in men. And it is said that this decrease means that this decrease will definitely give rise to an increase in corresponding increase in PDET because of the subtraction. And it is said that this should be taken into account when you are finally calculating the PDET at Qmax level. Then again, there is, if you notice that this patient, the detrusor pressure at the end of filling was not at baseline or near baseline. This was a poorly compliant bladder. And so the pressure started from there to rise. So PDET at Qmax, when that will be taken, will this be taken from the baseline from 0, or will it be taken as the increase from the end filling pressure? This is a controversial issue. The machines calculate it as the absolute from 0, but what the Abrams book on urodynamics says is that it should be taken from here. So that is manually every time one should be calculating it and not depending on the machine PDET, Qmax and bladder outlet obstruction index values. There are a few other things also to be noticed here, that the start of flow happens a little later than when detrusor pressure begins to rise. That part where the detrusor pressure begins to rise and the flow starts is the isometric portion where the detrusor is contracting, but the flow is not yet happening. And recent researches more and more emphasize on that flow, and there are a lot of many parameters are coming from that flow, and it will surely take up more space in times to come. Again, this is tube slipping while passing urine. This is the bladder tube that has slipped while passing urine. This is the rectal tube that has slipped while passing urine. One generally should be doing the study again, should be repeated, but one should take a call if the slippage of tube has happened after the peak flow has been achieved and during the second half, then maybe all the relevant parameters will be available to you, and you may not repeat the study if you think that everything that is relevant is there with you. Then look at this graph. Here there was a terminal detrusor overactivity which resulted in voiding and without command to pass urine. So if the command to pass urine has not been given, then you should not take it as complete and you should repeat. Here I have waited before these detrusor overactivities, strong phasic contractions have come down to baseline, and then a command to pass urine has been given, and then voiding has happened. So permission to void can be given even at the when sometimes patient says that I'm not able to hold any longer, there is a terminal DO. You can give the command to pass urine during a terminal DO, that is now termed as terminal DO voiding. And as soon as that command is given, it should be given in the initial phase of that detrusor contraction. And then the result of voiding can be interpreted and can be taken into account. Once we have all the values apart from the AG number and bladder contractility index, we can also put those values in PDET at Qmax and Qmax values on this nomogram, and know at once whether there is outlet obstruction or underactivity or equivocal or what type where we are going. Now, there are many conditions in BPH. Things are more or less clear if we know that that stricture is not there and a patient is of that age group. But then there are many conditions in younger men. I will like you to take note of these conditions, which I will present in next few slides. And then some of them can even be present in older ages when we see not so good results after prostate deobstruction. These are young men where poor uroflow and normal RGU was present. This is a young man, in fact, a doctor who had presented with bilateral hydronephrosis and increased creatinine. And you can see there is poor compliance. And then while voiding, he has definite bladder outlet obstruction. You can also notice that there is a slight increase in EMG, although not significant, but it has not dropped down. But this gives a diagnosis, no doubt. But the picture gets completed here. When in voiding film, we see that there is no funneling at the bladder neck. So it's a primary bladder outlet, bladder neck obstruction. Here again, this is again high pressure, low flow voiding, and then bladder neck is not opening. This is again a primary bladder neck obstruction. Here you can see the EMG not flattening and detrusor pressure going up. And on the voiding film, we see that there is dilatation of the proximal urethra. This is dysfunctional voiding or poor relaxation of the external sphincter, which is not allowing voiding. This can happen even in older men as well. Here, again, we can see a dysfunctional voider. Then this is BPH in a young male. Here we can see that there is bladder outlet obstruction urodynamically and EMG is not dropping. We can presume that it can be either maybe a dysfunctional voiding, but it is not so. The picture gets completed here. This is a 45-year-old male. You can see that the bladder neck is opening and there is obstruction at the level of the prostate. This kind of picture is very important in video or voiding film. Whenever there is confusing situation in younger men. Similarly, in men where Parkinsonism and multi-system atrophy is also there also this kind of picture is important. And we can see that this young man had a 30-gram prostate, which was pretty obstructive, and TURP gave him a good relief. He was only 45. This was one of the most difficult decisions to take at that point, because BNI is not going to help. You will definitely be counseling him for ejaculatory disturbances as well. Again, another point that I want you to focus is that although video is very important for getting to other diagnoses of bladder outlet obstruction, but in dysfunctional voiding, there is a pattern we can see that there is a pattern of flattening of the PDET curve. You can see this in all these three cases. If we go back in bladder neck obstructions earlier, then you see that these are tower-like patterns. They are not flat patterns. So this flattening pattern is even without a video, this is predictive of dysfunctional voiding. And Dr. Mayank has been working extensively over this marker, surrogate marker for the presence of dysfunctional voiding external sphincteric tissue. And we will be getting more papers from him in future. And then there can be underactivity as well. This is detrusor underactivity. And at the end, I will like to show another condition, which is detrusor hyperactivity with inhibited contractility. This can happen in up to 12 to 18% of men above 70 years, and is a very difficult condition to treat. But one should be able to recognize it. That is all. Thank you so much.
Thank you, Dr. Nikhil. I think we'll take some questions after the last.
last presentation is on detection of artifacts and how to reduce them.
Yeah. So we have understood that how to interpret the Euroflowmetry and Eurodynamic study, but we have to not uh, ignore that there are artifacts and we can do many things to prevent those artifacts, because artifacts will jeopardize all the interpretation from your Eurodynamic study. So a well-done Eurodynamic study is paramount for a proper analysis. And there are a lot many variables which must fall into place to make a study happen properly. So air bubbles, kinks, leaks, knocks, loaded rectum, empty bladder, software issues, hardware issues, so many things will jeopardize your aerodynamics. So we will just mention few of the artifacts and how to deal with those. So artifacts due to lack of privacy, due to unaccustomed voiding position has been discussed. This is a typical cruising artifact, and the patient should be told to pass urine properly and not directly into the hole and not play with the uroflow. Then the kicking artifact, it is not uncommonly seen that there is a very sharp jump in the Q ura curve, and it is because the Euroflowmeter was kicked during the study, and it happens more commonly in the weight transducer system. Then squeeze and release artifact, Dr. Chawla had discussed earlier that the patient wants to perform, and many patients with BPH have this tendency that they will just squeeze so that they have some time, the part of the stream is good. Then another artifact, it is not an artifact, but a common practice that you tend to zero the P-det and P-vesicle with the transducers active to inside, not to the atmosphere. Now, it is not an artifact, and as long as you are only interested in a properly zeroed, properly calibrated study. But as per ICS, it is a wrong practice, because we want to know what are the basic pressures inside the abdomen. So I don't consider it as an artifact, except for a few situations when you want to know the VLPPs. Otherwise, it is not an artifact. So as per ICS guidelines, you want to zero to atmosphere and then turn to active position so that you have some baseline pressures, which have been mentioned by Professor Chawla earlier. Cuff response, either it should be nothing in the PDET or at the most a small bidirectional motion in the PDET on cuffing, which is less than 5 centimeter water. To my understanding, to my practice, 5 centimeters is a big pressure variant. I will not accept even a 5 centimeter this thing. So like in this, you can see a bidirectional small amplitude. It is acceptable. But if you have it's an expanded graph actually, a bidirectional high amplitude. So there is something wrong. There is some discrepancy in the pressure transmission in P-det, P abdomen and P vesicle. And many times there is some kinking in the tube somewhere and it's manageable. So in cuff response, if you have a unidirectional cuff response upwards, so most probably either there is a reduced anal tone or it is because there is some air bubble or some kink in the respective pressure line. P-vis catheter expelled, then suddenly that means that suddenly there is a fall in the P vesicle. It becomes non-physiologically flat, or sudden P abdomen, same thing. Suddenly the pressure drops below zero and become non-physiologically flat. So non-responsive P vesicle, as in this graph, should be first corrected by assuming that there is a bubble somewhere in the channel, and most of the time it corrects by flushing the catheter. Non-responsive P abdomen, similarly, if you flush off the air from the channel, it will correct by itself. But if there is non-responsive PVES, it is not corrected by flushing. So there are few possibilities, like a completely empty bladder. Sometimes what happens that the hole which is measuring the P vesicle is attached to the mucosa, or there is a complete kinking of the catheter, or the catheter is not inside the bladder. So these are manageable by moving the catheters in and around, twisting, rotating the catheter. So all those things, maneuvers can correct the kinks and twists and the stuff. And sometimes what happens that your maneuvers are not working, you just fill to about 20 mLs, and then some space is created in the bladder, and then you will see that the situation is sorted. And sometimes what happens at the end of your voiding phase, you check cuff response, and you find that the cuff response is not working again. The same situation. Most of the time, once the bladder is completely empty, it will block the hole. And by some maneuvers, as mentioned previously, you must check that your pressure transmission was good during the study. Tubing movement artifact, it is not uncommonly seen when the pump tubing is in contact with the P vesicle and P abdominal tubing. So pump is usually is a pulsatile pumping. So what happens that if you expand this graph, you will find this kind of movement. As long as your PDAT is working all right, there is no artifact in the PDAT, it's okay. Or better still, you just separate the pump tubing from the PDAT and P vesicle. Rectal contractions are typically seen. So whenever you have a so-called detrusor overactivity or sudden fall in the PDAT, you always see the PVES graph and PDAT graph, or the P abdomen graph individually. So typically a rectal contraction will reduce your P detrusor. And in that situation, you may have to take help of P vesicle parameters, because you see in the above graph, the P vesicle is smooth and the P abdomen is having too much of contraction, causing the trouble. So causes are not well prepared bowel, fecal loading, neurogenic bowel dysfunction, and use of colonic stimulants. Like many people will want to give PC enema or Dulcolex tablets or suppositories before urodynamic study. We don't practice this because they will lead to some rectal contractions, which may cause irritation during the study. Rectal relaxation, Dr. Nikhil has already mentioned. So if you encounter rectal relaxation during the study, so you have to check your PDAT Qmax and PDAT max based on the P vesicle, not based on P detrusor. Movement artifacts. So if there is any knock if the patient moves suddenly, so all the three parameters will move, and they settle down if the patient is stable. So nothing to be worried about. This artifact, maybe Dr. Nikhil can explain. I was not able to explain. There is only artifact in the P detrusor and not in the P vesicle and P abdomen. I would not explain it. It happened a couple of times and then it was all right. Maybe some software issue, or if Dr. Nikhil or anybody has another idea about it. Anyway, yeah.
No, I still think, but the voiding and everything is interpretable still.
Yeah, it is interpretable. But I could not explain why this happened actually.
Yes.
So EMG, this is a usual EMG response. This is a guarding reflex and relaxation during voiding. So then you have, you still can interpret this EMG. However, there are a lot of artifacts during the filling phase. But still, I would say in a background, you have a good guarding reflex and you have a relaxation during the voiding phase. But at times your EMG becomes autonomous. So there is no response whatsoever. And I will disregard this EMG during interpretation. And there are some physiological artifacts. What I was talking about while filling the catheter. This is a free uroflowmetry of this woman for whom we had done urodynamics for assessment of stress-invariant incontinence. Now see what has happened during the study. During the study, you find that the leak was less as compared to what is expected out of symptoms, and see the voiding phase. Now, voiding phase shows that there is some sort of a detrusor underactivity. So I will have to disregard this study because it is not corroborating with the clinical symptoms and the uroflowmetry. So sometimes we have to manually override because if the software is not very good quality, they will see, you can see in this study, it's a knocking artifact of Euroflowmeter, but the machine has taken this as a Qmax. So this is not the correct Qmax. Obviously, this is a knocking artifact and you have to manually place the Qmax at the correct place. And like so. Now this is a very awkward artifact in which the transducer was swapped and the P vesicle was measured in P abdomen. I think this was to conclude, for a good practice, prepare patient well, treat active infection, treat constipation with fecal loading, treat diarrhea, control sugars, make patient comfortable, insert catheter with adequate but not too much lubrication and with dignity, flush channels adequately, connect with respective transducers, and apply common sense at all times. Thank you very much. So if you have time for a couple of questions, we can take or whatever.
So with this, we move on to the next part of the ISU session. And thank you, Dr. Mayank and Dr. Nikhil. May I invite Dr. P.P. Singh, Dr. Atul Khullar, and Dr. R.S. Chahal on the dais to conduct the next session. This is again a ISU session, and in this we are going to discuss, understand the ultrasound probes and the fusion MRI for the prostate biopsy. Dr. P.P. Singh, Dr. Atul Khullar, and Dr. R.S. Chahal, please. Dr. Rajiv Yadav, can please start.
Thank you very much for this invite. At the onset, I will like to pay my gratitude to my Guruji, Dr. N.P. Gupta. Today is Guru Purnima. My task is to talk about ultrasound probes, which are used in biopsy techniques. So for the next 10 minutes, I will be just focusing on the details of ultrasound probes, what are the probes available to us, and how they differ from each other. It's not moving. Okay. As you know, we are performing biopsies through either a transrectal route or a transperineal route. Both the biopsies, we can have fusion biopsies where with the help of software or in gantry, we are fusing the ultrasound images with the MRI and doing a fusion biopsy. So I'm sure you might have already seen details in some of the previous presentation, and in the next presentation, more details will be given about fusion biopsy by my friend. So keeping myself on the probes itself, briefly, this image summarizes what are the various kinds of probes. It can be simply divided upon the type where the piezoelectric crystal or piezoelectric mechanism is placed. In the end fire, very simply, the crystal is placed where the sound waves are generated is at the end of the probe. Then there are side firing where the crystals are on the side. The side firing can be arranged in the form of a transverse array or a longitudinal array. And then, of course, there are newer probes where more than one arrays are placed, meaning in the biplanar or multiplanar mode. Monoplanar probes, which is most commonly the end fire probe, is the most commonly used and most widely available and cost-effective probe. So if someone wants to invest into prostate biopsies, then this is the probe to be bought. Why? This is a multi-specialty use. Your gynecologists can use it because gynecologists are using it for transvaginal ultrasound. They are using it to fetch the ovum. So many IVF centers are now opening up. So one probe can serve the purpose for quite many of you. So if someone wants to invest into one cheapest probe, which will serve most of the purpose, this is the probe to go for. So the end fire probe is most widely used. Then of course, there are other monoplanar probes which are side firing, mostly for diagnostic purpose, less of use in urology. So I will not pay much attention to those. From that, we directly move on to this probe, which is a triplanar probe, meaning you can see in this probe, the array is placed right on the top of the end of the probe, which serves as the end firing. It continues to the side, which serves as a side firing probe. And then there is a transversely arranged side firing another probe. So one of the side firing probes works as a sagittal scanner, and another will give you the axial image. So this is a triplanar probe, but at one point of time, images will be shown in two of the axes only. So you have to switch, but the benefit is that you will not have to switch from one probe to another if you want to move from side firing to end firing. This probe is most widely used wherever we are using a transrectal biopsies, whether fusion or no fusion, this probe can be used for both the purposes. Most of the multi-specialty hospitals, bigger departments would like to own this, and this is what most of the time many of us have been using. This is another kind of more commonly used probe, which is a biplanar probe. This probe is used for transperineal biopsies. Now in this, as the red marks show you, one is transverse and one is longitudinal. So it can give you images simultaneously in two planes. So this biplanar probe is specifically used for transperineal biopsies. This is how it will be placed. All the probes, whether transrectal or transperineal, the probe will go into the rectum. So whenever we do biopsies, the biopsies are not done by placing a probe in the perineum. The probe will go into the rectum and then it will show the images. Of course, the biopsy needle may either go through the transrectally through the rectum or transperineal to the perineal skin. So in this, you can see the probe is in that model. The probe is lying into the rectum and looking at the prostate, and the needle through the needle guide goes through the perineum. So this is used for transperineal biopsies. Now I will come to how the needle, what is the relationship of the needle with the probe? So in side fire, you can see in the second image, the needle is coming by this side. So obviously it will be seen through the ultrasound waves which are coming through the side array. How it is seen is that in the transverse array will show it like a dot only. The sagittal may show the length of the needle while it is passing through. This kind of arrangement is used in fusion biopsies when we are doing transrectal fusion biopsies. While in the third image, you can see the image where the needle is coming through the end fire. It is almost in line with the sound waves coming at the end of the end fire probe. In my experience, if someone wants to start, this is the most easiest and the most reliable way of doing the biopsies. The simple reason is when we are using an end fire probe, we are actually pressing against the prostate. The image quality is good, and you can actually see the whole needle tract from the point of entry to the point where you are actually intending to put forward to. Basically, in transrectal, the patient's position is left in the lateral position, mostly done under local anesthesia until unless the patient wants it under sedation, where you can use propofol sedation because it hardly takes 10 minutes. So propofol, the anesthetists are quite happy with. Or if the patient really wants total anesthesia, that's fine. But majority of the situation, more than 99%, it will be done under local anesthesia. In transperineal situation, because you need access to the perineum, it is done in lithotomy position. Initially, when you start transperineal biopsies, you would like to do it under anesthesia because it's time consuming in the beginning, it is painful, and you also need time to get accustomed to the technique as well as you will take quite some time initially. So initial part, you do it under GA or spinal. Later on, with experience, you can think of moving to local anesthesia. But this is one of the most common criticism for transperineal, that it requires an OT setup. It increases the cost, takes a lot of time. So this model simply shows how the end fire works. You place the probe right against the prostate in the alignment where it is kind of giving the rays in the axial section, and the needle goes right in the line of the sound wave so that you can see it. The way you will move your probe craniocaudally, you will move from base to the apex, or if you tilt your probe up and down, you will move from mid position, meaning mid sagittal to lateral part of the peripheral zone. Whenever you want to switch from one lobe to another, you will totally rotate the probe from one side to another upside down so that the needle will be exiting from the opposite end. As you can see on the upper two images, it is mainly on the right lobe. And in the lower images, the needle is going to the left lobe. On the screen, of course, because of with the help of the software, it will always be seen on the same side. On the other hand, this side fire probe, you will be using a biplanar view. This is how the needle will exit. Whenever we are doing a freehand biopsies, most of the centers will be using an end fire probe. Whenever they are using a software-assisted fusion biopsy, they might be using a biplanar view because it requires vision in two planes. There was some initial suggestion that the detection rate were better with end fire probe. However, after a few randomized trials, it was found that the rate may not be different. But I think those randomized trials was done in some of the high-end centers. But in practice, in community practice, I still believe that the pickup rate in the hands of a urologist will be far better in end fire probe rather than a side fire probe. Simply because the needle placement and vision of the needle is far better in end fire probe. With that, this is how the setup of the transperineal biopsy probe is. Primarily, the probe is in the rectum, the biplanar probe, and you can do the biopsy either a freehand meaning without using a biopsy guide, or you can use a biopsy guide. Using a freehand transperineal biopsy is quite challenging in the sense that your needle should go right into the plane where the sound waves are coming. Even if you move a little bit, you will lose the track of the needle. So the visualization is not good. Most of the centers would invest into the biopsy guide. Unfortunately, these small piece of equipments are quite expensive. So unless your center is a referral center, you are receiving a lot of referral for transperineal biopsy, it may not be a good idea to invest into a transperineal biopsy probe. Now, this slide is purely academic in the sense that you can see how the needle enters into a truss versus transperineal core. So transperineal core, you are going longitudinally, while in transrectal, you are going axially. So what difference it makes? You are actually picking up the tumor, that's fine. The difference will be that if you are trying to compare one technique with another technique, in transperineal approach, the representation of peripheral zone in one core is far greater than this representation in similar kind of core when you are doing a transrectal, because it will traverse the peripheral zone, go to the transition zone, and it will be representing both the zones. While in transperineal approach, you will be focusing on the peripheral zone or a center zone, wherever you want. So almost 100% of the representation is from that zone. So it will be purely from the point where we are trying to compare the results of one from another. Otherwise, from the point of a pickup, it's almost same. So that's all. Thank you for your attention. I will be happy to take questions later.
Thank you, Rajiv. It was quite an elaborative discussion. But the question comes again, somebody who is acquiring in a setup. Now, each probe for
yes,
a lot of time. You told an end fire probe is ideal. But if somebody has to acquire two probes, which one do you recommend?
So to summarize, N5 probe is ideal for a single center, small center practice or a community-based urologist. For a tertiary care center where there are multiple urologists working together, you can afford to spend more money. Then it will depend upon what techniques you are comfortable with. If your majority of colleagues are comfortable with transrectal biopsies, you should rather invest into a triplanar transrectal biopsy probe.
Okay.
When you acquire a biplanar probe, which can only be used for transperineal biopsy, you are actually investing a lot more into a transperineal biopsy only. Then you will require a fusion software, which is far expensive than the machine itself. If you acquire a transperineal biopsy fusion software, it will almost cost you 1 crore. And the machine will be maybe 70, 80 lakhs probably. If you lose even the guide, because we have faced this, the CSSD lost one of the guide. It cost us around 1 lakh rupee. So it happens. If you are multiple people working in a group, things will get lost, things will get destroyed sometimes. And it is so you have to balance out the amount of money you spend in it. I would rather pay my bet on a triplanar transrectal probe in most of the situations.
I get it. Thank you, Dr. Rajiv. So move to the next topic, that is understanding fusion with MP-MRI. I invite Dr. Amitabh Singh.
Good afternoon, everyone. And thanks to Sood sir, Rishi sir, and chairpersons for giving this opportunity. So after having an excellent talk on the trust biopsy, the pros of trust, I'll be discussing on the understanding fusion with MP-MRI. Just to begin with the context of trust biopsy and why we really need MP-MRI guided biopsies. There are some shortcomings with the associated with trust biopsy because they are known for poor detection rate. They are known for over detection of clinically insignificant prostate cancer. They are known for having under detection of clinically significant disease. And we require more course actually to detect the prostate cancer, which adds on the complication in the post-op patient. So clinician tried to different strategies. They got MP-MRI after getting PSA to decide the biopsy. They included risk calculator after PSA to go for the biopsy, and they tried to include risk calculator and MRI also before getting the biopsy. So we should know that now MP-MRI has been used as a triage investigation before the biopsy, and it is now almost in every international guideline. And this has been established by the PROMISE trial. So in this trial, almost 740 patients are recruited, and the same patient underwent MP-MRI followed by transperineal template biopsy, where the every core was separated from each other by 0.5 mm, 5 mm, because we consider any lesion which is more than 5 mm is clinically significant. And after the same patient underwent a standard 12-core trust biopsy. And the result of MP-MRI and 12-core biopsies were compared with the saturation transperineal template biopsy. And we found that the MP-MRI has got higher sensitivity, almost double compared to the trust biopsy, and very significantly higher negative predictive value compared to the trust biopsy. So this is a very landmark study which established the role of MP-MRI as a triage investigation before getting the biopsy after PSA. So now what are the available ways for which we can go for the MRI targeted biopsy? First one is a cognitive fusion, where the clinician or the radiologist fuse mentally the picture of MRI and the real-time ultrasound and tries to hit the region of interest. Second is in-bore biopsy, where the radiologist try to get the biopsy in gantry of the MRI. And third is MR fusion, where we combine the high resolution images of the MRI with the real-time visualization of the truss, because we can see the lesion in MRI and we can target that lesion under real-time ultrasound. But there are certain limitations of cognitive targeted biopsies. Although very good studies, they are saying that the detection yield and the detection rate of clinically significant prostate cancer is as good as the MR fusion biopsy in cognitive targeted biopsy. But this needs a hell of lot of experience with the radiologist. because there are certain differences in the prostate orientation. We know MRI of the prostate, the patient is being done under supine position, whereas during a real-time ultrasound, during the biopsy, we keep either patient in left lateral position or lithotomy position. This change in the position results into the different orientation of the prostate in MRI and the ultrasound. So the transverse plane in MRI and the real-time ultrasound of the prostate may not match with each other, and that lead to the difference in the geometric misses. So you can, if you're not very well experienced, if you don't have your cognitive image in your mind, then probably there is very high chance that you may miss the region of interest and you will not target the region of interest. So researchers and we all clinicians are using fusion biopsy now more and more because it is very easy to do and it is very users friendly. In fusion biopsy, we try to see the prostate margins and we try to mark the lesion on the MRI and we do the biopsy under ultrasound guidance. So this is a fixed workflow. First, we get the multiparametric MRI of the prostate before getting the biopsy. And if the patient had underwent the truss biopsy before that, then better to wait for 8 weeks and then you repeat the multiparametric MRI of the prostate. After that, you do MRI interpretation, mark the region of interest, and then go for the MRI segmentation. This is a very important step where we mark the boundaries of the prostate and the region of interest in every MRI segment. And a third-party software creates a 3D MRI image, which is after being fused with the 3D construct of the ultrasound image. So this is a very small video where the MRI segmentation is being demonstrated. So this is being done under MRI suite. Actually, you can see 1 second. So now you can see this is the prostate boundary which is being marked under the software. So we are using Artemis machine at our hospital provided by the Egan. So this is being provided with that software. So this is installed in our machine also, real-time ultrasound machine also, and it is installed in the MRI machine also. So now the radiologist is marking the prostate boundary, and along with that, he will mark the region of interest also. So this is very important step. So we should very carefully mark the prostate so that it would match with the 3D construct of the prostate under real-time ultrasound. Especially we should we should be very focused at the apex of the prostate because in most of the prostate it is not very much clear, and we should not miss any median lobe or intravesical bulging of the prostate. And along with, although we mark the prostate in transverse images, but ultimately it marked the whole prostate in sagittal images also and the coronal images also. So this is just marking. If suppose there is like some extra amount of the prostate is being marked with this software by like some mistake, then you can erase all the segmentation also. You can resegment the prostate also. After that, the region of interest is being marked in the software, and there are different color codings also, green, yellow, red, depending on the Pirates scoring of the lesion in the prostate. You can see the one lesion is being marked with the green, one is marked with the yellow. So once segmentation is done, we export all these images to a CD, and after that we 1 second. Now, so after exporting the MRI data and the segmentation data, we import all these images to the MRI, this Egan machine, which is kept in the OPD along with the ultrasound machine. So we again reevaluate the segmentation and MRI targets. After that, we place the patient, depending on whether we are doing transperineal biopsy or transrectal biopsy in the lithotomy or left lateral position. We do truss of the prostate, we get the boundary of the prostate, and we acquire multiple images of the prostate by sweeping the ultrasound probe. After getting the images of the prostate, we do ultrasound segmentation where the boundaries of prostate are marked in one or more segments to create a 3D construct of ultrasound images. And after that, which is the most important part, is the registration and fusion. So we fuse 3D reconstruct of the MRI and 3D reconstruct of the ultrasound images over one another. And once the fusion is done, we start the biopsy. So by this simple picture, you can understand. So these are the segments of the prostate under MRI images, whereas on the right side, these are the segments of the prostate in truss images. And we force both images with one another by elastic fusion or registration fusion. I'll be discussing later on. So what it does actually, it superimposes the MRI images over the real-time ultrasound images so that you can see the region of interest over the ultrasound images. Now, the registration actually part, this is the most important step of this whole MRI fusion technique. So registration means is establishing anatomical correspondence between one image and the another images. And here we do anatomical correspondence between the MRI images and ultrasound the images. So basically we are having two types of registration. One is rigid registration and another is elastic registration. So what is the rigid registration? It actually do not deform the MRI images, all the ultrasound images. It just superimpose the MRI image, MRI 3D reconstruct over the ultrasound 3D reconstruct. The problem with the rigid registration is that we need to understand that both images cannot be same as each other, because the images can be deformed, either the presence of endorectal coil during the MRI, or that can be deformed by the position of the patient, or that can be deformed by the putting the probe inside the rectum. So in the rigid registration, what we do, we just rotate the images of the 3D reconstruct of the MRI to the 3D reconstruct of the ultrasound to matches in the most beautiful way, but we cannot deform the MRI images. So here we need to apply our mental images also, where is the perfect location of the region of interest. Whereas in the elastic registration, what we do, the software deforms the MRI images and it tries to fit the complete MRI 3D reconstruct into the ultrasound 3D reconstruct. So in a rigid registration, what happens actually, because we cannot deform the MRI images, so there could be two locations of the MRI, the region of interest. One corresponds to the MRI and one corresponds to the ultrasound. Whereas in the elastic registration, the software itself deforms the MRI images and it tries to fit into the image of 3D reconstruct of ultrasound. So there won't be difficulty in identifying the region of interest. So it has been said that for the newcomers or the beginners, the elastic registration is most suitable way to go for the MR fusion biopsy. And once you are very well experienced, you develop your own cognitive skills to identify the region of interest under ultrasound and under the MRI, then rigid registration is very good. So with BK ultrasound actually, so they have provided one more software which is called as a predictive fusion. So it is a type of rigid registration. What it does actually, as I have already mentioned earlier, that the orientation of the prostate is always different in MRI and the ultrasound. So what it does in the MRI images, it puts a virtual truss probe into the rectum and it tries to segment the prostate according to just that virtual transrectal probe. So it imagine that how would be your prostate looking while you are doing the truss imaging of this prostate while doing ultrasound. So in that way, it tries to negotiate and try to negate the deformity difference between the MRI images and the ultrasound images. These are the available platforms for the MR truss fusion biopsies like BK, Colis, Euronev, and Artemis. We are using Artemis, but other centers are using BK like Max and some other hospitals. So these are all these systems, they are different from one another in terms of basic features, like whether they require additional ultrasound, what is the type of registration, whether they are using rigid registration or whether they are using flexible or this elastic registration, and whether they are available with the attachments for the transrectal or transperineal biopsy or not, what is the workflow, whether the ultrasound requires calibration or not, and whether the contouring of the prostate during ultrasound is required or not, and the realignment is required or not. So realignment is required in BK fusion and Artemis. Whereas, so this is a very small video for doing transperineal biopsy, how we do at our center. So initially we are doing transrectal biopsy in every patient, transrectal MR fusion biopsy. Now we have switched to transperineal MR fusion biopsy in every patient. So this is Fusifilm biplanar ultrasound probe provided with the axial and the sagittal array. So this is the prostate. In the phantom, you can see the region of interest also. So this can be seen by the swapping of the prostate into this axial images and the sagittal images. So this is a sagittal image where you can see the apex of prostate going towards the base of prostate, seeing the urethra, seeing the SVs and the bladder as well. So this is the lithotomy position of the patient, how we keep during the transperineal biopsy. Once the prepping is done, the preparation is being done, we start administering the local anesthesia. So first we give the subdermal, infiltrate the skin with the hypodermic needle. We use a 2% lignocaine for infiltrating the subdermal space. Putting jelly into the rectum to facilitate the insertion of the ultrasound probe. After wrapping the probe with the condom, putting the probe into the rectum of the patient. Now seeing the prostate in sagittal view from the right side to left side. So this is prostate, levator ani, periapical tissue. So once you see the periapical tissue of the prostate, it starts giving this mixture of lignocaine and bupivacaine to provide the maximum analgesia to the patient. Although we are doing cases in short general anesthesia, but if the disease volume is high, then we do under local anesthesia also. Now here we are sweeping the ultrasound probe to get the images of the ultrasound from the right side to left side. So this sweeping is not required in BK ultrasound machine. This sweeping is required in Artemis to acquire that three-dimensional view of the prostate. So we need to do very gentle and very clean sweep to acquire the images of the prostate. The software generates the 3D construct of the prostate. We need to mark the boundaries. We need to tell the software where is exactly the prostate. So we do it one transverse also and sagittal also. So after telling the software, this is the boundary of prostate, software itself make a 3D reconstruct of the ultrasound. Now you can see this 3D reconstruct of the ultrasound image. So you can refine also. So if you like feel that the some part of the prostate is outside or inside, then you can readjust it also. You can recorrect it as and when if you require it. So here there is a facility now. You can mark the urethra also. Previously, it was not with the Artemis machine. So now the next step is alignment of the prostate. So here this facility has been given. You can refine the realignment because I told you the realignment of this prostate can be different with the MRI and it can be different with the ultrasound. So you need to realign both images of the prostate so that it should match with each other perfectly. Otherwise, you will miss the region of interest and you will not get the enough result or the required result from your biopsy. So once the realignment is done, it will fuse it itself. This Artemis machine uses elastic fusion registration. So that's why it is very user friendly. Now it always tells you what are the region of interest again. So I starts with always this targeted course. Now you can see this yellow is targeted core 1 and another will be at the this apex, very small, almost less 5 mm in the size at the base of prostate adjoining to this. So this is the way how we just turn or this realign our needle track from the like posterior zone to the anterior part of the prostate. So after just setting the machine, after fusion, now we start targeting. You can see precisely how needle is going to the desired track. The beauty of this fusion machine is that now I would like to show you, you can target this small lesion also. You can see this very small 5 mm, this yellow region of interest. So you can still target very beautifully this. So you can't do this with cognitive fusion biopsy. So that's why this is more user friendly. And we are having a very high yield of clinically significant prostate cancers. So thank you for your patience hearing.
Thank you, Amitabh. Now, just one small question. You already taken extra time, but this elastic fusion, which you described with Artemis, is also available with BK, isn't it?
So BK uses rigid fusion.
Only.
BK use rigid fusion, whereas EGAN use elastic fusion.
So you have the advantage of not using your cognitive sense with BK, isn't it?
Exactly. So what happens in elastic fusion, you need not to apply your cognitive fusion because that software will do that for you.
Okay.
Whereas in BK, you need to realign the both images on one another. You need to superimpose the MRI images on the ultrasound images, and that will not match. So what happens if the lesion is at the contour, at the periphery of the prostate? So there would be difficulty in hitting the region of interest. If they are in the middle of the prostate or away from the this margin of the prostate, then you can hit it. But if they are at the margin of the prostate, then you will feel difficulty.
But you're doing mix and match. You're using Artemis as well as QG.
So, pardon, sir?
You're using QG probe, isn't it?
I
Your probe is QG, not the BK.
No,
The
sir. We are using Fusifilm.
Yeah.
So BK probe is being provided with the BK MIM software for the fusion biopsy. So they are having a complete setup for the fusion biopsy, either transrectal or transperineal. So they are having their own software for the fusion also. They are having their own hardware also. Whereas in our hospital, we are having fusion machine with the EGAN, but we need to use ultrasound, separate ultrasound, because EGAN is not coming with the ultrasound. So we are using Fusifilm ultrasound. That's it.
Thank you.
But the total cost in our setup is less than BK fusion. Because if you are buying the BK fusion, probably it will be coming around 1.5 to 2 CR. If you are getting the whole complete setup of the BK. Whereas in our setup, we are using EGAN and we are using Fusifilm ultrasound, and that is coming around 1 CR altogether.
Thank you.
Hello. As I understand that you will do MRI at the MRI shoot and then move the data with the machine there, or the CD moves to the ultrasound machine.
So
how it happens.
So what we do, sir, we do segmentation in the MRI console. We export the data in a CD and we bring that CD and we need to put that CD into that EGAN machine.
Thank you. Thank you.
Thank you, Chairperson, sir. We move on to the next session. This is the clinical case discussion session, and we club the first two case discussions into one. May I invite the panelists here? Dr. N.P. Gupta, sir, Dr. Kamaljeet Singh, Dr. Vrinder Sagar, Dr. Umesh, and Dr. Amitabh. Dr. Amitabh, please join us on the bench, please. So, Dr. Mallikarjun Reddy is going to start with the post-URP bleed.
Respected chairpersons, thank you, Rishi, Kamal, and the North Zone for this opportunity. This is not a very uncommon scenario, but how do we deal with this uncommon scenario is what we look at. Don't think it is going to be very simple. People here would really enjoy once you go onto the fifth slide. So this is a 64-year-old male who presented with painless hematuria, 4 episodes with a clot. He was having 80 cc gland with a PSA of 4.1. We did a cystoscopy, clot evacuation, and workup for malignancy were normal. And he underwent a bipolar TUR, and it was uneventful. His catheter was removed. He went home. The next day, he goes home. He develops an acute MI. So promptly he gets back to the hospital, and the cardiologist in the night does a primary angioplasty, PTN, the stenting, and he puts him on rivaroxaban and whatever bands and everything you have. And then this guy starts to bleed, and then he has a 8 centimeter clot in the bladder, and we get a call. So the immediate thing which we did was to put a catheter and put on irrigation. Then we had multiple catheter blocks. And then the next day, with all the risk, we had to do a clot evacuation. We couldn't find a bleeder in the prostate. And then we again put back the catheter and irrigation. 2 days down the line, we stopped the irrigation to see how things are. And then The evening you end up again with a 6 centimeter clot. So he gets 3 episodes of clot evacuation and irrigation in that week, in spite of the risk. And then we don't find a bleeder in the prostatic fossa. The cardiologist was kind enough to bring down his anticoagulation. We put him on Tranexa and all. Sir, up to you. What next to be done, sir? NB Gupta, sir.
So actually, what you have done is right to a good cystoscopy and bladder wash. Because sometime when clot is inside, that itself can give rise to botheration for the bleeding. So better to do a good clot evacuation, put a 3-way caster and put a traction on the caster. That is what I do, a benign traction and high traction both, and leave the traction there for 4 or 5 days. Don't try to relieve it and again see what is happening. And as far as anticoagulant is concerned, that you have to tell your cardiologist the minimum possible what is essential they should give him. And if you leave the caster for 8 or 10 days, let his cardiac condition also stabilize, things will automatically settle down.
So the whole issue was every 2 days he was bleeding. He was having a clot. That is the problem. All this time he had a catheter in situ. Never was a catheter removed.
Okay. The other option is to do a prostate artery embolization. That can be considered actually for him because you can't do anything else. To do a angiogram, see where if there is a bleeder, they can do a coagulation.
Kamal, anything else would you do?
So, I think so. Disclaimer, I know the details of the case, so I will go as I don't know anything else. First is when we are going to give a traction to the patient is when we insert the catheter, inflate somewhere around 10 to 15 ml, pull the catheter into the fossa and inject 10 ml more so that there is a complete compression of the fossa. That is the likely place we are going to have a bleed. And rightly as what NP Gupta sir said, keep the traction on for at least 48 hours. I usually do not go beyond that because sometimes it can lead to the other damages also. So the stricture rate and everything falls in it. Beyond this, I don't think so. I will be contemplating to doing it. The only information I would like to have is the access sheet for the PTCA still in situ or not?
No, everything is out. He has got this thing. It was a transradial angioplasty which was done, not a transfemoral angioplasty. Transradial angioplasty is done in the night. The traction is we could give only minimal traction because again he was complaining of pain. The only good thing is because they have not gone transfemoral. Even if he moves, that there was no risk of any sort of a bleed from the angiography side. So minimal traction, and we had to release it in 24 to 48 hours. Each time we were looking at doing that, and the moment we release, we stop irrigation. We see that things are clear. We stop irrigation. We have a clot.
Actually, when I say the balloon, I don't keep the balloon in the prostate so much. I like to keep in the bladder itself. I inflate the balloon around 50 cc. And then we put a traction. It is mostly a venous bleeding. That is the problem in this case, not the active arterial bleeding. And this is a secondary hemorrhage we have. So if the venous ooze, this is the only best way to control.
Sir, we had also put it into the bladder, but secondary in a sense, it was 4 days after the TUR. So it was bleeding because of the anticoagulants. There was no infection inside. So, and then he continued to bleed because now this is a situation where sometimes we end up because the cardiologist says, I can't decrease the things beyond a certain level because they will have a stent clot. And then if we develops an acute MI, then we will lose life. Now it's a situation on that.
So the stent there, was it a medicated stent?
It's a standard medicated stent. Medicated stent. Now no one uses this non-medicated stents anymore. Yeah. The next, I think we went ahead and then did the prostatic artery embolization. Now here comes the controversy. Who has to do this? Is it the cardiologist? Is it the radiologist? Or is it the urologist?
My center, we have got the, radiologists who are especially, specialized interventional radiology. So they are doing in my hospital. But cardiologists, I don't know how much experience they have for prostate artery embolization. So in my hospital, the
Radiologists are doing.
Sir, why not the urologist?
Sorry, again, we don't have experience. So how can I do?
Sir, we have the most experience on treating the prostate. For whatever way it is, whether it is monopolar, bipolar,
Why Institute of Cardiologists take this case?
that is what I want to put it across, that we are the ones who deal with the prostate. Right from its start, even in children, when we do extrophy, we look at the prostate, we look at the verru. So we deal with the prostate until we do an angiogram. Why do we need that? No, let us look at the, sir, 1 second.
Dr. Mallikarjun Reddy,
Sir.
in these multi-specialty hospitals, we have got these specialists available.
Yes.
Now, just listen to me.
Yes, sir.
We are urologists are doing PCNN, and who does the embolization for them? They again send it to either cardiologist or interventional radiologist. So why urologists cannot do that? So that is not the correct argument. I think so. They are more specialized for doing this work. Better to let them do it. If something odd happens to the patient, he can go to the court and he can challenge you. You are not a radiologist. How can you do it?
Sir, anyway, let us go through the embolization part and then come to this. We have gone through a, yeah, 1 second, then I'll just stop this video. Dr. Swapan sir, yes.
Just want to bring, I mean, Dr. N.P. Gupta is very aware that the initial lithotripsy machine in AIMS was actually installed in the radiology department. So there is always going to be that turf fight. And if whoever makes that turf will actually be the
Winner of it. So we did angio. In fact, I have done this this prostatic artery embolization. So this is the sheath, a 6 French sheath in the femoral the right femoral artery, and then you have a 6 French catheter going in. Then you have a 1 mm micro catheter, which you are seeing here. This is the 1 mm micro catheter, and this is a runner guide wire. This is used in this, and this is the embolization. This is a artery going in, and there is a fallen of a bulbar artery which is coming in here, which is coming from here. So we actually put in micro beads of 150, 250 microns, so that it reaches these small vessels of the prostate. We were not keen on using a coil, because if the problem with the coil is the amount of coagulation which it does into a vessel is far larger. So we may end up in coagulating much more, clotting in much more bigger vessels. So microbeads are the one which we look at going in. And you can see this vessel. This is the prostatic vessel, which is on the right side. To go the ipsilateral internal iliac is a little difficult. You need to be a little careful in terms of how to manipulate the guide wire into it. And once you have wedged it into that, you give in a microbeads. You can see that. You see this vessel here. These are the other vessels going down. And this is how we inject the microbeads. You need to have the syringe down, because the microbeads will be in the base of the syringe. So once you do the microbeads, now you can see that when we do the angio, you see this vessel disappearing. So what we will see next would be what actually we have used. The microbeads, the catheters, these are the microbeads. This costs about 12,500 rupees for each of the microbead, which is diluted to 2 cc. And if you have to do both sides, you can use both. This is the Cook catheter, which goes in standard, and this is the micro catheter. This is a 1 mm catheter. This is again a prograde, which is again that small guide wire, which the tip can be actually bent to whatever way you want. If you do a big U, that's a bigger problem, is you will not be able to torque it. So we make it about 90 degrees to 100 degrees, so that you can actually manipulate into the artery. So I think we leave it to discussion, but my ultimate scenario here is that, do we need to do this? Every year we bring out 400 to 500 urologists, new urologists into our fold. And if we start losing chunks of urology to some interventional radiologists, to other urologists, andrologists, and where do we look at holding urology to a certain extent? Now, I feel that we should have a subspecialty of endovascular urology where we should be doing prostatic artery embolizations, renal pseudo embolizations, renal tumor embolization, renal artery angioplasties, varicocele embolization, pudendal artery angioplasties in impotence. We need to get it into our curriculum. We need to take inspiration from the neurosurgeons where they do their endovascular interventions, the neurologists do their endovascular interventions. And where do we look at legality today? When nephrologists can do AV fistulas, we keep quiet. When they do CAPDs, we keep quiet. When someone does a transplant, we keep quiet. Shouldn't we go back and take back our own areas, which we should be doing? Sir, I leave it to the panel for further discussion.
I think so, Mallikarjun, what you are saying, this is the era of specialization and super specialization. The question comes to one single urologist. We have 10 subspecialties now. So how can you expect to have one more? And that job we will not be doing routinely. See, anybody can do the job. That is not a question. Question is how often you are doing it, how efficiently you are doing it, and do you are dedicated to that work day and night. That is not possible for a single urologist to do it. And as you are saying for neurosurgeons, in my hospital, I don't know, ours is a very big hospital. We have a neuroradiologist separate who are doing an endovascular neurological procedure. It is not like that the neurosurgeon. So I think so. The ideas, the areas are defined. We should not embark into the area which we don't know.
Sir, please take them.
In which actually the neurosurgeons are doing the intervention. They are not the qualified radiologists or neuroradiologists. They are the MCH neurosurgery who have taken some training only. That's all. It's not a qualified degree. It's just training, like observation and training. So there are many, like there is one in PSRI, there is one in Spinal Injury Center, and there are many in the country.
Your point is okay, sir. We can do some sort of these procedures apart from doing normal urological cases, but making that a separate specialty right now is not feasible.
No,
because there is not a lot of work.
No. The only reason I put that up is there is an area which we have lost and which we can take back. That is the bottom line. I am not saying that we should create a new specialty or we do something. Look, I have posted one more case tomorrow. That is a primary case. Tomorrow I go back. Tomorrow, 2 o'clock, I will be doing a bilateral prostatic artery embolization. This guy has gone around to the interventional radiologist and also come back. And he has said that, sir, you know the prostates better. And they have said their coils, you wanted to put microbeads. I've read about all that. The complications of coils are much higher than microbeads.
So if I'm not wrong, Dr. Amitabh, you must be remembering that in SMS, we are doing the renal artery embolization from femoral artery. So many a times we were succeeded, and I have seen 1 or 2 cases, but definitely after passing out, we didn't.
Look, nowadays, previously we were all individual urologists. Now we are a group of urologists working most of the time at every place. And each one of us can actually take up a niche segment and then develop it so that we keep urology on a bigger scale.
You know, okay, Dr. Friends is best defense. Right? So rather than let other people come into our domain, I know of a local cardiologist, very confidently cardiologist. He does a lot of prostatic artery embolization. And whether we like it or not, prostatic artery embolization has found a space in the spectrum of BPH. Somewhere there is a space for prostatic artery. Do we use that space to the cardiologist? Or do we have the, that's like Dr. Mallikarjun, so sort of go into there and do the PAs ourselves. It's not organ, it's not a cardiology, it's not a cardiac catheterization, it's not a cardiac angioplasty. Your mistake may not result in something. There's something to think about. I go a little more than this. Do prostatic artery embolization have a treatment or have any role in BPH?
Mine is too limited. I have only seen as a Facebook post, nothing more than that. And the respected cardiologist I have also heard of. Now, I would like the people from the education institutes to come forward and share with the forum is do does this treatment modality holds any ground for BPH treatment?
Kamal, just a second before we come up. First thing is, it has gone into the public that this is a part of the treatment. There are now in the EAU and the AUA guidelines that this is also a part of the BPH treatment. It is time we as urologists go out into the public, tell the pros and cons of this procedure. We are the people who know who benefits. If there are 10 modalities of treatment for a particular disease, that means one size doesn't fit all. We need to know that who is the right person who needs an embolization, and we are the right persons who could probably tell that particular individual that you need this treatment. We need to go to the public. We don't go into the public. We don't publish data on embolizations or something saying that whether this is good or bad. Let us not cry back, become a cry babies and say they are doing it, they are doing it. If you don't want to take it yourself, don't cry. I'm sorry for my language, but please excuse me on that.
Last comment from you from PGI Chandigarh.
When PCNL was started in PGI and early 90s, and at that time, complication of bleeding rate was quite high, up to 10%. And interventional radiology at neonatal level. And I have seen Dr. Goswami used to do angioembolization on the table, and embolization on the table also. But we left this area because at that time very few urologists were there. So we did venture and progress on that direction. But if you do something in programmatic way, all interventions like post-penal bleed, renal artery angioembolization, or prostatic artery angioembolization, you can develop one branch. You need not to separate it, but somebody has to give the time in that direction. Okay, thank you.
Okay, I think so.
One short. So similarly, for the transplant, there are centers where the vascular surgeon is being called to do an anastomosis. So it's leaving your field to the others. How much we want to leave or how much we want to retain.
That was the old time. Now things have to be.
There are still centers.
Okay, thank you very much. Welcome.
Thank you, sir. For the next session, Dr. Himanshu and Dr. Shashank are online. They could not make it in person, so they would be discussing their cases online only. Dr. Himanshu, go ahead.
Yeah. So good afternoon to all respected dignitaries and attendees. So first of all, I would like to thank organizers, Dr. Sopan Sood sir, and North Zone Council, especially Dr. Rishi Nair boss, for giving us the opportunity to present some interesting case scenarios in front of you. And again, I sincerely apologize for not being able to be present there physically because of the logistics. Our flight got cancelled. So to start with, आज गुरु पूर्णिमा है, तो सभी गुरुजनों को सादर चरण स्पर्श हमारी तरफ से प्रणाम. एनपी गुप्ता सर, स्वपन सर और सारे गुरुजनों को हमारी तरफ से प्रणाम. And so in day-to-day practice, we are consulting the patient with lower urinary tract symptoms and with raised PSA, borderline raised PSA, and we need to go for the biopsies. Then there are few scenarios where we, or especially the beginners, got confused that whether to go for the biopsy, go for MR, or need to repeat biopsy, or what to do. So there are some special interesting scenarios which we will discuss, and my fellow colleague Dr. Shashank will discuss these scenarios. We have 3 clinical scenarios, and we'll try to finish within 20 minutes. And over to Dr. Shashank.
Good afternoon to all esteemed members, and seek your blessings on this auspicious day. I'll start without wasting much time. So this is a case. We have a 55-year-old gentleman. He's ECOG 0, no comorbidities. There is no significant family history. He had mild LUTs in the last 2 to 3 years. Recently got a PSA checked and it came out to be 9. DRE is benign. So my question is, I'll start with the respected NP Gupta sir. Sir, how do we proceed in this case, sir?
I like to repeat one more PSA after an interval of 2 or 4 weeks. If second PSA
Okay,
is
sir.
not too high, I like to go for
Okay.
MPMRI. That is our practice. And according to the
Okay,
report
sir.
of MPMRI, then I will decide to do the biopsy or not to do the biopsy.
Kamal sir, any difference of opinion, or Umesh sir, any difference in opinion regarding what sir said?
See, when you have a PSA of 9, first is rule out
Yes,
an
sir.
active infection. If it's not there, then repeating a PSA after 2 or 3 weeks is the correct idea. And if it's still come elevated, then MPMRI is the next course of action.
Amitabh sir,
Shashank, I would like
yes,
to
sir,
have
yes,
the
sir.
urine culture report is not there, urine routine or culture.
Urine culture is sterile, sir. We assume that is sterile, sir. In this case, we'll start with that. Urine culture is sterile. He is having a PSA of 9. The LUTs are mainly obstructive LUTs. There is no dysuria and suggestive features of fever, anything suggestive of UTI in this case. We'll start with that, sir. So, Amitabh, sir, any role of antibiotic here before we move on?
No.
Amitabh, sir?
Yeah, I can hear you, Shashank. So there is no role of antibiotic because you already told that urine culture is
Yes, sir.
normal, sterile, urine RM is normal. So there is no role of antibiotic till now.
Okay. So, sir, before proceeding, what we did, so this is a little review of literature. I'll not go into the detail. These are the two prospective randomized trial. One in which 2 weeks antibiotic was given, and in the other one 6 weeks of antibiotics were given. And both of these trials came out to be negative. They have been included in the recent guideline also. And after these trials only, the guidelines have been formulated. This is the AU recent guidelines. So no empiric antibiotic for elevated PSA in asymptomatic patients. So my question is from Virendra sir. Sir, does this hold true in our Indian scenario? Like we get like a lot of patients who are coming with elevated PSA have some history in the past. Now urine culture may be negative. Do you ever try this, that just get an antibiotic for 2-3 weeks, let's repeat a PSA, or you always follow this AU guideline?
In my practice, I give antibiotics, low dose antibiotics. Though the culture or routine is normal, I'll see the trend, follow the trend after 3 to 4 weeks. And that is if PSA is decreasing, then I won't go for the biopsy. In routine practice, I give a low dose antibiotic.
Sir, what do you mean, sir, by low dose, sir? Which antibiotic you prefer, and what, like, can you specify, sir?
Either the nitrofurantoin or this one, Xenocin.
Okay, sir. Okay. So, and I'll final comments for NP Gupta, sir. Sir, can you enlighten us on this? Is this correct, sir? Can it be followed, or in Indian scenario, sir, our scenario?
No, I will repeat a PSA. That's all. After 3 or 4 weeks.
Okay, sir. Okay, thank you, sir. Thank you. So we repeat a PSA. So what is the evidence? Since sir told that there is the latest EAU guidelines in asymptomatic men with prostatic PSA between 3 to 10 and a normal DRE, repeat a PSA test prior to further investigation. Although the rating is weak, but this is what, as sir told, we are also doing, and I think most of the panelists will also agree. So we got a PSA after 3 weeks. 8.6 is the PSA, sir. Sir, NP Gupta, sir, what's next, sir?
No, I like to do MPMRI. That is our practice. And before I do that, I will do the counseling of the patient. I will tell him that your PSA is raised, and there are 3 causes of the raised PSA that I will explain to him: BPH, CA prostate, or chronic prostatitis.
Okay.
And
Yes,
we
sir.
like to know the cause of the raised PSA. And I will
Sir.
tell him that if it is high, if your findings are altered in your MRI, you will undergo biopsy. So this I will explain to him before I do MP-MRI also.
Umesh, sir, any role of antibiotics now? Supposedly, we have not given antibiotics, like sir said, not to give since patient was asymptomatic. Now, any role, or we go for MRI now?
No role of antibiotic right now. Just go ahead with the MP-MRI in this case.
Okay, sir. As the panel told me, yes, according to the panel, we got the MRI done. And what is the support for this? So the Americans still a little doubtful. They have used the word may, but the Europeans are very strong they have a strong opinion for MRI. So EAO guidelines 24, perform MRI before prostate biopsy in men with suspected organ confined disease. And clinicians, according to AA, you may use the recommendation level is grade B, evidence level is B. So we got an MRI done here. We got a lesion in the right anterolateral and posterolateral zone, size of around 2.8 into 2.4 centimeter, pyrites 5. So my question is from Virender sir. Sir, how do we proceed now? So we have a positive MRI, pyrites 5. Sir, what is the next step? Virender sir.
I will go for the trust-guided prostatic biopsy 12 course.
12 course trust guided biopsy. Amitabh sir, you just had a very nice talk about target biopsy, sir. Only 12 core biopsy, sir. Anything you want to add, sir?
Okay, so this is Pirates 5, quite big lesion, 2.8 centimeter. So
Yes, sir.
I think trust biopsy is enough for this patient.
Okay, sir.
Fusion biopsy actually is required if the lesion, the size of the lesion is very small. Because I hope this lesion is must be palpable now in the DRE also.
The DRE was normal, sir.
Because what I see in this MRI images, this is a Pirates 5 lesion. This must be palpable in the DRE also. So for this patient, trust biopsy or transperineal, whatever. So this is a debate actually whether you want to go for transperineal or transrectal, but just ultrasound guided biopsy is enough for this patient.
Ultrasound guided biopsy.
So Amitabh, so what do you prefer in this particular case presented to your center, transperineal or transrectal?
Okay, sir. So
If you are equipped with both of these modalities.
Okay, sir. So now if we'll talk about the whether transperineal or transrectal, so there are two objectives before deciding for transperineal or transrectal. First is yield, whether you will be getting much higher yield for the transperineal or not, and what is the chances of complication. So it has been seen that the infection related complication, they are released with the transperineal, provided if the patient is not getting targeted prophylaxis, antibiotic prophylaxis. Which I don't see any institute in our country is doing, like getting the rectal culture before doing the transrectal biopsy and getting the culture sensitivity and giving the antibiotic depending on the rectal bacteria. Depending on the yield, if we'll talk about, then the anterior lesion are the one which are having a significantly better outcome in terms of transperineal. Those lesions which are at the peripheral zone, the yield is almost same whether you are going for the transrectal biopsy or transperineal biopsy. In this patient, the lesion is going from 7 o'clock to 11 o'clock. So there is a much burden of the disease is at the peripheral zone. So that can be targeted very well with the transrectal biopsy also. And if you'll see, in our country, there are only handful institutes who are having or who are doing transperineal biopsy. Rest all the institutes, they are doing transrectal biopsy. So this patient can be done with both technique, whatever facility is available with you.
Okay, thank you. Shashank.
My next question is from Kamaljeet sir. Sir, supposedly now this is a very obvious lesion. Amitabh sir already told very big lesion. We'll take a trust guided biopsy. Sir, had it been a normal DRE small lesion, will your opinion change? Like I'll move to the next slide now to make the question more obvious. Will go for a MR fusion biopsy, sir, or you'll go for a cognitive biopsy? Sir had already given a talk just half an hour back, sir. What is your opinion, sir, regarding this?
Shashank, at Amritsar, we don't have a facility of MRI biopsy, so we will go by the standard trust guided biopsy with a directed biopsy from the lesion. That's what I will be doing.
Umesh sir, any difference in RML, sir? Anything, sir, different you are doing, sir, there?
So in RML, we still don't have the fusion biopsy option, but what we do is that the standard, in this case, standard 12-core biopsy plus targeted biopsy from that lesion, extra code from that lesion. 3 or 4 lesions.
Okay, sir.
That,
Okay. NP Gupta, sir, anything, sir, your preference for any, since you are working in the big corporate setup, sir, any other thing, sir, we can like fusion biopsy will be beneficial. Anything you, sir, add?
No, as in this particular case, trust guided cognitive fusion can be done. You have
Okay,
the
sir.
image, now you know right side you have to focus. So you can do a standard 12 core and you can take 1 or 2 extra core from the right side. I think so that is good enough.
Okay.
But I will explain to the patient if he's interested in fusion biopsy. We have got the facility and I will not hesitate to do a fusion biopsy also.
Sir, so Sir.
I think most of the institute, they are doing cognitive fusion biopsy right now because they don't have the software with their institute.
Sir, so my yes, sir. Sorry, sir.
But for a small lesion, I think it's very difficult to target these lesions with cognitive fusion biopsy. But this is very large
Agreed.
lesion.
Agreed, sir. So, sir, my next question is from Virendra Sagar, sir. Extent of the biopsy, I think Umesh sir already answered that he'll go for MR targeted plus systemic 12-core biopsy. So, I think any difference in opinion from the house on this, sir? MR target plus systemic. Amitabh sir was saying that it is very big lesion, so systemic will cover. So, I'll just skip around because we have lack of time. So, this is the evidence for MR targeted biopsy. So, I'll say that according to the EUA, adding systemic biopsy with targeted biopsy really helps. Omitting will miss some 16% of the detected grade group 2 cancer and around 18% from the grade group 3 cancer. So it should be added with the targeted biopsy. So just finishing in 2 minutes, a question from Amitabh sir. Sir, how many cores from the target lesion, sir?
I think 3 to 5 is enough. It all depends on the Pirates score. Like whether it is a 5, Pirate 5, 4 or 3, because there is a concept of index lesion, then umbra and penumbra. So what happens actually, so it is not only the lesion, it is the perilesional area also which can harbor the clinically significant prostate cancer. So if it is a Pirates
5. Yes, sir.
yes,
Yes,
so
sir.
if it is a Pirates 3 lesion, then there are chances that you can have a clinically significant prostate cancer up to 1.5 centimeter of the periphery of that index lesion. Whereas in
So you are
Pirates 5
saying
score,
perilesional also will take, sir. Perilesional biopsy also will take, sir.
So that's why, so you should take 3 to 5, where 2 to 3 from the index lesion and 2 to 3 at the periphery of the lesion.
Okay, sir. So this is what the support for this is from the EAUA guidelines also. You should take at least 2 cores from the target, as Amitabh sir told, and some perilesional biopsies also. So this is the pathway what we are following. It is a combined pathway with, if the MRI is positive, you go for systemic plus target, negative biopsy, negative MRI, you go for systemic. Or we come the MRI pathway. In positive MRI, you do biopsy, negative MRI, no biopsy. So this is little gray and white and black only. So we have to find a middle path. So this was a paper recently published in a radiological journal actually, in which they said that there has to be some middle path. So PSA density, family history, and a positive TRE they used. And they said that even if the MRI is negative, you have a Pirates 1 or 2, and the patient has high risk feature like PSA density, DRE positive, or some family history of prostate cancer in young, you should do a. So this is a risk-based pathway. And they found that the cancer detection rate was 97 and the biopsy avoidance was 19. So we have to balance between overdiagnosis and underdiagnosis. So this came the winner in this paper. So this is the summary. Scenario 2, I'll just do, if initial MRI is negative with elevated PSA still, what next? NP Gupta sir, can you just give your valuable thoughts on this, sir? Initial MRI negative, elevated PSAs.
If he has the symptoms of the LUTs, then I will try to give him some alpha blocker also. And then I will like to wait for 3 months. I will repeat the PSA at the end of 3 months to see what is the PSA level. And then I will take the decision to go for a repeat MRI or go for a repeat biopsy according to the PSA will decide.
Sir, any other marker apart from PSA we can use during this observation period? Anything else which can help us?
See, my suggestion is that if patient, we explain to the patient, we have got PHI is available in Delhi. We have got
Okay, sir.
And Calicrine 4 assay also has been done in USA, but these
Okay,
are
sir.
very costly. So in clinical practice,
Sir.
I will inform the patient. If he's interested to spend money, I will get those tests, because all these tests will give you a percentage probability. None of these tests is a 100% definitive. So you have to use your clinical judgment according to the patient and decide for the next repeat biopsy or not to do a repeat biopsy. In routine clinical practice, we don't do these markers.
Okay, sir. Agreed, sir. Agreed. So this is the AUA flow chart for a negative biopsy scenario. So we can use adjunctive biomarker, as NP Gupta sir told. If available in the market, we can use PCA3, PHI. And if MRI has not been done earlier, like in this case it was done, if not had been done, there is a very strong recommendation to go for MRI in the second sitting, and if positive, for a biopsy. You can see at the bottom of the slide there is an asterisk and this. If adjunctive biomarker is positive and your MRI second time is also negative, you have every right to go for a systemic biopsy. I think this is not a very common scenario, but everybody sitting in the hall may have seen this, that MRI is negative and these markers are PSA density is rising. I think time for go for a systemic biopsy. Amitabh sir, anything to add on this? We're just concluding, sir.
No.
Anything I'm missing?
No, thank you very
Okay.
much. Good
Oh,
discussion.
okay. Thank you, sir. Thank you so much, sir.
So thank you, sir. Thank you, NP Gupta, sir. Kamal first.
Thank you, Dr.
Thank you.
Himanshu and
Thank you,
Dr.
Rishi boss.
Shashank.
Thank you, Sopan sir.
Yeah, so we'll move on to our last session. This is again a very important and often neglected topic, which is the patients with concomitant CA prostate and BPH LUTS symptoms. Now, the management of these kind of patients is not often mentioned in our books. And for this session, may I invite, thank you, Chairperson, sir. May I invite the next set of chairpersons, Dr. Aditya Pradhan, Dr. Sopan Sood, and Dr. Rajiv Yadav. Please.
Good afternoon, everyone. Thank you, organizers and Dr. Rishi, for inviting us here. I welcome all my panelists. So we have two scenarios today. The first one would be the medical management of LUTS in non-surgical patients of carcinoma prostate, essentially metastatic carcinoma prostate. Other scenario would be the surgical management of LUTS in patients who are on active surveillance that my colleague Dr. Ashish will speak on. So we'll go ahead with the first case scenario. So this is the index case, 70-year-old male. He is a comorbid patient with history of CAD, status post, CABG, diabetic patient with a history of severe obstructive LUTS, IPSS of 21, uroflowmetry Qmax of 10 and obstructive pattern, PSA 63.1. MPMRI showed locally advanced disease with indistinct plain with rectum, pelvic lymph node positive, and a prostate size of 70 cc. So trust biopsy shows 8 out of 8 of sorry, this is Gleason score of 8, 10 out of 12 goes positive. PSMA PET scan showed multiple lesions in the bone, both in spine and pelvic bones, also paraiotic node positive. So treatment plan, this based on the number of bony lesions that came into a high volume disease. So the treatment plan for these patients was essentially a androgen deprivation therapy coupled with a second drug. So my first question, Dr. Pradhan sir, would you take? So this patient, we know the treatment plan for the carcinoma part. So do you think the ADT alone, as we are going to give him, is enough for his LUTS? We'll talk about if you want to add anything. I just want to know from you, what is the effectiveness of ADT in these patients in terms of decreasing severity of LUTS in terms of IPS, and whether they help more in obstructive symptoms or they can help in irritative symptoms also, and in terms of prostate volume.
So from what you have said, this is in generic terms, if I speak, yes, ADT does help to reduce the symptom level, but with a extensive disease like what this gentleman has got, whether this will be able to correct all his symptoms is difficult to say. So the way we have been handling such a situation is that we tell the patient right at the outset that we start your medical therapy, we have started doublet therapy, and we reevaluate after a period of about 2 weeks. If he's better off, we can avoid doing anything further. If he is not improved with that, then probably I will need to address his symptoms by way of a channel term. I may have to consider.
So you want to add anything, sir?
Yeah, I think one of the choices of the ADT will also matter in this.
Yeah, so we are coming to that. That is the next question. I'll come to you for that. So this study showed this is a prospective study, Japanese study, which evaluated the role of ADT in these sort of patients and the patients who had any form of primary treatment or were on any alpha blocker or any 5-alpha reductase were excluded in this study. So mainly CA prostate patient not having received any form of treatment, and it was seen that the significant volume reduction, and they were followed for 24 weeks. Significant volume reduction, which is defined as more than 30%, was seen in these patients. And the IPSS voiding score, total score reduced significantly. And it was mainly the obstructive score, voiding score, not the storage symptom, which was significantly affected. And also, if you stratify according to the IPSS severity, so those patients who had moderate to severe IPSS scores at the outset were having more benefit as compared to the patients with mild. So, Sopan sir, like you were saying, you think what type of ADT like LHRH antagonist would be more beneficial as compared to agonist or anything?
I don't have the literature report for this, but I would think with such a high IPSS score, which is already in the operative section of the assessment, I would rather go for an immediate decrease of the testosterone rather than the wait for the flare and do a retention.
So basically, either a orchiectomy in older patients or maybe a LHR antagonist. You want to say. So absolutely true. So these patients do better in LHRH antagonist group. So this was a study against again a randomized control study of 182 patients with no basically no criteria of baseline IPSS, but 77% were having moderate to severe LUTS, and primary endpoint was total prostatic volume and severity of change in the IPSS score by LUTS. And it was seen that although both antagonist and agonist reduce total prostatic volume, but the major change was seen in the significant change, which was defined as more than 3 points difference, was seen in an antagonist group as compared to the agonist group. And the percentage of patients increased with this sort of response increased over 12 weeks as compared to 4 weeks. Even at 4 weeks, there was a significant difference in percentage of patients. So, Dr. Rajiv sir, you think adding alpha blocker to these patients are going to help anything significantly? Is it going to make a significant difference in that?
Yeah, I think the idea in such group of patient is to have the action fastest. And that way, whatever helps him improve the symptoms should be started. And that's where alpha blocker play the role. But one point is that all this argument about using bicalutamide, using fastest acting antagonist is probably a thing of past. Now, when you upfront start dual anti-androgen with the enzalutamide or abiraterone along with ADT, the question of flare-up goes back. The question of rapidity of action goes back. Question of difference between agonist and antagonist goes back. So things have changed with the change in the practice pattern. So of course here alpha blocker should be added.
Yeah.
But if we are using doublet, other questions are also things of past.
Okay. So yeah, that's true. So adding an alpha blocker again will help in reducing the total IPSS, also obstructive IPSS as compared to the irritative. Irritative symptoms are not going to be benefited with this definitely. And this difference is mainly seen after 8 weeks. There is no significant difference in the first 8 weeks if you're adding alpha blocker, even giving ADT. But after 8 to 16 weeks and then 16 to 24 weeks, the maximum difference you are going to see. So the patient has come to you with in retention or a very high PVR, and you're going to put a catheter for him. Do you think with ADT we can obviate the need for channel TURP? Or and the second thing is, do you think that grade of prostate or the Gleason score, T stage, anything has to do with trial of wording? Dr. Pradhan sir, would you down for that?
What we know from data is that you achieve about a 30% volume reduction with your ADT. That's about all that you would achieve. So if to begin with, it was a very large gland and he was in retention or he is almost impending retention, your ADT is not going to change things very much for him. smaller gland, yes, you might be able to say that ADT will work. So I think the square off is not very clearly defined. At this you can do ADT alone, and this requires shallow. It's not like
Our patient has a size of 70
grams.
cc, but this is a study which is from Dr. Sood's center only. In this, the average size was little smaller in this, as you rightly said. But for this study, they evaluated the role of ADT for trial of voiding at 1 month, 2 months, and then 3 months. And 101 patients, 27 voided at 1 month were successful, and 50 at 2 months, and another 20. Total 97 patients out of 101 at 3 months were pre-over. But we don't know, because long-term follow-up is not given in this study. We don't know after 3 months how many had to, again had retention or had to undergo TURP. But at 3 months, this scenario was that only 4 patients required. And based on the other criteria, DRE grade, Gleason score, there was no correlation as to who will fail and who will not.
I mean, I was just trying to bring this out in your first question only, when you said when ADT alone suffice. That's where you started off this discussion. Because there is a lag, it takes at least a couple of weeks before you will understand. I mean, in clinical practice, would you be able to hold like this patient? He is going to demand therapy from you.
Yeah.
So would I be actually able to hold this guy off for 6 weeks or 8 weeks?
Yeah.
So in real terms, I think we don't wait so long. Clinically, we wait maybe a week, at best 2 weeks, and then we intervene if he is not adequately controlled.
I think one of the important points for consideration is also what he said is absolutely contradict that, and we have to make a personal decision for each patient. But I think also in a Gleason 8, we need to consider the number of interventions of bladder outlet obstruction which we are going to have over the next few years as we manage this patient, and whether one less will actually matter or not. So keeping that point in mind, I would like to postpone the first surgery as long as possible, so that he come up for a second intervention.
Right. So, yeah, thank you. So my last question before I hand over to Ashish for the second scenario. So can you actually predict which of the patients would, of this CA prostate, which of the patients would actually need a channel TURP? Means a patient has come to you with CA prostate, and which of the patients would actually, any predictors you think are important, as whether it's a age of the patient, whether it's a PSA of the patient, whether it's a prostate size, whether the patient presenting in the retention, or whether it is, a Gleason score. So do you think any of these patients, any of these predictors, Dr. Rajiv?
No, I'm not aware of any of such predictors.
So, yeah, so this was the study from HGVJ, it's around little older study, but they evaluated these patients, and the patients who already have retention, and especially those patients who have a Gleason sum of more than 7. So those were the patients who did poorly, and who wanted, who needed TURP. And of note, that patient who did not present with retention and Gleason sum of less than 7, they did not need TURP. But the patients who successfully voided, but then had a Gleason sum of more than 7, in the longer term, they were the ones who again needed TURP. So if you have a patient who is already gone into retention, although you may wait for 3 months or so, and especially if the patient is having Gleason sum of 7, so he is going to go need a TURP. So thank you for this scenario. I'll just give it to Ashish for the second scenario.
Good afternoon, everybody. Thank you for this opportunity. Can we have my presentation? So this is an interesting topic that was given by Dr. Rishi sir. So we'll start. So this is, the slides have gone from my screen. So this 67-year-old gentleman is sexually active. He has no comorbidities and he has lower urinary tract symptoms for the past 6 months. He was evaluated outside and these symptoms were primarily obstructive in nature. He was prescribed silodocin and his symptoms improved. However, he landed up with acute retention of urine 2 months back, for which a catheter had to be placed, and somebody did a PSA outside, which was at the time of retention was 23. Although this retention was on alpha blocker therapy, another trial of voiding on the same therapy had failed, and then he presented to us. On further evaluation, he had a grade 3 prostate, no nodule was palpable. On catheter, the PSA was repeated after 1 month, and this PSA had come down from 23 to 9.6. An ultrasound revealed the Foley's was in situ, prostate was 111 grams, and kidneys were normal, and the culture was sterile. So, in view of a dubious PSA between 4 to 10, we did a multi-parametric MRI for him, and we found that there was a Pyrites 4 lesion. A large median lobe was there, and there was a Pyrites 4 lesion here here we can see there's a small lesion, Pyrites 4 lesion in the peripheral zone in the midline at the apical region. In another section, I'll show the coronal cut. We have a large gland. A large median lobe, Foley's is in situ. So this patient underwent a transperineal MRI truss fusion biopsy. The targeted cores were 3 cores were taken. All 3 were positive for Gleason 3+3. Maximum core length was 10%. And the systematic cores that were taken from the entire prostate were BPH with chronic inflammation. So this patient was very apprehensive about the side effects of radical radiotherapy or prostatectomy, and his disease status at present did not warranty such radical measures. So I would like to ask Dr. Swapan sir, is there anything that we can offer for this gentleman who has a very low volume prostate cancer, but a very high volume BPH that is at present the issue at hand?
You want me to tell you how I would manage this?
Yes.
So he has had an acute retention.
Yes, sir.
And you have given a catheter-free trial, which has failed.
Yes, sir.
His PSA is 9.61 and Gleason score is 3+.
Yes, sir.
That's basically a low-risk prostate cancer.
Absolutely.
And with the severe outflow. And the patient is, what is the patient? Have you discussed with the patient the impact of radical prostatectomy versus radiotherapy?
Exactly. So he has been told about the option. As it is, the disease itself does not warranty radical therapy because it will not kill him. But his LUTs are very disabling. But he's very apprehensive. He does not want incontinence. He wants to preserve his sexual life till possible. So is there something that we can do so that he can continue to enjoy his... is there anything specifically I'll ask for this BPH part that we can do?
So I think you can try another catheter-free trial if the patient is really this thing. You can give him dutastride and all, try to keep it, shrink it a little. All the time you need to keep warning him that that those people who go on observation, almost 50% of them or more than that will end up with some kind of a radical. One of the other things which in my mind, I would keep clear about this patient, that perhaps this is not an ideal patient for radiotherapy, being the bulk volume of the prostate is not a very good candidate for a asymptomatic radiotherapy or even a curative radiotherapy. So I would tell the patient, okay, I would like to operate on you. I would like to do a radical prostatectomy and remove the prostate simply because you need a surgery and the cancer will be removed along with. We don't have to go into the complications of observation and watchful waiting. At the same time, if the patient is not ready for a radical treatment because of his factors about incontinence and erectile dysfunction, I could offer him a holmium laser enucleation of the prostate. And I would tell him that will not remove the cancer. The cancer is still going to be there. You are going to keep needing observation, even if your PSA comes not. And I would warn him that active surveillance is not inactive surveillance. You will need a biopsy every year. You will need an MRI every year. And if there is change in the Gleason score or there is a change in the MRI picture, then you are probably a candidate coming up for the radical procedure later.
Very well said, sir. So now, practically, we are dealing with benign component of this patient, which is refractory to medical management. So my question to Dr. Pradhan sir now is, now I've listed various options: radical prostatectomy, which he is not in favor of currently, TURP, HOLEP, Urolift, or robotic simple prostatectomy. Pradhan sir, would you would like to offer any of these to him? And if yes, why and why not?
No, you said RP is as it is.
Yes, sir.
Is not an option.
Yes, sir.
Now, question is whether Urolift is going to work in such a large prostate.
Yes.
So very little data that it works beyond 70 or 80 grams very well. Then it's because of the potential. Can't actually offer that either. So what I'm left with basically is and yes, I'm happy to offer him a talk which can be very easily executed. Regarding a robotic simple prostate, normally I confine myself to 100 plus grams of the planet, which is not amenable to transurethral procedure. Instead of going in for a whole, those are the patients I offer.
So this is 111 gram.
Yeah, but I will not be very sure about my claim of enucleation, and therefore I would not be happy doing a robotic simple prostate. I would go for the simplest.
Okay. So I'll be reviewing the literature. So what I'd like to say is that LUTs requiring medical management for active surveillance is 1/5 patients. Almost 1/4 will have some medical management, and around 2% will require some surgery for this BPH. This is the data from almost 1 million patients who were on active surveillance, and almost 20,000 required some procedure, of which, because this is the older series, TURP, simple prostatectomy, photovaporization, and HOLEP were the most commonly used procedures. So our decision to offer some part of this BPH surgery would be based on its efficacy and durability in these patients. So for this photo-selective vaporization, it has been shown to reduce the volume of the prostate. The LUTs improve drastically. There is a median PSA reduction of 34%. When we come to robotic simple prostatectomy, first of all, multiple series have shown that it is feasible. When you are dealing with this is actually a benign gland. There is no disease in the transitional zone. So the problem of finding a plane will not exist because it is a low volume disease in the peripheral zone, first of all. Secondly, in this series of the median size was 157 and almost 10 patients out of 23 had retention and all of them successfully avoided. And they continued to be in active surveillance, most of them, despite having this procedure. So their PVR reduced from 295 to almost negligible, and only 2 patients progressed on active surveillance and they were treated with radiation therapy. Coming on to holmium laser enucleation, in this study of 20 patients, the median size was 99, median volume resected was 65, and there was drastic improvement in these patients in terms of their lower urinary tract symptoms. So first of all, we have established that these BPH procedures can be useful in patients where the LUTs is caused by the benign component. So we decided we'll offer this patient HOLEP. So would you want to review the biopsy of the transitional zone or the enucleated part of the prostate that you sent for analysis? Would you want to review it in this patient, or are you satisfied that after a fusion biopsy, it is mostly going to be benign?
Yes, I was coming to that. I actually wanted to comment on that. That if the biopsy comes negative, don't be surprised. The cancer was mostly in the peripheral zone, and likelihood is that second problem is going to be that the sampling percentage which you do and from where you sample, all the chips are going to get mixed, whether you are doing HOLEP or this thing, and the chip which contains the cancer, whether it is going to turn up in the pathologist slide or not is another factor which you have to keep in mind. So you have to warn the patient that if the biopsy comes negative, then don't get all enthusiastic that you don't have a cancer and the biopsy initial biopsy was wrong. You're still a candidate for active surveillance. But at the same time, if it comes positive and it comes positive in a significant number of chips, then probably the diagnosis has moved from a low risk prostate cancer to a higher risk
Absolutely.
Prostate cancer, and you have to modulate the treatment accordingly.
Exactly.
But this patient would now become a candidate for radical radiotherapy also, because now the volume of the cancer
Perfect.
is
Yes. Rajiv sir,
if I may interfere here.
Sir.
So there is prostatectomy, robotic prostatectomy described by Dr. Hemal group only in these kind of patients where you go either do it as a phase or as a Millen's prostatectomy. But rather than removing only the adenoma, because in these patients, peripheral zone is mostly compressed and thinned out. So go outside the prostatic capsule, remove the sort of entire prostate from within only, so that you don't injure the neurovascular bundle and all. And but remove the entire prostate along with the peripheral. So this is described by Dr. Yes.
But I feel that preservation of neurovascular bundle, the peripheral zone is still there. If you want to remove the peripheral zone, might as well take the
the whole radical prostatectomy as it is. We'll be better off with that way. So what I want to say here is there any concern that the morcellated tissue of the whole specimen may not be a representative sample to comment on the malignancy? Yadav sir?
Yeah, that probably was addressed by
What I mean to say is the morcellation, does it distort?
that kind of that suspicion can be raised in the first stage of the biopsy itself that it was undersampled and all this decision was wrong. The undersampling or the upgradations is going to affect subsequent radiotherapy, subsequent decision about any further surgery. I'm sure the patient should be explained that you will not be able to get everything. Here, I will strongly oppose him radical prostatectomy, not this.
Okay. So a point that I wanted to raise is that it has been seen that holmium laser enucleation versus the transurethral resection of prostate, large amount of tissue is received by the whole specimen. It is adequate even after morcellation for interpretation of cancer. So the next thing is that we have to understand whatever management we are offering, what impact it has on follow-up strategy. So when I raise the question of urolift, for example, I'll just go into that. Even if the prostate was 50 grams and he is on active surveillance, I would not offer urolift as a procedure because it interferes with the MRI performance after the procedure itself. So for patients where active surveillance is being contemplated, any mechanical device that is going to be inserted in the prostate is absolute no. That is one point. So the next thing is that after the this simple prostatectomy or HOLEP has been done, how do you follow your patients? If what exactly would you tell them? What PSA decline are you expecting? Is there any value that you're satisfied with in the post-operative period? Any of the panelists can answer this. I mean to say that active surveillance is PSA plus MRI. So what PSA value are you expecting in the post-operative period in such a patient?
So I think we have to re-establish the baseline. So re-establishment of the baseline mean after 3 months, you repeat the PSA, probably you will repeat the MRI, establish a new baseline because you will not be able to use the previous MRI now. The effect of HOLEP or TURP will also be there. There will be sort of fibrosis, which will be seen on the MRI. So re-establish the new baseline for MRI as well as the PSA and then start following from there. Any significant change from this will be your benchmark for subsequent intervention.
Absolutely. So in this study, they have shown that after holmium laser enucleation and simple prostatectomy, there is almost 80% reduction in PSA values despite the cancer being untouched. So most of the PSA is produced by the adenoma itself. And with procedures such as HOLEP and simple enucleation, there is a durable response of the PSA. However, if we see for TURP, because we know that we are not able to remove the entire adenoma, the PSA decline is less and there is multiple variations in the PSA. So the monitoring in the post-operative period in such a patient becomes easier with HOLEP or simple prostatectomy rather than offering them TURP because adenoma is still there. And this study also, they have shown that the durability has been seen over a period of 18 months. So there is another point that after HOLEP in such patients, PSA should decline by more than 70%. Studies have shown that in intermediate risk and poor risk patients where you diagnose prostate cancer after HOLEP, their decline in PSA was 50% or 0% for high risk. A decline of more than 70% should point that you have done a good job and there is an insignificant cancer in the prostate only. Finally, let's talk about what is the effect of any therapy on MRI. So multiple studies have shown that any prostatic intervention is going to reduce the accuracy of MRI. So we have to be more cautious and we have to be alert for picking up cancer. And these alterations can occur because there is gland deformity and residual adenoma can make interpretation difficult. Microhemorrhage can make the prostate hypointense, making interpretation difficult. So the first MRI after any procedure should be done only after at least 6 weeks to 3 months. And finally, after HOLEP, the residual peripheral zone can have granulomatous prostatitis in almost 7% cases. We all know that prostatitis can mimic cancer and this can be a confounding factor.
finally, as I already described, for prostatic urolift, it makes the gland obscured. And uh, finally, we all know that post URP, we find that we need to reconstruct the bladder. There is an impact of this surgery on the final surgery if this patient progresses. I would just like to conclude that outcomes of radical prostatectomy after HOLEP or any procedure takes a little longer because you need to reconstruct the bladder neck in most of the cases. The continence, final continence is equivalent, but the recovery is slightly delayed, and the erectile function, despite nerve preservation, may be impaired. So these are the points that we need to discuss with the patient if we are following this pathway that we have discussed in this case. Thank you very much for your patient listening. Yeah.
For this question, what is your take for HIFU and on-table TURP? If I mean, was this discussed or if this
So
patient?
for a gland that is 100 cc, there is no role of HIFU. Even
No,
if you do
if the
TURP,
lesion, if the lesion is posteriorly, you can do HIFU because
no,
it
for
has,
so you have to understand that a size constraint is a very big constraint for HIFU.
okay.
But despite and in larger glands without MRI fusion, you may not be able to target it properly. Your most of these patients will not benefit
But
much
on
with
the MRI, the lesion was situated posteriorly in the peripheral.
that. I
Now,
understand. Yes, yes.
let's say focal therapy, cryotherapy plus this.
For such a
TURP.
large gland, I would still not offer HIFU. But
no, I am saying cryotherapy.
Cryo is usually not indicated for peripherally located lesions, which is
No, that I know, but since this lesion is posteriorly located, but it is very well doable HIFU.
our main focus is in this patient is not to treat the cancer. We are not treating the cancer in any of this patient. Our main focus is the benign part that is causing the LUTs.
Yes,
And that is why we are focused on the management of BPH in patients with active surveillance.
Presentation is not about the choice of treatment for the cancer, but for the benign.
I understand, but the patient is concerned about the radical treatment and effects of ED and incontinence. So the better alternative, which will treat, for example, this patient will definitely require general anesthesia, for sure. So if we are giving general anesthesia, this patient can be subjected to.
So please don't mind. We have heard our seniors say that if you have a hammer, everything looks like a nail.
Yeah.
So in this 3+3 with 10% core positive, he is definitely not going to die of cancer.
Exactly.
So my aim here should not be to deal with the cancer. It should be to relieve the LUTs. I agree. If the volume would have been more, a sizable lesion would have been there, I would do a HOLEP, wait for 3 months. Maybe if the prostate is amenable to some form of focal therapy, offer that.
Okay.
Not for this patient.
Thank you very much. Very nice presentation. Please.
So with this, we come to the end of our program on BPH 360 degree. Before we disperse, may I call upon everybody to please come on the dais. We'll have a group photograph together. All those who are available, all the faculty and delegates, leave it, leave it, leave it. Leave it. Excuse me. So we can have a group photograph together. Please, all the faculty and delegates can come forward. Thanks, Karlan. Thanks, Karlan. Hopefully. I also have a brief announcement to make. You see, Norzone is making efforts to reach out to all its members and the urologists outside of the Norzone, and we have the social media handles being done by Dr. Harshit. Is taking the lead in that. So all of you can please join us, like us, and tag us. And let us join hands in reaching out to the world outside of North Zone. Thank you. With this, may I invite all the delegates, please come on the top. We'll have a group photograph.
नहीं चेयर रहने दे।
So, एक बस 10 सेकंड बोलना है। I'm Dr. Atul. Kamal. So, dear all, on behalf of the President of the North Zone Urology Society of India, we come to the end of this wonderful midterm meeting on BPH 360. I'm extremely thankful to Dr. Sapanthu, Dr. Atul, and the whole team of Patel Hospital who have done a job which was not an easy job. Wonderfully executed conference, more than 16 cases done, and I thought today is going to be a dull day. But believe me, I just sat here and learned a lot. We are extremely impressed by the kind of audiovisual, the kind of hospitality, and the teamwork which has been done by the team. And friends, it is not the end of the conference. In fact, it is the start of the execution of whatever we have learned in this conference. We all have learned the newer technique which are going to find a place in our practice, and and going to help our patients. So thank you very much all, and see you in the annual conference at Gurugram. Thank you.
I'll just take 2 minutes because unless you acknowledge all the contributions, then conferences are not complete. There are 4 mentionables which I have to mention. For example, yesterday there was no light all of the day, but the transmission was uninterrupted. Everything. Our maintenance team worked overtime to keep the transmission alive and to keep the this function going. My thanks to Charanjit. He's not here. He's our head engineer, and he did all the background work, allowing the uninterrupted progression of the entire. Second mentionable is very important is Dipinder and my outreach team. He worked overtime. He is here. He deserves the applause. He has managed all the around 250 registrations which we had, both online and offline. Registration, nearly 200 registrations which we had. He has managed. If there are any complaints, I take the blame. But he has done more than his best when he has done the thing. My third acknowledgement for Sayam and Kamal Sachdeva, both of them worked overtime for this conference. I have taken the steering wheel of the conference, but they were the engine, they were the buggy, and they were doing. I think petrol was added by Professor M.P. Gupta and Kamaljeet. They did a great job, and Rishi made such a wonderful program that I think we did not change the program from day one. Maybe we added a couple of talks to adjust a few people here and there, but the entire program envisioned from the beginning by Rishi was wonderful. I think AV staff did a good job. I got some feedbacks, but I think they did a great job. Audiovisual team, and they had some bad experiences, but we had a team going since last few years. And we sort of there to re-engage for this conference. Lastly, not the least, of course, the pharma companies without participation. However, disconnected we want to be as Buddhijeevis from the pharma companies. I think they are an integral part of the medical profession. And the entire technological demonstration was not about the doctors, it was about the technology which the doctors could use, whether it was Resume, whether it was Thulium, whether it was Holmium. That was the good thing. I must acknowledge the role of Patel Hospital, which gave me a free hand in doing all these things. And then lastly, my wife, she stood by me and my tantrums through the last 10, 12 days. I was not in a good mood at my house because, all these things, they cause attention when big wigs are coming, like Dr. Rajesh, so Dr. Henry. Now you want to put your best foot forward, and we really, I lost my balance a couple of times at my house. She's not here, but I'm sure someone will convey that I have thanked her in person. Thank you very much for coming all this way. Thank you.